were HBV and 15% were non-B, non-CCLD cases. So the trend that was evident in the past 10 years, in the past decade, was that HCV remained the most common cause of HCC in our population. But in the recent years, it has been slightly on the declining trend. Hepatitis B has also been declining, but very slightly. However, non-B, non-CCLD seems to be on the upwards trend in the recent years. This is a year-wise depiction of the picture of HCC cases. So in conclusion, this study displays the trends in the presentation of HCC over the past decade. The interesting finding was the significant increase in number of non-B, non-C cases from an 8% in the first group to a 15.7%, almost a double in the recent years. Due to the rapidly accelerating prevalence of alcoholic and metabolic liver diseases, cirrhosis secondary to these are leading to HCC are growing. It is imperative to work on the relevant risk factors if we aim to halt the overall incidence and progression of the disease. The limitations of the study were that further analysis of the causes of non-B, non-CCLD group was not done, and more comprehensive analysis of the clinical records and presentation of these patients could have been conducted. That would have been further valuable to the study. Thank you.
Question and answer from audience.
So most of these patients with BC negative cirrhosis will be having MASH-related cirrhosis. So you didn't study the other possible causes of liver disease in this group?
So we are planning to do that now because it was a significant increase. This was a very basic initial study that just showed us that the viral hepatitis-related CLD associated with HCC is the same, but non-viral cause is also increasing. It has doubled over the past decade. So we are planning to do further subgroup analysis of that as well.
And a comment just to make a group of viral hepatitis versus non-viral hepatitis, that would rather than using non-B, non-C.
Okay, sir.
And you might get the trend which we picked up with the data. You might get better results.
Thank you, sir. We'll do that. Thank you.
Thank you, Dr. Ayman, for such a wonderful talk. Now my last presenter, Mr. Abdul Hai. He is a PGR in SIUT. He will talk on non-invasive predictors of hepatorenal syndrome and DCLD. Dr. Abdul Hai.
Assalamu alaikum everyone. I am Dr. Abdul Hai, resident trainee of GI, SIUT. So the topic of my presentation is predictors of hepatorenal syndrome in patients with chronic liver disease. As we all know that acute kidney injury is the most common complication in the patients with decompensated liver cirrhosis, most common cause being dehydration and volume depletion. AKI in cirrhotic patients is associated with high morbidity and mortality. The estimated median survival is less than 50% in 3 months. Hepatorenal syndrome is a form of acute kidney injury occurring in the patients with decompensated liver cirrhosis. The pathophysiology is multifactorial, attributed to an uncompensated hyperdynamic circulatory system, renal vasoconstriction, and systemic inflammation. Early diagnosis, treatment, and timely management is most important and better prognosis in this group of patients. So our aim of the study to identify non-invasive predictors of hepatorenal syndrome in patients with decompensated chronic liver disease. So the study design is a retrospective study. We included all the DCLD patients from June 2018 to the December 2021, and we excluded all the patients who were having AKI, obstructive uropathy, patients who were on nephrotoxic drugs, intrinsic kidney disease, renal vascular abnormalities, and HCC. So data was entered and analyzed using the SPSS version 22, and results were presented as a mean standard deviation. Continuous variables were analyzed using the student t-test, and categorical variables were analyzed using the chi-square test. Statistically significant variables on univariate analysis subsequently underwent multivariate logistic regression analysis to identify independent predictors of HRS in DCLD. A p-value of less than 0.05 was considered statistically significant. So out of 249, 199 patients were included and 50 were excluded. Out of 50, 11 patients' data was missing and 39 were excluded according to our exclusion criteria. Out of 199, most of them were males, 124. Most common cause was hepatitis C virus, followed by hepatitis B. And 65 patients was diagnosed as SBP, and 78 patients were diagnosed as HRS. On univariant analysis, the variable showing age more than 40, hemoglobin less than 10, TLC count more than 11, urea more than 30, and the presence of SBP, ascites, encephalopathy, CTP score more than 13, and non-kidney organ failure were significantly associated with the HRS. And on multivariant logistic regression analysis, age greater than 40, hemoglobin less than 10, TLC count more than 11, urea more than 30, and CTP score more than 13 was strongly associated with HRS. So the conclusion is these strong predictors of hepatorenal syndrome can help in prevention, early diagnosis, and prompt treatment of the patients with decompensated chronic liver disease with or without dearranged renal functions, thus improving the overall survival of DCLD.
Hi, just a question here.
Yes, sir.
What specific criteria you use to categorize these patients as HRS?
So
Which criteria to label these patients HRS was used?
including criteria.
Diagnostic criteria to label them HRS.
Sir, we included all the patients who were having known case of DCLD, and we give them fluid challenge and all the parameters we checked, like creatinine more than 1.5, and they were not responding to the albumin and fluid challenge, so we diagnosed them.
Are you giving all
And you
patients
didn't-
200 ml normal human albumin for all patients with DRNG?
Yes, sir. They were having
The
ascites.
ascites club criteria says for 48
Those
hours.
who were having ascites, we give them.
No ascites and deranged LFTs or RFTs.
So the voice, I can't hear you, please, sorry.
EASL's HRS criteria, which is that AKI when the FeNA is less than 0.2% and the absence of the nephrotoxic drugs. So we all excluded all those, and the rise in the creatinine of greater than 0.3 milligram per deciliter in 48 hours, or doubling of the creatinine, that criteria was used.
And did you exclude intrinsic disease renal disease in such cases?
Sorry?
Did you exclude intrinsic, because he didn't mention about the excluding intrinsic disease?
We excluded all the patients who are having either intrinsic renal injury, nephrotoxic, taking nephrotoxic drugs and all this.
And how many of them had underlying SBP?
How many of them had SVP? Yeah.
Yes, sir, I already mentioned.
Sir, we saw that most of our patients had SVP.
Okay.
They were having concomitant disease. Thank you.
So one of the parameter was the hemoglobin. So how do you explain that? How is that related to the prognosis and outcome?
Decreased hemoglobin. I think because of the splanchnic vasodilation, dilution, and then it causing the false reading of decreased hemoglobin, and then decreased renal perfusion, and then it can cause it's a positive cascade basically.
My question, that comment rather, that being a retrospective study, you can use a word risk factor rather than predictors.
Okay, sir.
Just a final question before once we finish. You have said that the non-invasive predictors of HRS can lead to overall betterment as far as the prognosis is concerned. That was one of your conclusions. How can it specifically improve outcomes in those patients who are awaiting liver transplantation? Have you got any recent actually published studies regarding that? Especially because since you are working in an institution, which is actually a lot of patients come. So have you got any idea about how such predictors can improve patients who are awaiting liver transplantation?
Sir, actually we are trying our best to early diagnosis and early treatment of such kind of patients, and then we will evaluate for liver transplant.
Okay. Thank you, everyone. Before for my conclusion, I will request the respectable jury and chairperson to comment and remark about these presentations and presenters. Dr. Zishan Ali.
Probably we got the message from Chair Scientific Committee that we are going to not specifically mark individual, and we are going to give all, because he was pre-selected of all those 32 abstracts submitted. So Aliyada, can you announce that?
It was a nice session. I had the opportunity to go through all the abstracts submitted. So the whole idea of this session is to encourage residents and young consultants to come up with good novel ideas and present their papers. This is something that makes the worth of your institution and as a country for us. It's direly needed that we start looking into the avenues which can be researched, which can be worked on, to come up with the ideas which can improve the management, overall management of the patient. So the request is to please come
up. I will say the same. The idea of this whole exercise is to encourage our younger colleagues to work more in research, come up with new ideas that will ultimately help our patients and improve our patient care. Thank you.
Thank you. And now I will request Dr. Ali Hadar Bloch for the prize money distribution announcement.
Thank you so much, Dr. Yasir. It was very difficult to have all sessions in 1.5 day annual meeting. Despite that, Pakistan Society of Hepatology has arranged, taken time, and all you have given us opportunity to share the research work of our postgraduates or of our institutes. So Pakistan Society of Hepatology is pleased, allocated have an adequate cash prize to the presenters at the annual meeting, annual dinner tonight. Thank you.
Before final group photo, I would definitely want to thank all the audience, especially who are present in the room and also linked through Zoom. And definitely in the past 1 hour, we have learned a lot. For final group photo, kindly come on the stage.
Six presenters, please come here for a quick group photo. May I request इनके अगर mentors present हैं, एक सेकंड रुक जाएं. नासिर, आपकी presentation थी लोगों की, आप इधर आएं. शाहिद तो इधर already हैं. और किसके अपने उस्तादों को बुलाओ भी. किधर हैं आप लोगों के उस्ताद? किसी का उस्ताद मौजूद है यहाँ पे? सारे नासिर की लगते हैं. केस चक्कर क्या यार, तुम किधर छापते हो सारे? तुम लोग भी आओ ना यार. एक सेकंड, आप दोनों एक सेकंड आप दोनों आए. और चौधरी साहब किधर हैं? प्रेसिडेंट PSH सॉरी, कोई नहीं आए. एक सेकंड, असद भी आ रहे हैं, एक सेकंड यार, हमारे वीआईपी तो रह गए. थैंक यू वेरी मच. अच्छा, अगर लास्ट मोमेंट पे हमने एक छोटा सा आइटम ऐड किया था आप लोगों के लिए, हमारा ख्याल था कि आप लोग शायद सुबह नहीं आओगे तो टू मेक इट मोर अट्रैक्टिव, लेकिन आप लोग तो आ गए. क्विकली मैं ये आपसे कहूँगा कि क्योंकि यहाँ पे बहुत सारे CPSP के एग्जामिनर्स मौजूद हैं, तो वी थॉट वील हैव अ वेरी क्विक डिस्कशन ऑन द एग्ज़ाम टेकिंग पे. इनफॉर्मल होगी, कोई प्रेजेंटेशन नहीं है. कितने लोगों ने नाश्ता किया हुआ है सुबह का? कितने लोगों ने नहीं किया हुआ? गुड. हलवा पूरी तैयार है. इट विल बी गिवन टू यू इन 10 मिनट्स. तो प्लीज बैठ जाएं 2 मिनट के लिए. लेट्स हैव अ क्विक डिस्कशन ऑन दिस. मैं रिक्वेस्ट डॉक्टर बद्र फयाज जुबैरी, डॉक्टर अल्ताफ आलम, डॉक्टर जिब्रान एंड डॉक्टर आसिफ गोल्ड टू प्लीज कम ऑन टू द स्टेज और इनके कुछ क्वेश्चंस आंसर कर दें प्लीज. सो बेसिकली हम आपके माइक दे दें, इनको बच्चों को माइक दे दें. प्लीज निशान सेटल हो जाएं, प्लीज सेटल हो जाएं सो वी कैन गेट दिस स्टार्टेड. सो मैं आपसे ये रिक्वेस्ट करूंगा कि बजाय कि हम चेयर्स को कोई कुछ बोलें, why don't we have one of the PGs start the discussion by asking them a question. Who wants to ask a question about the FCPS exam? Nobody wants to ask. डरो नहीं, एग्जामिनर तुम्हें कुछ नहीं कहेंगे. Who wants to ask a question about the FCPS exam? सारे पास हैं ये? ट्रेनीज नहीं है सारे? कौन नहीं है? कौन ट्रेनी है भाई? कोई ट्रेनी नहीं है. जी, गो अहेड. इनमें झिझक वाली कोई बात नहीं. दीज आर माय फेवरेट एग्जामिनर्स. कुछ नहीं कहेंगे आपको. चलें, माइक में बोलो. माइक दो भाई. चल भाई, जी बोलें, आप ट्राई करो.
Hello, I'm Dr. Shamim Nazir from Ziauddin Hospital. My question is regarding the BCQs. I think sometimes we get confused regarding the key, the answer. Sometimes I think there is a variation in the answer in the different books when we consult. So I think there should be there must be a comprehensive BCQs available for the trainees to, I think it should be easy for us to go through all these BCQs before the exam, if key is available.
Jibran, do you want to take the question?
First of all, thanks a lot for your question. FCPS exam, it's very competitive and it's about survival of the fittest. Yes, we agree that the key should be available, but there are always past papers which are already being created by a number of the passing candidates. So I think collaborating with them would be a better idea, because at the end of the day, it's the application of theory into practice. And all of your domains, the cognitive, psychomotor and affective domain counts. So go through the scenario, answer it to the best of your ability, and yes, you should consult those candidates who have already passed the exam. That is very, very important, because they give you new ideas, and who have passed the exam recently. That's important.
Well, you see that providing key to the examination is not possible. It defies the whole concept of examination. But if you understand how this paper is set, the questions are made and submitted to the MCQ bank by the fellows. And then there is a committee that reviews those questions. And then those questions are rechecked by a second committee. And then they are included into the MCQ bank. Once they are in the bank, they are available for examiners, for paper setters. Before every exam, paper setting exercise is done a few days before the exam, where the panel of examiners, more than 3, pick out the questions, and the questions are then, they check their keys, they check their relevance, they check their spelling mistakes, and then they okay those the papers with them. So more than 2 papers are set, and which one will come out, it's nobody knows. Which of those questions which will be printed in the final paper, nobody knows. After the exam, the exercise doesn't end with the examination. After the exam, the questions are re-evaluated, and then they are analyzed that which of these questions had a discriminatory index. And what is the discriminatory index? It is if a question is answered by all the persons, 100%, it has a 0 discriminatory index. And if the question is answered wrong by all the questions, by all the candidates, it again has a 0 discriminatory. So we need questions which can discriminate a good candidate from a poor candidate, right? So 100% correct answers, if question again is too easy, shouldn't be in exam. And sometimes, not always, the different...
Sorry, go ahead.
The MRCP people, they eliminate these 2 from the result. I don't know about the policy of CPSB because that's a secret, they don't tell us. But MRCP people, they exclude 100% right answers and 100% wrong answer questions for marking of the candidates. Right? So this is somewhat being followed in CPSP also, but to what extent I don't know. And those questions which are 100% yes or no are excluded from from future examination, from the pool. They are excluded. Okay, they are not good questions.
Thank you, brother. एक जो चैलेंज आता है हम लोगों को, हमने क्वेश्चन गो अहेड आ जाएं द माइक. जो एज एन एग्जामिनर हमें क्वेश्चन की प्रॉब्लम आ रही है कि आप लोगों का हाफजा बहुत अच्छा है, आप लोग क्वेश्चन याद कर लेते हो और जाके लोगों को बाकियों को दे देते हो, विद द रिजल्ट कि वो पूल ऑफ क्वेश्चन खत्म हो जाता है. सो एवरी टाइम दे हैव टू रीइन्वेंट द क्वेश्चन, एंड दिस बिग चैलेंज. वन मोर क्वेश्चन एंड देन कमेंट्स फ्रॉम द चेयर्स, वरना नाश्ता लेट हो जाएगा. जी बताएं प्लीज.
Hello, Assalamu alaikum, sir. First of all, thank you for arranging this session. And I don't have questions, I have just comments to make.
Please, go
because
ahead.
I've recently given this exam. It's about all 3 parts of our exam. First of all, our theory exam, I found it much, much better than my part 1 and IMM exam. Exams written should test our intelligence, not our ratta.
Yeah.
There were a few questions that would ask ACLF grade C ki mortality kitne percent hai.
Yeah.
I don't think those kind of questions should be kept in part 2 exams because इतना सब कुछ होता है पढ़ने के लिए, ये numbers के रट्टे की क्या ज़रूरत है. That was about theory. Talks में it was a very good exam. Examiners were very good, but there were a few examiners that would go on to ask about your supervisor and your institute, which I found slightly unethical.
Agreed.
And it was also, very pressurizing because I'm representing my institute and I don't want to leave a bad name to it.
Yeah.
And third, in clinical exam, this is coming from a candidate who's passed in her 3rd attempt. I think it is very, very, very important that we get some kind of feedback where we are lacking. I understand that you are seeing a lot of candidates and it's not very easy for you to do it, but a simple line that tells me I'm bad at palpation or I'm bad at history would help me. Because every time I was left at stage 0, कि मैं अब यहाँ से कहाँ जाऊँ? Where am I lacking? Why did I fail? Which part was missing? So I think it's really important for all the candidates to know where they are lacking, where they should be putting more attention on so that they are able to pass in the next exam.
I think
Thank you.
Excellent comments. और time नहीं हमारे पास, वरना this discussion can go on एंड आई थिंक ये बिल्कुल अपने कहते हैं ना वो डेप्थ ऑफ द हार्ट से बोल रही थी. आई थिंक वी आर वेरी एज अ नेशन हमको अनफेयर एग्जामिनर्स हैं. हम चाहते हैं कि हम वो पता करें जो इसको नहीं आता, और भाई जो बाकी 99% आता है वो तो पूछ लो. So the culture is changing, and I think one of the leading individuals in that has been Dr. Altaf Alam. I think puri outlook Dr. Altaf Alam ki towards the exam and examinee was different. So I really appreciate हमने बहुत सीखा. So I would take the chair's comments and then we'll go to breakfast. जी अल्ताफ आप शुरू करें please.
I've been an examiner for a long time. Haven't taken the exam recently, but yes, some ethical practices on the part of the examiners, like you mentioned, is also very important. And we don't need to go into the details of the exam, of the candidate's background. We just need to judge them on their performance on that particular day. And you are absolutely right. In UK, they have a very formal session on feedback if requested. And you have to pay a nominal fee for that, so that, you know, somebody has to travel, the examiner has to travel to some place to do that. So there is a nominal fee for that, but they have a very structured, formal feedback if requested. So yes, I agree that that is also very important. So we all need to improve. We need to improve as examiners, and I feel that we need to coach the examiners as well from time to time and tell them how to go about the exam, and also formally arrange a feedback session for those candidates who have not passed, and it should be a formal one. They should have access to all the, you know, the mark sheet and everything that you have performed in the examination, and we should be able to give you a feedback. Thank you very much.
Thank you अल्ताफ. और मैं ये रिक्वेस्ट करूँगा, ये इतना हॉट टॉपिक है कि मे बी आई विल रिक्वेस्ट अली हैदर एंड डॉक्टर दाऊद कि मे बी अगर कल सुबह हम अर्ली मीटिंग से पहले मिल लें फॉर 30 minutes टू डिस्कस दिस इज अ वेरी हॉट इशू. अच्छा, टाइम नहीं है, मैं सिर्फ डॉक्टर आसिफ गुल से रिक्वेस्ट करूंगा प्लीज फाइनल कमेंट्स. आप जिब्रान और बदर बोल चुके हैं, सो वी कैन हेड आउट टू द ब्रेकफास्ट. जी
थैंक यू वेरी मच सर. Comment from my side is I endorse Professor Altaf Alam to make examiners also standardized. ऐसा ज़रूर होना चाहिए कि जो कुछ पूछने वाले हों उनके पास भी स्टैंडर्डाइजेशन हो. और डेफिनेटली फीडबैक हर चीज़ की एक बैक स्ट्रेंथ होती है, और हमें जो एक स्टैंडर्डाइज फीडबैक है वो बहुत ज़रूरी है अपने एग्ज़ाम्स को बेहतर करने के लिए. और मेरा लास्ट कमेंट ये है कि अगर आप ऑर्गेनाइज़र्स अगर इस तरह का सेशन रखें तो उसमें CPSP का कोई स्टेक होल्डर ज़रूर होना चाहिए.
एक्चुअली आई एम ऑल्सो ऑन द फैकल्टी ऑफ CPSP. आमना सुभान भट्ट ने आना था, आई थिंक शी इज मिसिंग इन एक्शन राइट नाउ, बट वी विल डेफिनेटली गेट इट. अच्छा जी, थैंक यू वेरी मच एवरीवन. सॉरी इट्स अ ब्रीफ सेशन. अच्छा, मेरी रिक्वेस्ट आप सबसे ये होगी कि ब्रेकफास्ट इज सर्व्ड इन द हॉल ऑपोजिट टू हियर. आप प्लीज नाश्ता करें, बट वी विल ट्राई एंड स्टार्ट द सेशन एट 9:05 हियर. सो प्लीज सब लोग वापस आएँ. It's a long day, it's a very interesting day. Thank you very much. So please head out to the breakfast.
Hello, hello, check one. Hello, hello, check one. Hello, 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 check one. Hello, hello, check one. Hello, hello, check one. Hello, check one. Hello, hello, check one. Hello, hello.
Hello, 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 mic check. Hello.
Hello. Hello.
Bismillah ar-Rahman Rahim. On behalf of Pakistan Society of Hepatology, I, Dr. Ali Haider, Chair Scientific Committee, warmly welcome you all esteemed faculty in this 24th annual PSH meeting. We have completed a session of oral presentation of research. Now we are going to our next session, and mic is handed over to moderator.
Assalamu alaikum and good morning everyone. I am Dr. Gulmina Kasi, working as Assistant Professor at Jam Ghulam Qadir Hospital. I offer greetings to all of you at Pakistan Society of Hepatology and warmly welcome our esteemed guests. Thank you for joining us today. We are excited to have such a distinguished group of audience and speakers. We encourage you to connect with one another and let's make this memorable experience together. We will start our session by calling our reputable chairpersons. Our first chairperson is Professor Dr. Anwar Ahmad Khan. He is consultant gastroenterologist and hepatologist at Doctor Hospital Lahore and Beria Orchard Hospital, where he runs a fellowship program under CPSP. Please, sir, join us. It's my privilege to introduce our next chairperson, Professor Dr. Sharbat Khan. He is professor, retired, and head of department, gastroenterology department, Bolan Medical Complex Hospital. He had made significant contribution in our field and will lead our discussion today. Thank you, sir. With esteemed credentials, it's my pleasure to introduce our next chairperson, Professor Dr. Ghayasun Nabi Tayyab, sir. He is working as Professor of Medicine and Consultant Gastroenterology Department. Please, sir, we will skillfully navigate our discussion. Our third chairperson, I have the honor to introduce Dr. Amna Subhan. We are waiting for her, she is coming. She is consultant, ma'am. She is consultant gastroenterology at Aga Khan University, Karachi, and program director of PG, and also she is a vice president of PSLD. A highly respected figure in the field of gastroenterology who will chair our session with wisdom and insight. Thank you, ma'am. Next up, we have our first speaker, Dr. Marukh Ali Bukti. She is consultant gastroenterologist at Sheikh Khalid bin Zayed Hospital. She is a young, brilliant gem and rising star in the gastroenterology field. Please welcome her, and our topic of presentation is hepatitis A and D, burden and management.
Assalamu alaikum everyone, I'm Dr. Marukh. Thank you, Dr. Gulmina, for the kind introduction. I'm really grateful for this opportunity today. I'm going to present about acute hepatitis A and E, the burden and management strategies. So globally, the World Health Organization estimates that around 1.5 million cases of HAV per year, and they have seen that more than 7,000 cases have been reported in 2016 because of hepatitis A virus infection. So this is the map that has been taken from the CDC Health Information for International Travelers in 2014. It shows the prevalence of hepatitis A around the globe, and we can see that these are the areas where this infection is highly prevalent, which are the areas of Africa and Asia, and we can see that we are right there in the high prevalent areas. Apart from that, this South America, Eastern Europe, parts of Asia, Africa, and Central America has the intermediate prevalence of hepatitis A virus infection. So this is the map which shows the MP. MP is basically the age at midpoint of population immunity. It is the age at which half of the birth cohort has the serological evidence of the prior exposure to hepatitis A. So as you can see in the map that Africa and part of the Asia and the subcontinent area, the MP is less than 5 years of age. So the lesser the MP, the higher the endemicity in that area. And the higher the MP, the lesser the endemicity in those areas. So we are highly endemic in the concern for hepatitis A virus infection. So these are the number of the reported cases that the CDC viral hepatitis surveillance of US has shown. There is a marked increase in the number of reported infections from 2014 to 2019, and the estimated infections have also increased in these years. But they have reported that the number of infections, there is a decline in the reported cases since 2020. That is because of COVID-19 and the destruction of the surveillance system because of COVID-19. However, we can see that even in the US, the number of cases are in the rise from 2015 to 2019 and 2020. So the age group which presented mostly with the infection was majorly between 30 to 39 years of age. So the previous concept that it is a pediatric population infection is now have changed because mostly adult patients are presenting with this infection as well. So regarding hepatitis E virus, every year there is an estimated 20 million HEV infections worldwide, leading to an estimated 3.3 million symptomatic cases of hepatitis E. So the World Health Organization estimates that hepatitis E has caused more than 40,000 deaths in 2015, which makes up about 3.3% of the mortality due to viral hepatitis. So this is the map which shows the endemic areas for hepatitis E. Again, it's quite similar for the A and E, that the areas of Africa and Asia are the topmost ones where the hepatitis E virus is highly prevalent. But this intermediate prevalence is also seen in America and Europe as well, because the genotype 3 and 4, which is caused by undercooked meat, this infection is more common in those areas. However, genotype 1 and 2 are more prevalent in our part of the world. So there was a mini review conducted from all the studies in the Pakistan from 1985 to 2009. There was a mini review of those studies, and which was published in 2016. The summary of the review shows that hepatitis A virus accounts 50 to 60% of the cases of acute viral hepatitis in the pediatric population of Pakistan, and up to 100% of the children tested positive for HIV IgG by 14 years of age. 4.4 to 6% of adults have been found to have acute hepatitis due to HIV. Regarding HEV, the review says that a total of 14 to 26% of apparently healthy pediatric population were found to be exposed to hepatitis E, that is, they were HIV IgG reactive. Up to 20 to 22% of adults and 2.4% of children were found to have acute hepatitis due to hepatitis E virus. And the maternal mortality rates were ranging from 20 to 29.3%, with a perinatal mortality rate of up to 30.3 per 1,000 live births. So the basic symptomatology is, as we know, is reduced appetite, weakness, arthralgias, digestive disorders like diarrhea, pain in the upper right quadrant, nausea, vomiting, followed by jaundice, dark urine, and pale poop. Excuse me. Regarding the investigations, there are antibody testing for hepatitis A virus, which includes IgM and IgG. IgM is mostly done in symptomatic patients, which shows the acute infection. Antigen detection has also been done through PCR method and nucleic acid hybridization assays. And of course, liver enzymes are always done in a patient with symptomatic hepatitis infection to check the disease severity. This is the typical serological course of HIV infection and recovery. As you can see, at the onset of clinical illness, there is a rise in the anti-HIV IgM levels. These levels peak around 1 month, and then there is a decline in these levels. This is followed by IgG levels, but they will remain for the lifetime, and it will provide a long-term immunity in case of hepatitis A. This is for hepatitis E virus. It has a similar trend in case of the antibodies. At the start of the illness, the IgM levels are raised, and then IgG follows it. But with the passage of time, both the antibodies touch the baseline. So these are the panel of tests that can be used to differentiate acute from chronic. In acute infection, HIV RNA is usually positive with anti-HIV IgM, and IgG is done in cases where there is a case of reinfection, because IgM is usually not present in case of reinfection. HIV antigen can also be done. All these three testing can be done. So regarding the chronic infection, if the HIV RNA persists for more than 3 months, this is considered to be a chronic infection. HIV antigen can also be present. If there is an anti-HIV IgG, it could be possibly because of a past infection. So as we know that hepatitis A and E both are usually self-limiting infections, and what we need to do is a little bit of supportive treatment in those cases, which includes nutritional support, hydration, the use of antiemetics if there is a case of vomiting, use of antibiotics to relieve fever, and attention must be paid to the use of paracetamol to avoid further liver damage and further liver toxicity. So the mainstay of management in hepatitis A and E both is the prevention of infection, which includes use of boiled water, purified water for cooking and cleaning the vegetables, washing the hands frequently, and in areas where the zoonotic infection for E is common, avoid eating raw meat. So in case of hepatitis A, we do have vaccines available. The high-risk population that requires vaccination is the patients with HIV, MSM, drug users, both injectable and oral, homeless people, pregnant women with a risk of severe hepatitis A, people with an increased risk of exposure, patients with chronic liver disease, international travelers, close personal contact with international adoptees, and children aged more than 12 months to 23 months, and older children who have not received the vaccine yet should be vaccinated. These are the vaccines that are available for hepatitis A. These are single antigen vaccines with the name of Havrix and Vecta. 2 formulations for both have been licensed. One is for 1 to 18 years, and one is for more than 19 years. The Havrix for 1 to 18 years, 720 ELISA units are present in the vaccine, while for more than 19, 1440 ELISA units are present. Similarly, for the Vecta for 1 to 18 years, 25 units, and for more than 19, it is 50. The second dose is usually given for both the vaccines 6 to 12 months after the first dose. There's also a vaccine which is a combined vaccine for hepatitis A and hepatitis B, which includes the HAV and hepatitis B surface antigen. It is recommended for more than 18 years. There's a standard dose and an accelerated dose. It constitutes of 720 ELISA units of HAV and 20 microgram of B surface antigen. The standard dose, as we know, is the second dose is given 1 month after the first, and the third dose is 6 months after the first. While the accelerated dose is, the second dose is given 7 days after the first dose, and the third dose is given between 21 and 30. And usually booster is needed 12 months after the first dose. So there are investigational drugs that have been investigated for the treatment of hepatitis A virus, but currently none of these are licensed for hepatitis A treatment. So these are a list of medications that have been studied in various studies for the treatment of acute hepatitis A infection. N-acetylcysteine has found to be ineffective. Interferon alpha has shown in vitro inhibition of viral replication. Sofosbuvir again has shown in vitro HIV RNA decrease. Corticosteroids have shown survival improvement in children with fulminant hepatitis with a reduction in the risk of prolonged cholestasis. AZD1480, zinc chloride, and a drug which upregulates heme oxygenase. All of these have been studied to show in vitro reduction in viral replication, but none of these have been licensed so far. So in case of HIV-related acute liver failure, it has seen that in all the patients with acute liver failure due to hepatitis A virus infection, 1/3 of patients may require a transplant. Studies have shown that the transplant in HIV infection has a lower survival rate as compared to hepatitis B virus at 1 year, which is 69% versus 88% respectively. So for hepatitis E, unfortunately, there is no FDA-approved vaccine or immunoglobulin which is available to prevent HIV infection. However, there is a Chinese vaccine with the name of HEV239 vaccine, which was approved in China in 2011, and it is also available in Pakistan as well. Chinese phase 3 clinical trial was conducted in which more than 100,000 healthy subjects demonstrated an efficacy higher than 99%. So it is available in Pakistan as well. So the recommended doses of this vaccine are 3 intramuscular doses of 0.5 ml, each given at 0, 1, and 6 months. The people require the vaccine are at high risk of the infection, which is age 16 and above, which includes people who are handling the animals, food handlers of the students, members of armed forces, pregnant women, and visitors to the endemic area. As in pregnancy, the mortality is quite high if a patient who is pregnant and has an infection with hepatitis E virus. So in a study, this vaccine has shown that there is a strong antibody response, and it has shown to be protective for more than 10 years. So in case of HIV-related acute liver failure, a small proportion of patients might present with acute liver failure, and that group includes the pregnant women and underlying liver disease being the highest risk. So in areas endemic to HIV, infection in a pregnant HIV-1 infection in a pregnant person can progress to liver failure and death. So the benefit of ribavirin in patients with severe acute hepatitis E and those with HIV-associated liver failure is still uncertain. Just a few words for chronic hepatitis E. So it is defined by the persistence of HIV replication at 3 months after infection, mostly caused by genotype 3 and 4. It is basically thought that it is associated with the diminished HIV-specific CD8 T cell responses. So in chronic HIV, the detection of HEV RNA either in serum or stool of the patient for minimum of 3 to 6 months time duration is the reference test for the confirmatory diagnosis. The cases which are more prone for the chronicity of the infection are the people who have solid organ transplant, patients with stem cell transplant, and people who have HIV, concomitant HIV infection. So this algorithm shows the treatment plan for the chronic HIV infection. So the first plan is reduction of immunosuppression, and it shows HEV clearance. If it doesn't show HEV clearance, then there is 3-month course for ribavirin monotherapy. So if the patient responds to the therapy, but there is a relapse after the therapy, that is the presence of HEV RNA in stool and blood, then the ribavirin can be continued for 3 more months. But still, if there is persistent HEV replication, and for the cases where there is no response to ribavirin, pegylated interferon for 3 months in the liver transplant patients have been given, but there is no alternate available for other solid organ transplant patients. So these are the studies that, these are the drugs that have been studied. Ribavirin, as I mentioned, is recommended for chronic hepatitis infection treatment. PEG interferons are given only if the patient doesn't respond to ribavirin or they have a relapse. Only for the patients who have been transplanted for liver, and cephospover has not shown any improvement in cases of chronic HIV infection. These are my references. Thank you.
Thank you, Dr. Maru, for delivering informative presentation, and we appreciate your time and efforts. Our next honorable speaker, Professor Aqib Dilshad. He is a professor gastroenterologist at Amiruddin Medical College, General Hospital, Lahore. He will wrap up our discussion with his insight on direct-acting antivirals' impact on cirrhotic patient with or without hepatocellular carcinoma. Please welcome.
Bismillah ar-Rahman ar-Rahim. My name is Dr. Aqib. I'm currently working at Lahore General Hospital. Today's talk is directly acting antivirals' impact on cirrhotic patients with and without HCC. So I have no disclosure to make. This is the overview of my talk. We'll talk about cirrhosis, compensated and decompensated, and cirrhosis with HCC, patients who are potentially curative candidates, and then candidates for liver transplant and advanced HCC with cirrhosis. So first thing first, DAs in cirrhosis. With the advent of pan-genotypic drugs, the EASL has recommended that in those areas where genotype could not be done or it increases the cost, one may treat with pan-genotypic drugs, and the combination available are fosfovir velpatasvir or glycepravir pebrentasvir for 12 weeks duration. However, if we have the information of genotype or subtypes available with us, that increases our armamentarium of treatment. For patients with genotype 1, 2, 4, 5, and 6, one may treat, in addition to the standards of velpatasvir and GP, we can treat with grazopavir albasvir for genotype 1B patients, and for genotype 3 patients, in addition to cephospover and velpatasvir, one need to give weight-based ribavirin, and the duration of therapy is 12 weeks. The other option is soft Velvox. However, it is important to note that the genotype that we are facing in our region is predominantly genotype 3. So the recommendation is that if you want to treat cirrhotic patients with genotype 3, and even if you don't have the genotype, you treat them with soft velpatasvir plus the ribavirin for 12 weeks therapy rather than the soft velpatasvir. So what is the impact of this treatment? We all know that the SVR rates in the range of 90 to 95%. And what is the impact of that SVR? It was reflected in this study that was carried out in Taiwan, in which more than 200 patients were taken, and the indices of fibrosis in non-invasive and invasive indices were compared before and after therapy. The patients' pre and FIB-4 score were calculated before the treatment and at week 4, 8, 12, and 3 months after treatment. Similarly, paired liver biopsy for patients who consented for it was taken before the start of therapy and then 6 months after the therapy. And the result showed, here you can see that with the FIB-4 score, mean FIB-4 score before the treatment started was in the range of more than 4.5, which with a sharp decline in FIB-4 score at week 4. And you can see that FIB-4 score decreased from 4.78 to 3.66 in 12 weeks time. Similarly, when we see the APRI score, it was more than 1.6 mean before the start of treatment, and with a decline, sharp decline of up to the 0.6 level, and we see that the APRI score decreased from 1.6 to 0.82 in 12 weeks time. When we see the biopsies, here only 21 patients consented for paired biopsy, and you see that before the study, before the start of treatment, 21 patients, 19 were in F3 and 2 were in F4 group. So all were in advanced stage fibrosis, and post-treatment biopsy showed improvement in histology in terms that 10 patients were noted in F2 group and 1 in F1 and F0. So there is significant improvement in fibrosis. Similarly, the histological activity index also showed improvement from 6.9 to 5%. So in summary, we can see that if we see the impact on compensated cirrhotic patients, the pie chart A showed that there is significant regression in FIB-4 score that is noted in 74% of the patients. Similarly, in pie chart B, we can see the improvement with reference to the fibrosis, and it was noted in 61% of the patients. And in pie chart C, you can see the improvement in histological activity index that was noted in 71% of the patients. Now we talk about the decompensated cirrhotics. The treatment option available for decompensated cirrhotics are sofosbuvir, velpatasvir, and weight-based ribavirin for 12 weeks therapy. The start dose recommended is 600 milligram, and you titrate upwards subject to the tolerability of the patient. If patient is intolerant to ribavirin or there is contraindication to ribavirin, you extend the duration of therapy to 24 weeks without ribavirin, that is soft velpatasvir only. Mind you that the protease inhibitors are contraindicated in decompensated cirrhotic due to the risk of toxicity. And there is a caution that these patients should only be treated in experienced centers, and only those patients who can ensure follow-up, as there is a risk of decompensation, so patient needs to be in close monitoring. When we treat decompensated cirrhotic patient on liver transplant risk, the guideline says that if the MELD score is less than 18, you treat prior to liver transplant, and if the score is more than 18 to 20, you defer the treatment with DEAs, and you transplant first and treat afterwards. However, if the waiting time is more than 6 months, you may consider treatment upfront. So what is the impact of treatment on decompensated cirrhotics? As you know, the SVR rates is in the range of 85 to 90%, and the impact can be seen, this landmark trial called Astral 4 trial, whereby it was published in New England Journal of Medicine, whereby 3 groups were made. One group was treated with soft velpatasvir, other group was given soft velpatasvir ribavirin for 12 weeks, and the third group were given soft velpatasvir for 24 weeks. And it was concluded that the maximum SVR was achieved in groups where ribavirin was given along with sofosbuvir velpatasvir. However, CTP and MELD score was also measured before the treatment and afterwards. And it reflected there is significant improvement in child score. That is 47% of the patient showed improvement in child score, and the improvement was in the range of -1 to -3 child score. Similarly, the impact on MELD score, here I want you to concentrate on this lower segment where the baseline MELD score was more than 15. Here you can see that the improvement in MELD score was significant in 81% of the patients, and the range of improvement is from -1 to -11, which is significant. With the impact of improving child and MELD score, it was thought that those patients who were listed for transplant, they may be delisted with the treatment. So this matter was taken up in a European study. It was a retrospective study whereby the data was contributed by 11 transplant centers, and it showed there's a significant decline in MELD score in those patients who were delisted. And the author concluded that 1 out of 3 patients were inactivated, that is, was put on hold, and 1 out of 5 patients were delisted in 60 weeks' time after the treatment with DAs. So now we come to the next part of our presentation, that is DAs in cirrhosis and HCC. So those patients who got cirrhosis with HCC, the first group is compensated child age cirrhosis with HCC. If the patient group includes those patients who have the option of curative therapy in terms of liver resection and ablation, it is better to defer the treatment, do first the HCC bit, and then treat the Hep C. And those patients who are compensated cirrhotic awaiting liver transplant, there you should treat first Hep C and then the transplant maybe. Well, second group is where there is complete response to HCC treatment, then you treat as per general recommendation, and you need to follow these patients for surveillance for new HCCs. Those patients who are awaiting liver transplant with advanced liver dysfunction, their decision is made by case-to-case basis in MDM with regards to treatment of DAs. And the last group is the patient who are palliated for HCCs or advanced HCCs. Such patient may be treated depending upon their individual risk and life expectancy. If they have comorbidities, you may not treat it. If he is otherwise fit, you may treat it. So what is the impact of HCC treatment with DAs? So initial response was, reported response was unexpected high recurrence rate of HCCs in those patients who were treated with DAs. This study, which was carried out in 2016, showed that 103 patients who were cured of HCC, when they were treated with DAs, there was significantly high percentage of those developed recurrent HCC in the tunes of 27%. Similar high recurrence rates with HCC were also reported from other centers as well. that raised a question on the safety of DAAs in HCC. And as a result, large volume studies were planned and data was accumulated. And this issue, over the next 4 or 5 years, the issue resolved. And this was nicely reviewed by this paper in World Journal of Gastroenterology, which showed that a large number of patients treated with DAs in the tunes of 18,000, 2,000, and 3,000 showed that the risk of HCC is ranging from 1 to 3%, which is not high, which is normal as per the other population. So negated the question and over the safety of DAs in cirrhotic patients. This research part is also showing the safety of DAAs after liver transplant. The recurrence rate was found to be only 2.2% after a follow-up of 70 months. Then this is the part this paper is showing the concept of recurrence after the treatment. After the cured HCC, the impact of DAAs on the recurrence. And you see there are two groups, one all patients and done with cirrhosis. The blue worm is showing the group who has not been given any treatment with HCCs, and you can show that there are high percentage of patients developing HCC. When you compare them with those given interferon and those given DAAs with red line, you can show that there is significant improvement and decline in the incidence of in the recurrence of HCC. So the paper concluded that DAA therapy after curative HCC treatment can decrease HCC recurrence and all-cause mortality compared to interferon-based therapy or no antiviral therapy. This was an important issue, and this was taken up in the AGA meeting, and an expert review was also, best practice review was also published on this. The relevant part has been reproduced here, that AGA best practice advice is that for DAA treatment is associated with a reduction in the risk of HCC. Number two, the presence of HCC, there is decrease in sustained virological response. And that is why if the curative treatment is available, you first treat them and then treat them with DAAs. And the curative therapy with liver resection or ablation, you defer the DAA therapy until HCC treatment is completed. And those patients who are listed for liver transplant DAA treatment, the decision is complex and it is based on the median wait time. If the wait time is more than 6 months, you may treat them. And then the availability of hepatitis C virus positive organs. So if the positive organs are there, you may get reinfections, you may treat afterwards. But if the hepatitis C negative donors are insured, then you may treat them beforehand. And the degree of liver dysfunction, that is the MELD score, if it is more than 20, there is risk of decompensation, there is risk of deterioration, so you may treat them afterwards. And then the active, intermediate, or advanced stage HCC, the treatment decision is based on HCC tumor burden, degree of liver dysfunction, life expectancy of the patient, and patient preferences. Thank you very much. In the end, I would like to share this event that we are organizing in November. I would like to invite all of you to participate for this. Thank you very much.
Thank you, sir, for your generous talk and time. I hope this excellent presentation raised your awareness. It's my pleasure to introduce our final speaker, Professor Javed Gubal Farooqi. He is a professor of medicine, hepatologist, and gastroenterologist at Life Care Hospital Research Institute, Ayathabad, and he was a president of PSH 2017 to 7 to 2010. He will enlighten us on the update on chronic hepatitis B virus management. Let's give him a warm welcome.
Bismillah ar-Rahman ar-Rahim. Thank you, Dr. Gulmina, for the kind introduction. Thank you, Dr. Ali Haider, Chair Scientific Committee, and Dr. Daud Gilzai, Chair Organizing Committee, and Dr. Asad, President PSH, for your kind invitation. And a great job done by Lahore team for organizing this event on about 1 week notice, so great job. Greetings from Peshawar. The assignment given to me is the treatment of hepatitis B in 2024 onwards the paradigm shift. We all know the hepatitis B is a major global health problem. In a 2019 WHO report, the worldwide prevalence of hepatitis B was reported to be 3.8%, with 1.5 million new cases and mortality of 0.8 million deaths. And the pool was 296 million cases. And the issue was that 88% of this pool was residing in Africa, Southeast Asia, and Western Pacific region. But the great dilemma that only 10% of those 296 million were diagnosed and only 2% were treated. So this is the dilemma of hepatitis B. We know the plethora of guidelines. Almost every year, we see the guidelines from the at least 4 major organizations, AASLD, EASL, APASL, and WHO. And these last two guidelines in 2023 by the Chinese and 2024 by the WHO, they have really shifted the paradigm. This is for reference. I won't go into the detail of that. You must have seen this, the paradigm, the shift which is by the algorithm of the Chinese, that when the patient is found to be HBs antigen positive, look for these scenarios, and if the patient has these scenarios like liver cirrhosis, liver failure, liver transplants, patient in need of chemotherapy, then treat that patient without doing PCR. But if these scenarios are not present, then the PCR is required, and if the PCR is not detected, you do the follow-up. If it is detected, ALT is raised, you treat that patient. If the ALT is normal with positive PCR, go for these 3-4 scenarios. If these are present, you treat, otherwise you don't. The one thing which the WHO guidelines, they recommended just the qualitative PCR. No more quantitative PCR. This was just the last year. Then this year we had the guidelines by the WHO. And the WHO guidelines give us the 4 scenarios. Scenario number 1, when there is significant fibrosis, you treat that patient without doing PCR. Second, when the PCR level is more than 2000, ALT is raised, you treat that patient. Third option is when there is presence of these scenarios, you treat that patient without doing PCR. And this is very interesting. In the absence of access to HBV DNA assay, and studies are that when we do the PCR, in almost 50 to 60% of hepatitis B patients, the PCR is negative. But if there is no access and ALT persistently abnormal and no other cause can be found for this, treat that patient. So, we see a paradigm shift of 180 degrees in the light of recently published 2 international guidelines, the Chinese and the WHO. And this is in an attempt to achieve 2030 target of hepatitis elimination from the world. The WHO guidelines especially, it has broadened the indications. It wants that more and more patients should be brought for the treatment because they are the risk for spread as well as associated with its mortality and morbidity. So, the question, when to start antiviral treatment? Let's compare when I say it's a paradigm shift, What do I mean by this? We know there are three. One is that those scenarios which needs to be treated without PCR, but when the PCR is needed, or potentially it was recommended, the liver status, if a patient has got a cirrhotic liver. The previous guidelines till EASL 2017 and AASLD 2018, they needed PCR to be positive. For cirrhotic liver, PCR was required to be positive unless if it was a decompensated and the patient was undergoing liver transplant, that was another scenario. But the Chinese guidelines, they said no PCR required if the patient has got cirrhosis, is the same has been adopted by the WHO. Coming to the fibrotic liver, when the liver has got F2 and F3, the previous guidelines, they were requiring at least 2,000 international units of PCR, viral load of 2,000 with raised ALT. But the Chinese, they just want the qualitative PCR to be positive as it was required for in the previous guidelines was cirrhotic liver. And WHO does not require PCR here. This is the shift, which I am saying the paradigm shift. Coming to a non-fibrotic or normal liver, a liver with insignificant fibrosis, F0 and F1. The previous guidelines, if the viral load was more than 20,000, no, it was 20,000. For significant liver, with the previous guidelines, it was 2,000. And the ALT was more than 2 times normal, treatment was recommended. But with more than 20,000 viral load, insignificant fibrosis, ALT normal, the EASL recommended they should be treated. The apostle AASLD, WHO said no. And if the viral load was less than 20,000 with normal liver, ALT raised and normal, it may be treated when the EASL gave the 3 scenarios: age, family history, family stuff, HCC, all that. And if the PCR was negative, there was no role of ALT and treatment was not recommended by the previous guidelines. But what we see in the Chinese guidelines, they say a normal liver without significant fibrosis, when the PCR is positive and ALT is raised, just raised, treat that patient. And ALT is normal, it may be treated. These 3 or 4 scenarios. We'll go to those algorithms later on. And when the PCR was negative, no role for ALT and do not treat. Coming to the WHO, again, it's a normal liver. ALT more than 2,000. ALT is raised. Viral load more than 2,000, treat that patient. Viral load more than 2,000, ALT normal, WHO guidelines are silent here. They don't give any recommendation for this group. Viral load less than 2,000, ALT raised, may be treated. Even the 4th option was, if we don't have the PCR facility, you can treat that patient. And of course, ALT normal, don't treat. So this is the comparison of the recent 2 guidelines, 2023 and 2024, with the previous ones. But we know the guidelines, these are the tools of management, not rules of management, and you need to individualize these guidance for your patients. Let's see how we can do that, how we can use both the guidelines for our patient. If a patient is found to be HbS antigen positive, yes, we need to exclude HDV, HCV, and HIV. The WHO guidelines, EASL, they are giving these scenarios, the option 2, option 3, and this. And if my patient has got these 6 scenarios, I need to prevent the reactivation of HBV infection. If my patient is receiving chemotherapy, targeted therapy, immunotherapy, or the patient is undergoing liver transplant, or has gone under liver transplant, if there's extrahepatic manifestations, if there's co-infection with HIV, if there's family history of liver cancer and cirrhosis, if there are comorbidities, this is again the WHO is recommending, the diabetes, the MASLD, and if the liver status, if these scenarios are there, you treat that patient without doing PCR. But if these are not present, then you need to do the PCR. And coming to the PCR, I just showed you the WHO is showing viral load should be there. It is recommending quantitative PCR. Chinese just qualitative PCR. This is an old data. We all know that. The REVEAL trial. The point which I want to highlight is there's more than 2,000, there's higher risk of HCC and cirrhosis. But what about viral load less than 2,000? Even less than 60? Still there's the risk of HCC and cirrhosis. So, less viral load is not absolutely safe. There's another old study, you must have seen that, just almost 15 years old. And what they found, when just the PCR being positive, the risk of cirrhosis is 6-fold and HCC 12-fold. And when they see the viral load, of course, more than 2,000, risk was 17-fold for cirrhosis and 39-fold for HCC. But even less than 2,000, risk was still there. So, if we see if the patient's affordability and repeated testing, to me, the qualitative PCR is sufficient to start the patient on treatment. What if my patient qualitative PCR is negative? Then comes the role of ALT. My PCR patient H-base antigen was positive. No scenarios of these were present. PCR was negative. I take the help of this option 4 of the WHO, that even there is no access to PCR, and I told you studies say 50 to 60% of cases with HBS antigen positive, you do the PCR, PCR is negative. So being the optimistic, having that, it may be negative, and when it is negative, if the ALT is raised, you treat that patient. And if the ALT is normal with negative PCR, then these conditions, age more than 30, and these co-infection, again from these two guidelines, in that case, if the age is more than 30, there's co-infection of hepatitis C and D, especially during the treatment of hepatitis C or hepatitis D. I do need and I should treat that patient with the antiviral treatment. If this is not present, then this is the group which doesn't need any treatment. 6 to 12 months follow-up is required in this patient. So, by combining these two guidelines, what I see the 4-step strategy is patient H-base antigen positive, look for these 6 scenarios. If these are present, treat that patient. If these are not present, do the qualitative PCR. If that is detected, treat that patient. If that is not detected, go to step 3. If the ALT is raised, treat that patient. If the ALT is not raised, step 4 is those age and co-infection. If it is there, treat. If it doesn't there, don't treat. Another thought, another way, still always there is option 2 as well. Remaining in these guidelines, even if at times it may be that HBS positive or raised ALT, this is another, the same 4 steps, but no, this has come second and the ALT has come first. That's the reason I'm saying you need to individualize the therapy in the presence of those guidelines. I haven't been gone out of the guidelines. This is what I am suggesting we should see, because the target is the HBV elimination. So this ALT approach is just the simple one, go straight away. But of course, these two options, hybrid, and this seems to be some sorts of more burden, but of course, then how much you can treat those patients if you are deciding at the community level, but at the individual level, you can go for this option or for this option. It is a food for thought for you, but the WHO guidelines, they would definitely change the paradigm shift we see, and it was a very difficult question. We need to say whether the patient has got indication for treatment or not. Now we see if the patient has got contraindication for treatment or not, just like hepatitis C. Thank you very much for your very kind introduction. Thank you.
Thank you, sir, for such informative talk. Now moving to our next part, which is question and answer session. So any question from our audience? No question? Okay, Mike.
Recently, Professor Altaf? Yes, please. Female patient having multifocal HCC with PCR HBV DNA detected in moderate quantity. What should be done about this patient?
Your question, I think, because the echo, we have not been able to hear it very clear. Can you please repeat your question? There's an echo.
My name is Dr. Nasranja, working as consultant physician in DHQ Teaching Hospital, Sargodha. Recently, last week, a female patient having multifocal HCC with DNA detected in a moderate amount. What should we study about this patient?
Refer this to Dr. Akif, please, if you can respond.
Javed Faruqi.
Yeah.
One thing is the baseline is that what's the expected lifespan of that very patient. We treat hepatitis B or hepatitis C to ensure to reduce the morbidity and mortality. If a patient has got multifocal hepatoma and that is just needs a palliative care, then to me it's no need for embarking on the hepatitis B treatment, what we will get at the end of the day. So it depends upon, of course, this is, if the patient liver is okay and the expected survival is, you can get that. So this is, when the damage is that much, and to me personally, I won't go for the treatment. If it's a multifocal and stage and out of any therapeutic sort of treatment, then there's no role to me. There's no role for decreasing the viral load. The patient has lost the game already.
If you look at the guidelines, they recommend HCC and hepatitis B if the patient is not terminal, not expected to die within 3 months, and you are going for curative or palliative treatment, one should treat. This is the clear message from the guidelines, EASL and ASLD. So no harm, cheap medicine, oral, daily, reduce the dose if there is CKD, but according to the guidelines, HCC and HBV, unless the patient is not terminal, especially if going for palliative or curative treatment, one should treat. You could certainly treat if the patient is not terminal, and this is as per guidelines. Right. So yes, one may treat. I personally feel, in reference to hepatitis B talk by Dr. Javed Iqbal Farooqi, excellent talk, excellent suggestions, and of course WHO guidelines have come to our rescue from a public health point of view. You know, it's not academics, it is public health, that you want to eradicate HBV from many parts of the world where HBV DNA is not available. This is not the case in Pakistan. I can hardly see any region of Pakistan where HBV is not available, PCR is not available. The other thing is, qualitative and quantitative PCR of HBV is a myth, not a reality. All the FDA approved methods that do PCR check both qualitative and quantitative. And it is only seen in Pakistan that you ask for PCR and they would charge 3,000 more if they do a quantitative test. So they are doing it anyway, whether you are asking for qualitative or quantitative, because the method by Abbott and Roche both detect qualitative and quantitative and can give you that. And in my opinion, hepatitis B is a numbers game. So how would you follow up a patient who is going for chemotherapy or immunotherapy, and we are starting treatment on surface antigen alone without checking for BDNA if it is available? Of course, if it is not available, that's perfectly fine. You have no choice. But if that patient has a flare-up, despite giving HBV therapy, you would certainly need to know what is happening, and that is where the problems arise. So it's good from public health point of view, but not good from the academic point of view, that we are treating HBV. So both sides are okay, but you need to know the proper context in which we are talking about hepatitis B. As a public health problem, yes, WHO is very concerned, and it gives you an option that even if you don't have access, treat. Surface antigen positive ALT is more than normal, you have no other possible cause of liver disease, go ahead and treat. But in Pakistan, I think we should still be doing numbers rather than just relying on qualitative. If we are in Pakistan, we should always ask for quantitative test rather than a qualitative test. Because if I'm following up a patient on nukes, 3 months, 6 months down the road, I check the numbers. If the numbers are still high and we are using entecavir or tenofovir, I would know the patient is not compliant. We are not checking the drug levels, we are not checking the pill count or any other supervised form of giving therapy. So I would certainly urge my colleagues here to continue to use numbers in hepatitis B if possible, because that is not only helpful in deciding treatment, it is also helpful in monitoring the effects of the treatment. Thank you very much.
Thank you, Professor Altaf. I think Professor Gayas will like to make some comments on this.
I think excellent suggestion by Professor Altaf, but you see, one is policy, the other is academics. In the scientific world, I shall agree with whatever has been suggested by Professor Altaf Alam, but when we come to the policy side, you see, the PCR, cost of PCR, when we project it to so many people across the country, the numbers in terms of Pak rupees comes out to be huge in billions. So, talking on WHO and talking of national programs like hepatitis control program in Pakistan, There we have to do away with lots of things, and that's the reason that in 2022 we had issued a guideline on hepatitis B control, where it was not too different from what has been published by WHO in 2024. So idea was inclusive. And on the national health program side, going for quantitative PCR, adding 3,000, 5,000 extra, that means that we are depriving lots of money and diverting to the diagnostic rather than giving that money for the medicine. I agree that there's always a concern that with the available resources, with the available medicine, it can be spurious, people may not be compliant, there may be emergence of drug resistance, so many things can come up. But knowing that entecavir and tenofovir, alafenamide or tenofovir depoxylate are so effective, the chances of drug resistance have not been documented in the other parts of the world, and getting experience from them or getting information from the other places, I think from the national perspective, I shall endorse WHO opinion and I shall endorse the PSH guidelines 2021 on hepatitis B, that we should be inclusive and not exclusive, and we should be diverting our money towards the drugs, not just the diagnostics. And at the same time, although Professor Javed Iqbal Farooqi has said that TDF can be used, but from the national perspective, since TAF turns out to be cheaper on the national program, other than the people below the age of 5, from the national perspective, national program perspective, I shall suggest that TAF should be used instead of TDF for the universal availability, except for children below the age of 5, where we don't have much data.
Thank you, Professor Gyas. I think this will perhaps take a whole hour of debate here. So let me just wrap up in the interest of time. Dr. Maruf Bukti did a very nice review on hepatitis A and E, especially for hepatitis A. We always think about who should be vaccinated for hepatitis A in Pakistan, because in most of the testing which we do here, in a school-age children, 100% are already positive for hepatitis A antibody. So I think in a country like Pakistan, except in very small set of population, hepatitis A vaccination is perhaps not practical. The next talk was Professor Akif Dilshad. Very succinctly, he touched upon who should be treated, who should not be treated for DAs in the realm of HCC, whether they are positive, decompensated cirrhosis, very nicely covered. And I think unless my panelists have any comments on it, we move on to the next. Dr. Javed Iqbal Farooqi has very nicely covered all the guidelines and the debate which has generated here. With this, I ask my panelists if they have any question. I think Professor Sharbat Khan has some question or comments.
This is not a question. This is a case scenario from Dr. Farooqi. This patient came to me few days back. No? He is US return. His HBV DNA is 248 and ALT is normal. Elastography is 4 kilopascal. He was advised liver biopsy in US. He did not do that. What do you say?
The ALT more than 2 times normal. Here in this patient, it's very low and the ALT is normal, the fibrosis. So in those, it was not indicated. But now, as I said, that if there is, if there was family history of HCC or LC or the age is more than 30, in the previous guidelines, it used to be follow-up. But now, what we have seen that the low viral load doesn't remain low all the time. In follow-ups, these patients, it does fluctuate. So if there is no contraindication, I will go for treatment for this very patient, but this is the individualized approach, as I'm saying. I'm very aggressive with these patients that I do treat, because I've seen patients with low viral load, with even negative viral load, becoming cirrhotic, and I'm doing the fibrosis over the last 12 years, the fibrosis, the fibrosis does increase. Yes, the chance is low, but it's not perfectly immune that he will not deteriorate. So that patient can be treated. If he's, the guidelines are for the general, but if the right of the treatment lies with the patient, if my patient needs treatment, because he is the risk for the transmission as well for his family, so I'll treat that patient.
Right, Amna, if you
Right. So thank you very much. Wonderful presentations from all speakers and very pertinent points were highlighted. So just two comments and one small question for Dr. Farooqi. Dr. Marooq has emphasized about chronic hepatitis E, which is again something which is underestimated, especially in our part of the world, in Pakistan as well. So that's a good reminder. Marooq, thank you very much for that. I think two questions comes again and again when we treat patients with hepatitis A in E, especially when they are presenting with acute liver failure. A, for the pregnant women, what is the best time to deliver to them? Should it be an early delivery or not? And number two, the use of N-acetylcysteine. So it's very, if you just simplify the first area, when to deliver a pregnant woman when presenting with acute hepatitis A or E and acute liver failure, what's the best time? So the answer for acute liver failure is very simple. Somebody is like in full-blown acute liver failure, diagnosed in an appropriate time. These are the patients where early delivery would help. People who are having just acute hepatitis, no. People who have acute hepatitis with coagulopathy, no. And this is a gray zone where many people receive consults from our OBGYN colleagues, and even our colleagues go and recommend early delivery. This is the group of patients where you can wait, monitor them very closely. If they develop acute liver failure, these are the patients where early deliveries actually could help, especially you know that early delivery, for example, somebody is like just only 28 weekers, 26 weekers, the morbidity and mortality for the infant is very high. Mother is a priority, we all know, but here you can make a decision making very nicely and accurately. There's a very nicely written guideline of EASL published last year. You can reference for it, and they have actually they reviewed the topic very in detail. The second question is about NAC. The NAC was approved initially for N-acetylcysteine-induced acute liver failure. With a groundbreaking study published in 2009 by Professor William Lee has led us to use it in non-acetaminophen-induced acute liver failure के अंदर में भी आप ये use कर सकते हैं N-acetylcysteine, but remember this is acute liver failure. Now what is an observation? NAC is being given, we do see that being given to patients who are having acute hepatitis with coagulopathy. This is itself a research question. So use the NAC judiciously. You can use it in acetaminophen, non-acetaminophen-induced acute liver failure. Be cautious its use about liver acute hepatitis with coagulopathy because NAC itself has adverse effect. The third comment is about, and you can think about in your practices as well, most of the people in Pakistan, when they reach to the age of 18, they've been already exposed to hepatitis A. This is the older data. But how many of you do see acute hepatitis A coming in adult population? Can you please raise your hand?
Very rare.
This is changing. So this is changing. So if I would see that during last 3 years, a number of adult patients are coming to us with acute hepatitis A, we thought, let's see what is the trend. So we went back, we studied our 5 years retrospective data, and then the day patients were coming in 2023 and 2024, a good number of cases of adult patients coming with hepatitis A is like increasing and increasing. Now we're planning to analyze our retrospective data of last 40 years and seeing the trend, 30 years at least, seeing the trend, then is there a change or not. But I think you can also see your practice, is this the trend you're observing in your practice or not? If yes, then probably other than good sanitation, hygienic, educate them for safe water and hygienic practices, one can think about vaccination of hepatitis A in adult as well. But I think this is an area which is evolving, and we all can see that what is the trend of hepatitis E in adult patients. Thank you.
Thank you, Dr.
Thank you, everyone.
I
In the
think
end,
this session is to conclude. I thank everyone who are participating in this session. Thank you very much.
I request our chairpersons and speakers for a group photo, and then session will be proceeded by Dr. Atif. Thank you, everyone.
Assalamu alaikum, ladies and gentlemen. My name is Dr. Atif Majid, and I'll be moderating the third session today, which is actually a state-of-the-art lecture. So for this, I would like to request the chairs of the session to please come on the podium. We have with us Dr. Javed Iqbal Farooqi. Dr. Javed Iqbal Farooqi may I request you to be the chair of this session. So Dr. Javed Iqbal Farooqi has already been well introduced. He's had a talk just recently, the Professor of Medicine and Gastroenterology. And he's the head of department Everlife Institute in Peshawar. We have Dr. Muazzam-ud-Din, and we could invite him for the chair as well. He's the former head of department Quetta, Bolan Medical Complex, and he's also the former president of PSH. We would also like to request Dr. Ashad Kamal Bhatt to be the chair. And he's also professor of medicine and gastroenterology. He was the former head of department at Sheikh Zayed Hospital. And we've got Dr. Nasir Khan, who's an assistant professor in gastroenterology at Sheikh Zayed Hospital, Quetta. So now I would like to introduce it is a request to please, if we can have a moment of silence, please. Assalamu alaikum, sir. It is appreciated if everyone could have a seat. All right, thank you very much. It's a pleasure for me to introduce Dr. Wasim Jafri. Now, introducing Dr. Wasim Jafri is a big task in its own. It will take a long time because it will be a lecture in its own, so I'll try to simplify it as much as I can. Dr. Jafri has been the head of Department of Medicine and Gastroenterology at AKU previously. He served more than 2 terms. Subsequently, he was also the Associate Dean for Medical Education at Aga Khan University Hospital. Currently, he is the head of department at South City Hospital, Karachi. He has had a number of life achievements awards to his name. He's among the only few Master of American College of Gastroenterology that has been in Pakistan. He has had hundreds of publications. He's an esteemed clinician. He's a teacher, a mentor, and a role model for many. And in fact, he's someone whose mentees and his students have become role models and teachers. So without any further delay, I would like to invite Dr. Wasim Jafri on the podium for his talk regarding hepatitis B. And it's regarding the discovery to elimination. So I would like to invite Dr. Wasim Jafri.
Bismillahirrahmanirrahim. Would like to pay my thanks to the organizers of this conference and for the very kind invitation. We have heard quite a bit about hepatitis B and C in the recently concluded session, and here we are to discuss discovery to elimination. Is it a myth or a reality? When we look at the historical aspect, I think lots of you already know that Dr. Bloomberg was the person who first identified what we call as hepatitis B. And in good old days, the senior colleagues would remember that we used to ask for Australia antigen. There was no such thing like hepatitis B profile and DNA and all that. And let's check for Australia antigen. And that was what hepatitis B was. And the reason was because Bloomberg found out this thing in Aborigines from Australia, and this is how the initial term for hepatitis B used to be Australia antigen. And Feinstein in 1973, in fact, detected hepatitis A virus, and Mario Rosetto from Italy in 1977, hepatitis D virus. And who in 1989, he's a Singaporean who was working with Professor Houghton in California, US, and this is how we came to know about hepatitis C virus and hepatitis C by Rhines in 1990. So let's start with B first, and this is Bruce Bloomberg, and in fact, he received the Nobel Prize as well for his work related to hepatitis B virus. He had an immense curiosity and energy that were hallmarks of his scientific personality. Described as a leading light in the scientific community and was a great humanitarian. He traveled quite a bit. In fact, even came to India to collect samples for, this virus which was associated with transfusion-related, hepatitis. And Bloomberg identified the hepatitis B virus and created the first vaccine to prevent infection with the virus. So let's go to some of the key facts, and I think the audience is very well versed with all these key facts by now. Hepatitis B is a viral infection that attacks the liver and can cause both acute and chronic disease. The virus is most constantly and commonly transmitted from mother to child during birth and delivery, as well as through contact with blood or other body fluids during sex with an infected partner. Unsafe injections or exposures to sharp instruments. WHO estimates that 296 million people were living with chronic hepatitis B infection in 2019, with 1.5 million new infections each year. In 2019, hepatitis B resulted in an estimated 820,000 deaths, mostly from cirrhosis and hepatocellular carcinoma. Hepatitis B can be prevented by vaccines that are safe, available, and effective. And this is the map that you already are familiar with. And our country has got a significant number of patients living with hepatitis B whenever we look at it in the real sense. In fact, it is very difficult to say, how many of you have gotten yourself checked for hepatitis B virus, and hardly, you see a raising hand, amongst the audience that you would like to know. All right? Let me see your hands. Come on. All right. What about your households and people living in your house? How many of you are sensitive that, you have gotten your household people to know whether or not they have hepatitis B or C or whatever has been discussed in the recent past since morning. The Larkana belt, the Jack Babad, and Huzdar and all those areas near that is the heaviest burden of hepatitis B in Pakistan. So we looked into this fact that what is the current status and are we living with the same scenario as we knew many, many years ago, or are we improving? So we thought that yes, because Aga Khan University, we had collection points throughout the country. So yes, blood would flow in from Peshawar, from Quetta, and from all parts of Pakistan. Let's do it. So this is how we evolved into this study, changing trends of hepatitis B seromarkers amongst Pakistani population, a laboratory-based review. So out of 185,825 patients, we checked for the serological markers. And what we found was that the study substantiated the general perception that levels of surface antigen is showing a decreasing trend, while levels of surface antibody are increasing, perhaps due to a better vaccination of population. But don't take it in true sense and reality, except for the fact that this was just, the blood that flew in from different parts of the country for a variety of reasons, not for sake of LFTs and hepatitis. Can hepatitis B be cured? Can I see some of the hands? Can it be cured? What you have heard this morning? All right, let's see. Can HBV be cured? Chronic hepatitis, we all know, is a global health problem, elimination of hepatitis B infection and HBV-related diseases. All right, so HBV susceptible, we all are, and what we need is a vaccine at a universal precaution, which is so readily available, and very, very safe vaccine. All right, we have acute hepatitis B and chronic, we have antiviral treatment, and you have heard all about it. Cirrhosis and HCC are the aftermaths of this infection. All right, the current treatments, virus suppression and sustained disease control. All right, the nukes, viral suppression, that's all we do. Results in decreased inflammation and fibrosis and disease progression, marginal reversal of fibrosis and decreased projection, and decreased incidence but not elimination of hepatitis B-related HCC from cirrhosis to HCC. The surface antigen loss, however, is less than 5% after many, many years of treatment and follow-up. So that's what we stand today with the currently available hepatitis B treatment. We have two groups of hepatitis B, the E antigen positive and the E antigen negative. And you must know that because E antigen positive means there is a higher detection of hepatitis B DNA in this group, the viral replication, and the E antibody positive have lesser. So the currently used treatment, available treatment with PEG interferon, tenofovir, and entecavir, the surface antigen loss is unbelievably low, 2%, 3.2%, but this is in the cohort that was checked. But that's not, generally what you see in this group. The E antigen negative have even lesser of that amount, less than 1% with the currently available treatment. So you can control it, but you cannot cure it. All right, so new treatment concepts. Will we need combination of DAs and immune therapy? As I discussed that, lots of studies are currently happening globally with antivirals, immune restorations, the new capsid and siRNA antigen load, etc. And the checkpoint inhibitors, therapeutic vaccines, they are being studied, and TLR agonists. So yes, things are happening globally, and our goal for the next decades to be seen. So currently available treatment that we have got a control of hepatitis B from whatever we do, but we do not have cure. And what we are looking for is that yes, with multiple aspects of treatment we should be able in the next few decades for hepatitis B virus cure. The same thing as we know for hepatitis C, that we have curative medicine, we do not have curative medicine for hepatitis B. All right, so this is the gist of everything, that prevention through vaccination is what we must actually implement to its core. And we know that 60.1% decrease in the incidence of hepatocellular carcinoma, 76.3% decrease in mortality from fulminant hepatic failure, 92% decrease in mortality from chronic liver disease over decades since vaccination was introduced in Taiwan. So the study comes from Taiwan, where all these things were looked at and vaccine was started, and over decades they have seen that thing. Excellent safety profile determined by this thing. Cost effective, particularly as part of triple elimination strategy to eliminate mother to child transmission of HIV, hepatitis B, and syphilis. The WHO recognizes the importance of hepatocellular carcinoma and other HBV-related diseases as global public health problems and reiterates its recommendation that hepatitis B vaccines should be included in the national immunization programs. A comprehensive approach to eliminating hepatitis B transmission must address prevention of infections acquired perinatally and during childhood, as well as prevention of infections acquired by adolescents and adults. Reaching all children with at least 3 doses of hepatitis B vaccine should be the standard for all national immunization programs. Does it exist in the country that we live? The vaccination is recommended for all children worldwide, and all national programs should include a monovalent vaccine birth dose, ideally within 24 hours. And this is the gist of the thing, that birth dose within 24 hours or as early as possible is the hallmark, where of course this elimination strategy would come to a reality rather than a myth. Because within the first year, if you get hepatitis B from whatever reasons and sources, 95% chances are that you are hepatitis B positive for the rest of your life. Because that is what the core issue is. And if in adulthood you get, there is a good chance that you would be able to actually eliminate the virus through your own immune responses. But the birth dose vaccine, does it exist in our country? No. Within 24 hours, within few days, within a week, within a month, no. A 3-dose schedule, monovalent birth dose, second and third dose is given with first and third doses of DPT vaccine, or 4-dose schedule, monovalent birth dose, following 3 doses given with other routine infant vaccines, at least 4 weeks between doses. No evidence to support need for booster dose. Catch-up vaccination should be considered based on available resources. Priority should be given to younger age groups. Vaccination of groups at highest risk of acquiring HBV infection is recommended if they are not already vaccinated. And you know already that this is not a virus that comes to you shaking of your hands or doing whatever. It is derived from blood products, dialysis, or diabetic patients, recipient of solid organ transplants, persons with chronic liver disease or HIV, persons interned in prisons, persons who use injecting drugs, household and sexual contacts of persons with chronic HBV infection, men who have sex with men, persons with multiple sexual partners, healthcare workers, and others who may be exposed to potentially infectious body fluids during their work. HIV-positive individuals should be vaccinated as early as possible in the course of HIV infection, and immunocompromised individuals may have reduced immune response following vaccination, and one should know that. Vaccination is safe for pregnant and lactating women. A birth dose can be given to low birth weight and premature infants. The birth dose should not count as part of the primary 3-dose series. The 3 doses of standard primary series should still be given afterwards according to the national vaccination schedule. WHO position strategy for implementation. This is very, very important. National strategies to prevent perinatal transmission should ensure high and timely coverage of the birth dose through a combination of strengthened maternal and infant care at birth with skilled health workers present to administer the vaccine, and innovative outreach strategies to provide vaccine for infants born at home. This still happens in our country. Increased proportion of infants born in healthcare facilities and health promotion efforts to eliminate false contraindications like unease over vaccinating low birth weight. No, they should be vaccinated, and premature infants. Concerns over adverse reactions, fear of vaccine wastage, personal cost concern, and cultural prohibitions. Most unfortunately, all of you would have read in newspapers about lady health visitors going for vaccination, for caring of the newborns and all that, and they are eliminated, which is an unbelievable thing, that people who come to care your children or at least prevent infections in them, in fact, they are no more, because what happens to them is unbelievable. And you would have heard in newspapers about areas of Pakistan where these things have happened many, many times indeed. And when we go abroad and sometimes these things are discussed, it brings us to the lowest level of our strategy. What about reporting and monitoring? Reporting and monitoring systems should be strengthened to improve the quality of data on the birth dose. To monitor accurately the delivery of doses given within 24 hours of birth, these doses should be recorded as a timely birth dose of hepatitis B vaccine to differentiate them from birth doses given later, late birth dose. Serological surveys of hepatitis B virus antigen prevalence representative of the target population will serve as the primary tool to measure the impact of vaccination and verify achievement of the hepatitis B control goals. Now let's move on to hepatitis C. Discovery of hepatitis C virus, ongoing elimination efforts, target 2030. So 1989, when we came to know about hepatitis B virus, previous to that, or at least in 1989, before the advent, before April, in fact, we all used to say non-A, non-B hepatitis for this group, because we were at large as to what is the reason for this. So 1965, I've already mentioned about Bloomberg and Alter, and Feinstein and Kaplan, of course, in 1973 for HIV, the hepatitis puzzle was still incomplete. So transfusion-associated hepatitis, not due to viral hepatitis type A and B, and the common thing used to be at that time that this is non-A, non-B hepatitis. And New England Journal of Medicine, in fact, this reported in 75. 9 out of 22 patients had antibody responses to cytomegalovirus or whatever. So we had no clue as to why they would get, in fact, post-transfusion hepatitis. When we looked at it, in fact, in the same year, 1989, so non-A, non-B hepatitis is commonly the cause of hepatitis following transfusion of blood, and its products as hepatitis B surface antigen screening is commonly used on donated blood. 10% of post-transfusion hepatitis was related to this thing. We had no knowledge that this is hepatitis C at that time, but it was non-A, non-B. So the isolation of cDNA clone derived from a blood-borne non-A, non-B viral hepatitis genome, 21st of April in the journal Science, 1989. And here is Michael Houghton and Harvey J. Halter, and they were the principals who worked very hard in order to get us know about what this non-A, non-B is, and it is hepatitis C virus. So what he writes is that the molecular identification of hepatitis C virus was the culmination of a team effort spanning 7 years, during which hundreds of millions of bacterial CD clones, hundreds of millions clones were screened for a putative non-A, non-B hepatitis, origin using many different approaches. Only one positive clone was the result of this strenuous effort. If we had missed or lost 511 from the library, we may still be looking for HCV. So historically, transfusion-associated non-A, non-B hepatitis, 1975. Transmitted to chimpanzees, 1978. Genome cloned, 1989, and the initial classification was flaviviridae and then became hepciviridae. All right, the virus can cause both acute and chronic hepatitis, ranging in severity from a mild illness to serious lifelong illness, including liver cirrhosis and cancer. The hepatitis C virus is a blood-borne virus, and most infection occurs through exposure to blood from unsafe injections practices, unsafe healthcare, unscreened blood transfusions, injection drug use, and sexual practices that lead to exposure to blood. Globally, an estimated 58 million people have chronic hepatitis C virus, with about 1.5 million new infections occurring per year. This is not the data from this year, but as WHO's key facts illustrated, there are an estimated 3.2 million adolescents and children with chronic hepatitis C virus infection. WHO estimated in 2019 approximately 290 million people died from hepatitis C, mostly from cirrhosis and hepatocellular carcinoma. Antiviral medicines can cure more than 90, not like hepatitis B control. So cure more than 95% of persons with hep C infection, but access to diagnosis and treatment is low. There is currently no effective vaccine against hepatitis C virus. You must have seen this chart many times, and it lists us as number 2 in the prevalence figures of hepatitis C virus after China. But Chinese population is, many fold higher than us. So according to the world data at the time, this study is Journal of Hepatology 2014, but it lasted for many years. What about the PMRC study in 2007 and 8? It has not been replicated since then. We need an update on it. And it showed an HCV prevalence of 4.9% at that time, and overall with B and C 7.4. And the best study that revealed why we have got an enormous numbers of these patients. The injection practices in our country is just unbelievable according to the statistics. Our own at AKU and PMRC studies showed 13 to 14, whereas the WHO allows 3.5 injections per person per year. So what about the children? When we looked at this hepatitis B and C prevalence and risk factors associated with seropositivity among children in Karachi and adjoining areas, we screened about 3,533 children, and we still found that hepatitis B and C were prevalent at different studies, and the total number was 3.3%. There are 6 major genotypes, you already know that, and our genotype in Pakistan, which was, in fact, I would call a better genotype, because during the earlier days with interferon treatment, in fact, interferon was best suited for genotype 3, and our results were far better than genotype 4 and 1. 1 was in US and European countries, and 4 was in Egypt. So ours was 3. So when we looked at this study, in fact, we found that 87% of our patients were genotype 3 hepatitis C virus. Advanced liver disease due to HCV infection is a huge global burden. 27% of cirrhosis related to hepatitis C, and almost 1/4 of HCC cases due to hepatitis C virus. And we looked into this aspect, and we thought that let's look into the hepatitis C-related carcinoma in our subgroup. And what we found in 645 patients when they were enrolled, 84.7% were viral HCC and 15.3% were viral marker negative. So in the current era, when we are discussing MASL, which is metabolic dysfunction associated liver disease, like fatty liver and whatever, that also produces cirrhosis and HCC, but predominantly 67.9% were related to hepatitis C virus, 21.8% were hepatitis B, and concomitant B with C or D, 10.3% in our population. HCV cure reduces all-cause mortality from 26 to 8.9, and liver-related mortality 27.4 to 1.9, less than 2. So its cure certainly is most beneficial for the group that suffers from hepatitis C virus, and even hepatocellular carcinoma from 21.8 to 5.1%. And the cure is depicted by the term of SVR, sustained virological response, which means that you are treated and 6 months and beyond the PCR is negative, and this is, hepatitis C cure. We are very, very lucky today because we have got DAAs, the oral treatment of hepatitis C virus. Previous to 2013, it was interferon-based treatment. In fact, either, we started with daily, then of course became weekly, and finally we ended up with these wonderful drugs. And because of the extreme prevalence, you can see within 2013 and 2016, there were, so many drugs were approved by FDA. Which other condition in the entire, ailments can you ever think that within a period of 3 years, there are so many medications that are approved for that particular ailment? None whatsoever. Hypertension, whatever one can think about. But hepatitis C, because of the prevalence, the drug companies and all that, spend millions and trillions of dollars in order to make all these available. And this is how it is. And then in finally 2017, the other two were approved, and that's how we stand today. And this is across all genotypes that the oral DAs are effective. So genetic heterogeneity of hepatitis C virus is very well known, and that is one of the reasons that we cannot and we have not been able to develop hepatitis C vaccine, and there is no hope for future as well. High rate of viral persistence, lack of solid immunity, and genetic heterogeneity. So it is one of the viruses that is, it produces problems of liver, hepatitis, cirrhosis, hepatocellular carcinoma, and whatever. There is currently no effective vaccine. So what next? Elimination 2030. Oh my gosh. Why elimination? We have got number of deaths years from selected conditions, and look at viral hepatitis producing almost, according to the statistics, the same proportion, and that's how the sustained development goals were identified, and of course elimination was, what is the difference between elimination and eradication? Reduction to zero or a very low defined target rate of new cases of an infectious disease in a defined geographical area as a result of deliberate efforts. Continued measures to prevent re-establishment of transmission are required, refers to the reduction to zero or a very low defined target rate of new cases. So there is a difference between elimination and eradication. Elimination still will require, after 2030, continued measures to prevent re-establishment of disease transmission. However, if things are eradicated, the complete and permanent worldwide reduction to zero new cases of an infectious disease through deliberate efforts. So no further control measures are required if it is eradicated. All right, HCV discovery to elimination, myth or reality? WHO In fact, World Health Assembly met in May 2014 to develop Sustainable Development Goals. September 2015, and growing movements around hepatitis started. And this is how this was all focused on: elimination as a public health threat focus for HIV, malaria, sexually transmitted infections, tuberculosis, viral hepatitis, and focus on eradication of polio, and that is also still available in our country. So according to that, towards the vision of a world where viral hepatitis transmission is halted and everyone living with viral hepatitis has access to safe, affordable, and effective prevention, care, and treatment services. And they published their first strategy on viral hepatitis, WHO, in 2016 to 21. And 5 strategic directions were: more important information for focused action, interventions for impact, delivering for equity, and financing for sustainability, and innovation for acceleration. When it all started at baseline 2015, you can see the percentages and what is expected in 2030. About 90% of worldwide HBV vaccination, 90% of birth dose given, safe injections, harm reduction, HBV treatment, and HCV treatment. Elimination targets for hepatitis B and C would result 6 to 10 million infections in 2015 to 900,000. So it's not gone, it's reduced to 900,000 infections by 2030. 1.4 million deaths in 2015 to under 500,000 deaths by 2030. So global baseline and coverage targets. How this is going to be done. The global health sector strategy HCV targets at a glance. All right, you can look into that. There is an incidence targets, mortality targets, harm reduction with increase in sterile needles and syringes provided per PWID, the people who inject drugs, and testing targets, treatment targets, 90%, 80%. The quantum of viral hepatitis services and the retention cascade, now with focus on people who are injecting drugs, abusive in fact in this thing. We also looked at the seroprevalence and risk factors for hepatitis C infections among male prisoners in Karachi, and what we found was 18.4% therapeutic injections given by glass syringes, use of injectable drugs, sharing razors, and illiteracy were associated with higher risk of acquiring HCV infection. So, ladies and gentlemen, a people-centered health system for hepatitis elimination. National strategy, health workforce, financing, budget for provision, capacity to monitor disease progression, strategies for engaging PWID former or acting people who inject drugs, and effective surveillance monitoring of loss to follow up. Very, very important. We need to look into it. Eliminating HCV requires national strategies and plans. Are you familiar? Is there a national program that you have ever seen? Online? PDF? Essential goals to eliminate. Secure political commitment for HCV elimination. Expand screening programs. You must know about people who have got hepatitis. Universal screening, non-traditional screening sites like emergency departments, urgent care centers, dental clinics, behavioral health, and OBGYN. Screening modalities, etc. Treat, screen 85% of the population. Evaluate 85%, treat 85%, and cure 85%. Reduce the incidence of new HCV infections. Very, very important. Egypt has done a wonderful job. They have a much higher incidence of hepatitis C with genotype 4. And they are done, really the whole world accepts what they have done is wonderful, and if it has been cut down to almost nothing as I stand today and speak to you. So could they be, globally by 2030? We're looking into it, leaving no one behind towards equitable global elimination of hepatitis C. Very, very important indeed. What about it? National governments and global health communities must recognize the risk of history repeating itself and not allow hepatitis C to follow the same path as tuberculosis. With incidence of hepatitis C on the rise, the role of drug resistance still unknown, and the importance of poverty alleviation underplayed. The warning signs are there to see. Our time is now. Let us combine the fantastic opportunity presented by the development of directly acting antivirals with knowledge sharing, national leadership, and necessary financial commitments to meet the WHO goal of eliminating hepatitis C as a public health threat globally by 2030. Of course, the COVID-19 pandemic also resulted in negative effects during those 4 or 5 years. And given constraints in the budgets anticipated in the face of COVID-19 response, the elimination program in some parts of the world got affected. You must have seen this picture, find the missing millions. All right, have you tried that? Except on the day, in fact, you can wear your sun caps at something and take pictures and it come. What have you done since then? 9 in 10 people living with this is the World Hepatitis Day. You all know 28th of July. This is the most recent WHO figures who are undiagnosed and treated by WHO regions. And our region is there, Southeast Asian regions, and see where we stand today. Proportion and number in millions of people living with hepatitis B who are undiagnosed by WHO regions, 60%. Proportion and number in millions of people living with hepatitis B who are untreated by WHO regions, 60.4. Proportion and number in millions of people living with hepatitis C who are undiagnosed, but 26%. So here we are, as I stand today, as we go out of this meeting, hopefully energy, commitment, and resources would help that we are at par with the rest of the world by 2030. This is 2024, so it's not a lot of time left. A public health approach with simplification, integration, affordability, and equitable access. Partnerships between government, civil societies, private sector. Concrete and tailored action in countries guided by national plans, and hepatitis elimination by 2030, myth or reality in Pakistan? All right. Think about it. Thank you.
Thank you very much, Dr. Jafri. Indeed, it is a very difficult thing to comprise everything into just 25 minutes. So with this, since we are short of time, I would request chairs for their comments. And after that, we've got 20 minutes break for tea, and then we assemble back.
He eloquently covered hepatitis B and C starting way back in 1960s and going forward all the way to 2024 and perhaps beyond even. The statistics which Professor Saab has presented are sobering and terrifying. There are huge gaps which he has identified in governmental policies, but gaps exist even in our healthcare institutions as well. To my horror, recently I discovered, on more than one occasion actually, even the obstetrical units are not fully aware of hepatitis B immune globulin, when is to be given, what is the dose, and what to do. And surprisingly, I've come across instructions, do not breastfeed your infants if you have hepatitis C. Those myths need to be cleared even for our healthcare professionals. As far as hepatitis B is concerned, it was overshadowed by hepatitis C in 80s and 90s when C became the darling of all the hepatologists worldwide. And we thought that it's a very innocent disease. And I still remember those terms, healthy carriers. We used to tell our patients, don't worry, you've got hepatitis B, but nothing to worry about. We now know nothing was farther from the truth. Hepatitis B is there, it is still there, and it's come back with a vengeance, and we need to do something about it. The best part is that it is treatment of hepatitis B, although that's not effective, but vaccination leads to a preventable cancer. You don't get hepatitis B, you don't at least get hepatitis B related cancer. We can learn a lot from Egyptian experience and from experience in Iceland as well. They have been able to achieve their targets for elimination of hepatitis C. We believe that we are slowly inching towards cure of hepatitis B as well. There was a time when we said that no, nothing can be done. Now we have powerful agents available to us. Although we can currently control it and can't cure it, but hopefully within a few years we will have therapeutic armamentarium which will get rid of the cccDNA, and that will be a cure. And we are looking forward to it. Actually, we are looking forward to the day when hepatitis B and C, like the dinosaurs, are eliminated, never to return back again. I would now pass on the forum to my co-chair, Professor Javed Farooqi Saab, and for their comments.
Professor Wasim Jafri gives a very comprehensive and knowledgeable talk in which he highlights current management of HBV and HCV and importance of vaccine for elimination of hepatitis. And I expect this is also duty of government to cooperate with our society for this purpose and take safety measures for social workers through them, different societies, and we must involve ourselves for educate the people. Thank you.
Excellent talks by Professor Jafri Saab, as always. We are talking about B and C elimination and eradication, but we must also talk about D, which is highly increasing in some areas in Balochistan. It is very alarming. Some areas are there, every fourth person is infected with D. So we must also talk about this. Once again, excellent talks by Professor. Thank you, sir.
Well, on behalf of my co-chairs, the organizing committee and host, sir, I'm thankful to you for a very comprehensive and thought-provoking talk. You enlightened us as usual you do, and we hope that the message is carried to the macro level, and we all should play a role in the elimination of this because unless these approaches are adopted at the individual levels, probably we won't reach the 2030. To Pakistan, probably it will be 2040 or 2050. But if we can go half the way by 2030, that will be our success. Thank you very much once again, sir. Thank you.
Thank you very much. Now I would just like to request Dr. Jafri for the group photo with the chairs, and we would like to quickly invite Dr. Ravi to introduce the next session, and then Dr. Ali will come.
Assalamu alaikum and good morning. I am Dr. Ravi Raj, working as a gastroenterologist at 71 Provincial Hospital, Quetta. So next session is all about metabolic dysfunction associated steatotic liver diseases. So please join us after the tea break. Thank you.
जी, the tea break is in the hall next door. दरवाज़ा बाहर से है. आप लोग वहाँ पहुँचे. Please gather here again in 15 minutes. We'll start the session promptly, inshallah. And please go and meet your pharma colleagues. उनकी support बड़ी ज़रूरी है हमारे लोगों के लिए survival के लिए.
Hello, sound check. Hello. Hello. Hello, 1, 2, 3. Hello. Hello. Bismillah Rahman Rahim. Hello. Hello, sound check. 1, 2, 3. Hello. Hello, sound check. Hello, sound check. 1, 2, 3. Hello. Hello, sound check. Hello, my testing. 1, 2, 3, 4. Hello. Hello, sound check. Hello. Hello, sound check. 1, 2, 3. Hello.
Hello, 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 check one. Hello, hello, check one. Hello, hello, check one.
Hello. Assalamu alaikum, respected senior and colleagues. I am Dr. Ravi Raj. So, ठीक है। So as I already mentioned, this session is all about MAFLD or metabolic dysfunction associated steatotic liver disease. So may I have the opportunity to invite the chairpersons of this session. First I would like to invite Professor Dr. Kashif Malik Saab. He is a professor and head department of gastroenterology, hepatology, Sheikh Zayed Postgraduate Medical Institute, Lahore, and is also an ex-president Pakistan Society of Hepatology from 2021 to 2022. Sir, please have a chair. May I invite Dr. Nasir Hassan Lak Saab. Sir is a professor and head department of gastroenterology and hepatology at SIUT. Sir has more than 250 publications in the various prestigious journals with a notable work on prevalence of hepatitis B and C in the hemodialysis population. May I invite Dr. Mohammad Afzal Chaudhry Saab. Sir is in HOD Medicine, Nawaz Sharif Medical College, Gujarat. He is also an executive counselor, PSH Central Punjab, chapter head, Pakistan Society of Internal Medicine. May I invite Dr. Khalid Tawreen. He is a consultant gastroenterologist and hepatologist and working as an assistant professor at Sheikh Khalifa bin Zayed Hospital, Quetta. So before we start our session, I would like to tell all the audience that if you have any questions or queries after each topic, so we have some, we have the WhatsApp facility, and we have got some logos so that you can check it.
Basically, we are short of time, so this is a QR code. Please scan it. It's a WhatsApp number. इस पे आप अपने questions भेज दें because question answer session will be very brief, but we want your questions. So ये मैं circulate कर रहा हूँ. Scan this, save the number and send questions on that, please. ठीक है जी? So, and that questions will come here and then you can ask the questions.
So let's start the session. And the first talk will be presented by Dr. Zishan Ali Junejo. He is an associate professor of medicine at Jinnah Sindh Medical University. He is also the head of the Medical Unit 4, Ward 23 Medical ICU, Jinnah Postgraduate Medical Center, Karachi. He is also a member, Technical Advisor Group Sindh HCV Elimination Project, Government of Sindh.
Assalamu alaikum, and thank you very much for all of you to be here. Being as the organizer of the event, I've got more pressure, not only to cover the time which we have lost actually. We are 45 minutes late now, and try to catch up that. So, MASLD in Pakistani perspective, is it something which we should worry about? Is it something which is relevant to us, or it's just a kind of Western disease? And does this exist? That's what I'm going to talk about today. So, what MASLD is? It's a new term, but it has been there for last probably 7-8 years. We have been discussing this thing. It has been now officially nomenclature have been adopted by most of the societies. We used to call it NAFLD previously. Then Apazal tossed up the terms of metabolic associated MAFLD term, fatty liver dysfunction. Then The EASL and the AASLD came up with a term last year with the MASLD. And PSH is among the first Pakistani societies which adopted this terminology officially and endorsed this classification. And what it means is, if the person is having any kind of steatotic liver disease in terms of imaging, then it makes the case of steatotic liver disease. If there is metabolic dysfunctions associated, we'll be discussing shortly, then it is MASLD. And then if it is only fatty liver without any inflammation, then it is called MASL alone, or if there is inflammation or fibrosis, it would be labeled as MASH, which was previously termed as NASH. What makes the difference by taking the loves NASH or MASH is the biopsy, because previously it was exclusive disease. We have to exclude all the causes of the other liver diseases and label someone as a NASH and get the biopsy proven diagnosis. But now it is a non-invasive diagnosis. We can make it with the presence of deranged LFTs, and the evidence of the fibrosis is good enough in the presence of steatotic liver disease and metabolic dysfunction. If there is alcohol, because we all know the alcohol is not completely, somebody would take some amount, somebody would take more amount, and somebody would take very high amount. So alcohol is not being completely obstructed. Even in Pakistan, many people do take it, they may or may not report it. So if there is exposure of alcohol, it may be alcoholic liver disease primarily, and with metabolic dysfunction, or it may be metabolic dysfunction primarily with some amount of the alcohol consumption. So these are the two, MET ALD or ALD with metabolic syndrome are the terms. If there isn't any metabolic dysfunction with alcoholic liver disease, which is again presenting as steatotic liver disease, would be a pure ALD. Then there are other causes where there won't be alcohol involvement, and there may not be still the metabolic risk factors, but there would be steatosis in the liver. And these are the other causes of single etiology, drug-induced, monogenic, and then some genetic disorders. So this is what we have been proposing from the, this is already an article in press from the forum of HepNet, and some of the patients still may not be classified any of these, and it would come out as a cryptogenic. We were talking about the metabolic dysfunction. How would we define overweight or obesity? And remember these Asian criteria, 23 and above is overweight and obesity here. The BMI cutoff, or 90 centimeter or 80 centimeter men and women, the waist diameter. Dyslipidemia, triglyceride, or HDL, or on treatment, any systolic blood pressure more than 130, or diastolic more than 85, or on treatment for hypertension, or fasting glucose more than 100. Now again, this is impaired glucose tolerance, this is not diabetes. So even pre-diabetes and diabetes are the risk factor good enough in the presence of steatosis to define as steatotic liver disease. So it makes the whole paradigm completely changing while we are diagnosing MASLD. When we talk about epidemiology, every third person in the world with this is actually having MASLD or MAFLD. Now, this is a huge number. When we talk about in this hall, if we say there are 70 people in this hall are suffering from, this is what I am actually saying here. And every second person with the diabetes would be actually having MASLD. So we remember the Pakistan is a diabetic nation. There is a very high number of diabetes in our population. And more than 60% in fact would be. And more important than when there is diabetes, along with this fatty liver, there is MASH, which is 40% of these patients. Otherwise, in a patients with steatotic liver disease, 25 to 30% maybe, but when it comes to diabetes, it is close to 50%. These patients would have MASH as well. They may progress to cirrhosis and HCC. And when we to look into the Pakistani perspective, this was a data published by Dr. Zagham group that was 15% in general population. Again, another one from the PKLI, recent data which suggested 30% healthy kidney donors were having steatotic liver disease. So generally it is 15 to 30% is the number which we are talking about. The people in Pakistan are actually having the steatotic liver disease. Pathophysiology, when we talk about this in our patients, you can look into the risk factors of healthy liver, steatosis, fibrosis, cirrhosis, and then may lead to HCC as well. Eating habits. What is the typical Pakistani cuisine? Just imagine for a minute what you are going to like in your lunch today. Naan, cold drink, then some rice, We take staple food. These are all carbohydrate. We are very high in carbohydrate when we talk about our diet, typical Pakistani cuisine. So we take a lot of carbohydrates in our diet, we take a lot of fat in our diet, and this is what the major risk factor in our population. Visceral obesity. We did publish data from Karachi, from JPMC with underprivileged people. In diabetics, 89% of our patients were overweight or obese. And remember, these were underprivileged people. These are not the affluent class. So this is not a disease of a class of affluence. It is across the board. And then diabetes, Pakistan is one of the top nations of the world with increasing. When we talk about incidence, it is highest top 3 nations of the world. When we talk about the diabetes, insulin resistance, major problem in Asian population is insulin resistance. The thin lean people still having, we had a paper in the morning when they presented the lean NASH in our population. Yes, that is the real, because even if the obesity is not there, there is insulin resistance and we have to look for it as well. And hypertension, and 30% to 40% of our nation is actually hypertensive as well. And dyslipidemia, and so these are risk factors. We don't have genetic studies, so we can see the different genetic factors which will contribute to our population. But yes, the lifestyle and the metabolic factors are so ubiquitous in our population that makes our nation more at risk for the MASH-related complications or muscle-related complications. Here this data was published by Zubair University Group, and you can see the viral hepatitis actually is decreasing in terms of the liver-related deaths, and that is static. But what is increasing is metabolic MASH or muscle-related. And what is contributing more, you can hear the obesity, diabetes, and hypertension, dyslipidemia. These are all 4 things which are very prevalent in our part of the world and Pakistani nation. Where was the data? Is there evidence what I am talking about? Yes, 60%, 60 to 70% of our population is obese. This is what comes from the Dr. Basit group from the BIDE, and this was a National Health Survey, remember. Diabetes, 26% of our nation is diabetic. Again, one of the highest number. This again is one of the most cited papers, and Basit, Professor Basit and Professor Samashera, which are big names in the diabetes world, and this is National Health Survey. It was and it was public nationwide study. It wasn't a hospital-based study, remember. So hypertension, 46%. So this is our national data. These are the numbers for Pakistani highly cited papers and groups who are working in producing the major data. So we are very metabolically high-risk people. And when you look into the numbers of, convert these numbers to percentages to the number, 140 million diabetics, 140 million obese, 60 million diabetics, and more than 100 million hypertensive patients. So these all patients are very high risk for the muscle. So when we talk of Pakistani perspective, yes, this is a serious problem. With this, 50% of obese would be having muscle. Somewhere around 50 to 60% would be, or diabetics would have muscle, and again another 40 million hypertensive would actually have muscle in these patients. So with this risk profile we are living with, though we don't have specifically data nationwide available to give the numbers, what exact number of the muscle patient are there in our population, but the projected numbers are alarming and it's very serious. We know that 15 to 30% of patients with muscle would end up with MASH, but this number, when extrapolated on the population figures, it is 35 to 70 million. And with MASH 4 to 25 million, and cirrhosis 1 to 6 million. And potential HCC would be more than 4 lakhs. So this is what the number which may actually require transplant. Do we have that kind of facility? We would be able to transplant that number of patients? Never would be. We have to prevent this happening. And with that, we need to work on it, because this is a metabolic dysfunction. It is preventable for sure. With the numbers which I have projected, probably this is the answer, that we are having a public health emergency when it comes to muscle, metabolic dysfunction associated liver diseases. unfortunate problem is that it is taken as it is a asymptomatic disease, it is taken as a benign disease, which probably it is not. We used to, when we were student, we used to say fatty liver sabko hota hai, it's healthy, kuch nahi hota, just chhod do, bhul jao. Every ultrasound which coming with fatty liver, we used to ignore it, or kuch nahi hai, but this, we have to change it now, because this is potential cirrhosis, this patient is potential HCC, and this patient is very high risk of dying with cardiovascular deaths in future. And then we have to improve the awareness of this mere fatty liver is not a disease which is going to go away as a benign disease. And we have to improve our research and data to work on the management of the MASL, because very few medications are actually proven through the trial, and only one drug is still now approved for the treatment. We have to screen our patient. All high-risk patients should be, ultrasound is a simple technique which is freely available, and there are non-invasive markers in which we can diagnose. I will be showing you in the next slide, and develop accurate non-invasive, develop our data and validate those non-invasive tests in our population, and then disease can be labeled, and then the education of the patient and lifestyle changes should be recommended to these patients. This is the algorithm again we are going to propose. It's already in publication. At-risk patients, we have talked about all metabolic risk factors, diabetes, hypertension, dyslipidemia, overweight, obesity, or established cardiovascular disease, should undergo non-invasive testing, ultrasound, and FLI or CAP score. And if the MASL is confirmed, which can be without evidence of without biopsy, then look for the fibrosis. For the fibrosis, APRI or the FIB4 are good enough markers, which cutoffs already written. Low risk, these patients can be managed by the primary practitioners or for the metabolic risk control, and optimize the risk factors and reassess in 2 to 3 years. But if they are intermediate or high risk, then they need surveillance for the cirrhosis. They need active management of their risk factors and aggressive management of their risk factors. And if the cirrhosis is already there, they would need care for the surveillance of HCC as well. There are so the primary intervention which we can go through for these patients is weight reduction. We know the 5 to 10% weight reduction would lead to resolution of the fat in the liver, and more than 10% may actually end up with resolution of the fibrosis as well. Metabolic control, diabetes control with SGLT and GLP receptor agonists preferably, that is important. Metformin and TZDs are other medications which should be preferred to improve the insulin resistance. Dyslipidemia management and hypertension management again are the medication which have either shown to be effective in reducing the liver fat or approved for the MASL are the SGLT2 inhibitors, GLP, GIP, TZDs, and resmetirom, which has been recently approved FDA for the MASL patients. Patients who are cirrhotic would need the follow-up for their end-stage liver disease or advanced liver disease. That's varicose screening, HCC surveillance, and in some cases, where feasible, transplant. With that, I would end this talk here, and I hope we can take question, or we'll take the question at the night, as Al says.
Thank you very much, sir, for the wonderful talk related to the new terminologies. Next, I would like to invite Dr. Farooq Khan for the second talk. We will be talking about the role of endobariatrics in the MASL management. Sir is an associate professor consultant in the transplant hepatology and the advanced endoscopy at King's College Hospital, UAE.
Is it? Assalamu alaikum, everyone. It's always a pleasure. PSH has always been very kind to have us all here. Can I start by saying to the trainees as well as consultants in the room, future is metabolic medicine. Future really is metabolic medicine. And this is where we would really like to focus on. Institutes, trainees who will now start to develop paradigms. Sorry, आवाज नहीं आ रही? Sorry. Can you guys hear me? The back? है ना? और करीब करें? Okay, fine. आप इस तरह करो, I'll use this, that's fine. Is that okay? Better now? Better. Even now I can hear myself. Thank you. Okay, let's just quickly start. So I'm really very sorry for the busy slide. As you can see, I have too many. No, I don't really. I am trying. This is a message for pharmaceuticals here. I really want this slide to get busy. It's not really getting busy. I've been trying it for the last 2 years. So we now, very quickly in the introduction, we'll wake up for the change. ये उर्दू वाली तब्दीली नहीं है. It's just to wake up for the change in the paradigms, as Zishan has very nicely set the stage for me. There is a patient of mine I'd like to present called Catherine, and I was hoping that you guys will help me look after Catherine as we walk through. Endoscopic modalities are important. That was the title of the talk that PSH wanted. And very lastly, I'll share the pathway. जब हम लोगों ने metabolic medicine शुरू किया था Kings में, so we thought that we will, this is not working. Do you want this mic to work? So let's just take this away. We'll just use, we'll use. So and I'd like to share our pathway. So if anybody amongst the trainees who want to set up this program, they can do. Can I quickly share this number? If your BMI is normal, you're actually 70%, if not 80% likely to reach the age of 70. And look how it changes. Just by changing the BMI, no other cofactors, you are 30% less likely. And if the BMI of your patient is really 35 to 40, please ask him or her to start writing the will, because it's very unlikely they will ever reach the age of 70. And that's how important this BMI really is in the outcome of your patients. A lot of my patients and your patients will also ask you, Doctor Sahab, वजन कम कितना करना है? How much do I actually have to lose? And this is the recent data that come out that actually tells us, being us hepatologists and gastroenterologists, this is what we are interested in. But I really wanted to draw your attention. Look at the type 2 diabetes prevention. And look at the type 2 diabetes reversal. Patients of mine who have achieved weight loss, they have stopped using insulin. They have stopped using blood pressure tablets. How strong outcome can this be? What else can you ask for, really? Okay, and how much do I exercise? That's another, but can I just quickly share this with you? आप लोग अभी coffee break से आए हो ना? Does anyone know जो coffee आप लोगों ने पी है? How much calories did it have, and how much exercise you will end up doing to actually burn that? ये आपको patients को बताना चाहिए. Take a photo of this. I don't mind really. This is on the RCPS. एक coffee जो आप पीते हो, that's 300 calories. Like it or hate it. And for you to be able to burn it, you either walk 53 minutes or you will run for half an hour. The amount of coffees I drink, I'll be out of job. Because at the end of the day, I'll be just running. And I can see Altaf Sahib shaking hands. Yes, yes, yes. Yes. Exercise, मैं अपने patients को क्या कहता हूँ, and I think this is all justified. They need to do aerobic cycling, swimming, running for 30 minutes a day on an alternate day. Is more than enough. And strength exercises, Asians, particularly waist circumference, ask them to do ab crunches. I'm not going to spend more than this really, because aap log, you want some excitement, that's why you were here. We talk about endoscopic. How do we treat endoscopic the menace of obesity? Can we inject? That's one. Can we balloon them? That's number two. And can we actually suture them? Endoscopic. That's number three. And we're going to talk, my job is to make you aware of what works, what is safe, and what doesn't work. And then, of course, you guys then take a pick what you want to do. Injection is Botox. We all know that. We have tried it previously. Balloon is another thing we'll talk about very quickly. An endoscopic sleeve, which has really been out for the last 10 years. But recently now, because MAFLD is becoming an epidemic, so parts of the world have realized that if you're really looking for 15 to 20% of the total body weight loss, then you really should start talking about A, suture plasty, and B, the one that gives you permanent. So this is a patient, Catherine, 41-year-old, mother of 2. She was newly diagnosed with type 2 diabetes. HbA1c is of course high, so as the insulin resistance, she had all the metabolic full house. Weight was 116 kilos, BMI 32. She was a GLP-1 failure. I'm sure all of you by now know 5% of your patients will not respond to GLP-1s and or wouldn't tolerate it, stop it because of the side effects, and she was one of them. That's all about the Catherine. We'll talk about gastric Botox injections. So what is this? It's like, you know the models, what they do, they put the Botox so the wrinkles go away so they look beautiful and what have you. This is the same technique. What we're trying to do here is inject Botox in the antrum. It's important, please do not inject it near the pylorus. This is a treatment of gastroparesis. Yeah? So what the injections, if you really are planning to do the injections, do it at least 7 to 8 centimeters away from the pyloric sphincter. You want it in the antrum. Don't inject it near the pylorus or into it. You will in fact make it, you will help them, the gastric emptying, and they'll eat more and more. It's a treatment for gastroparesis, all right? Does it actually work? Does the dose matter? We make 1 ml injections and we inject about 10 sites. Should you choose to do it? So if you look at the studies, they followed these patients for 1 month, and all these patients lost about 4 kilos. Meta-analysis looking at it, and they did not find this superior to placebo. So maybe this is something you shouldn't use. But then my trainees asked me, why can't we use it for bridging? Because remember, balloon used to come out for bridging these patients to become anesthetically safe before we actually do the surgery. Again, data is out there, and really it doesn't show much difference between the two. So my take on Botox really, is it safe? It really is safe. You can do it even in the outpatient setting, let alone you need an endoscopy unit for it. But it doesn't work. It's ineffective. I think it's a waste of time. And for patients who end up paying for it, it's not really effective. Then come the gastric balloons. They are now NICE approved. And I actually do think that this is an effective option still for our patients, particularly for a bridging, and the second group of the patients where they actually can use it now that you have a 12-month balloon as well. Okay, Orbera was the first balloon that we started using even in the UK for our fatty liver patients. So we have a lot more comfort. Orbera, as you all know, it's an endoscopically put balloon. Initially, it was about 6 months. And my partner in crime, Jude Oban, from Guy's and St. Thomas's, he did studies on liver disease, and he has actually found out that almost 30% needed an extra 6 months. So we went back to these and said, can you not do 12 months? And this is where it changed. So you now have a 12 months Orbera balloon. Part of the problem, it's go in endoscopically, it comes out a year later endoscopically. What does the data tell us? 17 studies. And if you look at the mean weight loss is about 25 kilos at 12. This is really, really great. Yeah, 25 kilos at 12 months. What else can you ask for? But 1 in 3 would regain that back. That's the downside of it. So just keep it in mind. Alorion is another novel technique where you do not need endoscopy. This is a balloon that you can do in your clinic. You're talking to your patient, you give them as a pill, they swallow it down with a glass of water, that you just take an X-ray to make sure it's gone down, and then you connect it to this, and it will happen. So we, at King's, we do it in our clinics. Really, they go down to have a quick X-ray, and then they come back up. Very simple. Patients like it. It's about 4 months. Problem kya hai? If you look at the studies, and you will show it's very effective. Look at the BMI range that they tried this on. There are about 1,700 patients in this group of cohorts. Very effective, no doubt. Look at the weight loss. Almost 13 to 15 kilos. And after 4 months, you do nothing. It gets dissolved, it finishes itself. So your patient never needs endoscopy. That's the benefit of it. They swallow it in the clinic, and after 4 months, it just gets dissolved. So you never need to do anything. So it's very effective from that point of view, reassured. But, caveat, it needs a very strong team. You need a dietetics, you need a psychological support. You do need to follow these patients for 12 months. Not you as a physician, but of course your team with the dietetics, your psychologist, and your physiotherapist. Okay, that will take me to the last part of the talk, which is endoscopic sutureplasty. We're not doing bad for the time. So what is endoscopic sleeve? Where we leave the fundal part because it's a very thin part. We tend not to suture. All that's what the rest of all we will stitch. What's the technique involved? So you have a first U, that starts from the antrum. Then you have the second that takes the corpus. And now increasingly, particularly recently, we're now using reinforced technique, and I have started using certainly some fundus into it. I wouldn't suggest you guys would, but I'm sure as you do more and more, you'll get comfortable with it. So this is Catherine's sleeve. I'll quickly show you. So that's the stomach before we started. You can see the incisura there. So the left tower is where the needle is, and the right tower, which is at 5 o'clock, that's where the cinch or the suture will come out. So trainees in the audience, if you have a full thickness bite, and the second, if you have cinched the suture properly, your patient will lose weight. There's no doubt. Failure of ESG or endoscopic plasty is based on two things. A, the lack of team that provides support, and B, in the technique, these two problems. As long as this is full thickness, and as long as you have cinched it right. So as you can see, this is the first U as I'm making along as we go. So we've done the first limb, and now you will see that now I'm start coming back, as you can appreciate. So that's the first U as we're going back. How long does it take? About 40 minutes. And as more you do it, the better you get. Patient stays in hospital for about one night. At King's, we keep them for one night because that's pretty much standard practice. There was one patient of mine who did manage to escape the same day because she had a cat at home that she needed to look after. People have preference, people have priority. So this is I'm cinching. So now just wait. Look at the right side of the screen. That's the bottom of your sleeve. Look at that hole, how small it's becoming as I'm cinching it. Cinching means I'm pulling it and now cut. So I've cut it. Now I'll just show you the right side. This is now your bottom of the sleeve. Look at the small hole. And now I've moved on to another. I think in the interest of time, I'm getting dirty looks from Zishan. I'll just move it very quickly. So this is now, I'm right at the top. I've just fast forwarded to you. This is a reinforced technique. So what reinforced technique is, we now know that as much as the lower half of the sleeve tighter is good, the upper mouth tighter is, so we reinforce. I mean, this is what it is. As you can see, I'm now finishing the sleeve. I'm right at the top end, and all I'm trying to do is just tightening it. So in a second, when I'll close the sleeve, you will see okay, so I'm just going to take the last bite from now completing this through. So this is a reinforced, as you can see, this bite is now taken from the fundus. So in the reinforced technique, we really come, so we leave about 4 centimeter from the GOJ. And in a minute, I'll show you the barium follow through for this patient as well, so you'll completely understand what I'm talking about. So can you see that's the far end of the sleeve, right over there, and this is the mouth. Yeah? And in a minute you'll see when I start cinching it, so there you are. Yeah? As we start pulling and closing it, that now becomes the mouth of the sleeve. And the bottom is here. So this is the whole sleeve. The length of this is about 12 centimeters, so very decent size. And in a second you'll see the GOJ at the top, which is about 4 centimeter. So that's the beginning of the sleeve, and this is the barium follow through for the same patient. So you see the fundus at the top, and that's the entire length of the sleeve. So the reinforces, we make the mouth tighter as well. So that's on the left hand side is Catherine before, and on the right hand side this is afterwards. You can see the difference. Does this work? So this is the first time that we've actually been able to show reversal of fibrosis with that sort of weight loss. So the follow-up for 2 years of 118 patients who had a sleeve done. So total body weight loss, insulin resistance, and fibrosis we looked at, and all accounts have shown improvement, including fibrosis. This is Catherine at 3 months follow-up. Her fibrosis score, her HbA1c, everything had reversed, because she has managed to lose about 24 kilos. She actually sent me a text about 2 weeks ago. She's now lost 28 kilos, and she's almost 9 months into it. The last slide is this pathway. Any one of you want to take a picture? If you want, this is the pathway that we guys use in our center. This is how the metabolic medicine pathways should look like. It's a team, guys. Honestly, this is not, I am not relevant here. Procedure is not important here. It's the team. And if you can develop team, develop programs. That's where patients respond to. I'll finish it here. Thank you very much.
Thank you, sir, for the wonderful talk related to the endobariatrics. Without wasting time, next, I would like to invite Dr. Salman Khoso. He will be talking about little patients, big strides, developments in the pediatric steatotic liver disease. Sir is an associate professor at the DUHS Karachi. He did his FCPS in the pediatrics from Aga Khan University Hospital. Then second FCPS in the pediatric gastroenterology and hepatology from the Child's Hospital and Child Health Sciences University Lahore. He has total 6 publications at the national level. Sir.
Assalamu alaikum everyone, and thank you very much be a part of the Pakistan Society of the Hepatology. I am here to describe about the steatotic liver disease in the pediatric population. It is not only the burden of the adult, but is also now increasing in the pediatric population also. The objective of my presentation are in definition, incidence and risk factors, pathogenesis, how to approach and management in the follow-up. We know all about the fatty liver disease. It's the accumulation of the fat in the liver. And it is a chronic, then we call it as NAFLD. In new terminology, is a metabolic liver disease. And these are some other terminologies is usually used also in same as in the adult. And the close association of obesity with fatty liver. It's a burden also in worldwide and also in our population in Pakistan. We will go through for next slides. Guidance is needed for the clinical care decision of the pediatric population. What world says, near about 0.7% of children between 2 to 4 years of the age having incidence percentages of fatty liver disease. It's increased up to 29 to 38% in obese children or in overweight children. It's increased near about 2.7 fold of from 1980 to 2010. The boys are more having percentage than the girls, and we see that white and Asian children have higher percentages than the African and American children. But remember, not all obese children develop fatty liver disease. And the world says that the America has 40% along with Australians, and we have also a burden. In Asia, we have also a burden of near about 30%, and Europe, then the Europe and American. Where we are, हम कहाँ पे हैं? हमारे पास है नहीं है, हम तो poor country में आते हैं. हमारे पास है 4 out of 10 children under the 5-year age are short, छोटे हैं. One is approximately 6% are wasting में है, and 1 in 3 underweight, and 1 in 10 बच्चा, हर 10 में से एक बच्चा हमारा overweight है, और हर जो है 16 बच्चों में से हमारा एक बच्चा obesity में है. The prevalence of overweight among the 5 years of the age is doubled over the 7 years. In Pakistan, this is a 2018 data. The increasing from 5% to 10% in 2018. This is the prevalence of the malnutrition under the 5 years of the age. We have 40% are short, 17% are wasted, and near about 30% are underweight, and we have 10% of the burden in our population. Depending upon the locality, this disease is not only limited to urban area, it's same figure and also in the rural areas. Despite of undernutrition, we have a lot of burden also in the rural areas in our population. Dividing in the province, we have higher percentage in the KPK and also in the Balochistan, after that in the GB, and then the Punjab, and then the Sindh province. This data is from national guidelines of the Pakistan in 2018 that show that higher incidence in these 3 provinces. According to the male and female, male are somehow higher percentage in the overweight and also in the obesity. near about in girls as 9% in overweight, and you will see in the boys that is 11%, near about 12%. So the boys are more prone to develop the overweight. How to screen and whom to screen? Risk factor, familial risk factor like parental nutrition and parental obesity, family history of obesity, and also maternal obesity. These are the important risk factors in the children, and also the gestational diabetes and male gender. And there is some genetic association also with the children's, and postnatal factor like excessive consumption of the fructose, as discussed earlier in the presentations, and also the breastfeeding less than 6 months of age is more culprit for developing overweight and obesity in our population. And also the metabolic syndrome, some like obesity and insulin resistance, and also gut microbiota have a definitive role in developing the fatty liver disease. We should screen all the patients, all the children who have BMIs greater than 95 percentile and overweight like 85, BMI lies on 85 to 95 percentile, and additional risk factor like earlier discussed like insulin resistance, dyslipidemia, and obstructive sleep apnea, and also the parents having history of or sibling having history of fatty liver disease. And what is the pathogenesis? We know all about the pathogenesis. Once the inflammation is started, then trigger the immune system of the liver that will lead to hepatocyte injury and inflammation, that will lead to the hepatocyte apoptosis and activate hepatic stellate cells that make the fibroblasts and finally develop the fibrosis and cirrhosis. If a child is present with you with recurrent abdominal pain or have firm hepatomegaly like 3 to 4 centimeter, having ALT of near about 50s and 60s, should go for screening of the fatty liver disease. The screening tool is, we know that ALT is a screening tool, and then the ultrasound abdomen and lipid profiles also. Liver biopsy have a definitive role in this to distinguishes either there is an ongoing inflammation or a fibrosis or anything, but the CT scan MRI having no role in the pediatric age group. This type of fibroscan, and it's a good thing. I don't know about the Punjab, but in the Sindh, we are doing a fibroscan even less than 1 year of the age of the group in Dow University. So in the assessment of, and also we will go for the assessment of the steatosis severity. According to our scale, there are 4 scale. We know all about that. Less than 5% of the hepatocyte is normal, and greater than 5%, that is 5 to 30%, is scale 1 in grade 1, and from 35 to 66 and above the 66 accordingly. This is the natural history of fatty liver disease. Once the steatosis has been occurred, it will lead to the inflammation and advanced fibrosis. There is a 2 pathway. Either go for the cirrhosis and then ultimately hepatocellular carcinoma, but I never saw any case of hepatocellular carcinoma followed by fatty liver disease. And it's right that we, in the pediatric, we do not have any data to according in NAFLD also. So that's why we cannot commit on the pediatric population that how much percentages of the hepatocellular carcinoma and fatty liver disease. Lifestyle is most important. Component of the lifestyle is energy restriction, like calories should be 50 to 1,000 per day, and approximately 7 to 10% loss of the weight should be focused on our management. And long-term approach is also important. Alcohol is not mainly used in the pediatric population, and fructose, avoidance of the fructose, avoidance of the juices, avoidance of the candies and gums, that they have a lot of fructose. So this should be stopped immediately. And also for the macronutrition supplementations like low fat diet and moderate to high carbohydrate, low carbohydrate ketogenic diet and high protein diet can help in the pediatric population, because we do not have approved any medications in the pediatric population that we can use in adult populations. Physical activity is, yes, very important. 150 to 100 minutes per week, moderate intensity in 3 to 5 sessions. So it is also important. Diet and life, greater than 7% of the weight loss have a significant effect on the liver enzymes and histology improvement. The patient without NASH or fibrosis should receive counseling for the healthy diet and physical activity, but no pharmacology. Remember this. Pharmacotherapy is basically used for progressive NASH, an early stage of the NASH with risk of fibrosis progression, and active NASH with high necroinflammatory activity. But there is a limited data in the pediatric population. We mainly do not use medications until unless we have proven for the biopsy that the child is going into the fibrosis. For insulin synthesizers, little evidence in the histology effect with metformin, and pioglitazone is better than placebo. Vitamin E has somehow role for antioxidant, and but lipid lowering agents are not mainly used in the pediatric population. Now follow-up. Yearly visits should be done to see the disease progression and the treatment. Nutrition counseling is a starting point, and physical activity is also the starting point of the treatment, and should be focused on also in the follow-up with the and monitor for the weight reductions, and also limit the sugar intake and dietary. No concern for low fat versus low carbohydrate diet. These somehow controversial in growing children's. Physical activity should be done in the first line of the treatment. Exercise is believed to improve the NAFLD, and 40% of the activity 5 days a week should be done in the pediatric population. Medication has no role, I already mentioned, but the bariatric surgery, this is the adult data basically, this is not a pediatric data. The bariatric surgery should be done for child, if any, having a BMI greater than 35, and also screen for dyslipidemia and type 2 diabetes mellitus. Blood pressure monitor should be done. Thank you very much.
Thank you very much, Dr. Saman, for a great talk related to the steatotic liver disease in pediatric population. As we are running short of time, I would quickly move to the respected chairpersons to share their views, please, about this session.
Thank you. Thank you very much, Dr. Ravi. Excellent presentation from all the three speakers. Dr. Zishan and Dr. Salman has defined the adult and pediatric MESLD or disease very well. And Dr. Zishan has said that every third person is having MEFLD, which is alarming. And the catch is, if we treat these problems at the early stage, the reversal is there, the reversal of fibrosis and to prevent cirrhosis in this patient is there. Again, Dr. Farooq has presented excellently the endoscopic management of MESLD, and that was a very good presentation. And I'm really impressed with the way he did the sleeve gastrectomy. So my message is for all of us and for the junior consultants, think about MESLD, don't take it lightly. It is the disease of the today and the future, and one has to act promptly to deal with these problems. Otherwise, we will end up with cirrhosis, as we end up in hepatitis B and C in the past. So with this, I conclude this session. For final comment, I would like to ask Dr. Nasir to give his valuable suggestions.
I think the message is it's a multidisciplinary approach disease, and a team building has to be taken into consideration, and the eloquence of treatment lies in patient motivation, for which a psychologist and continuous motivation for the patient to decrease weight, because the pathophysiology is enigmatic and the treatment is very expensive, will be very expensive, the pharmacological treatment. And I think we should be prepared for the future.
Thank you. Very comprehensive and well elaborated talks by the speakers. I would suggest there should be endoscopic bariatric fellowship program that should be started in Pakistan as soon as possible. So thank you for leading us through this thought-provoking discussion. Your insights have been invaluable. Thank you.
So session is concluded. So thank you, Dr.
Thank you very much, the respected speakers and the chairpersons. If I may request the chairpersons to please come forward for the picture. So we are end up with the session, and the next session would be the fifth session of today's, and I would like to invite Dr. Abdul Latif Rodini to please come in the stage and take on from here.
Respected panelists, guests, ladies and gentlemen, Assalamu alaikum. I am Dr. Abdul Latif, working as a consultant gastroenterologist at Sheikh Khalifa bin Zayed Hospital. It is the fifth session. I am going to moderate it, and which is a state-of-the-art lecture on MESLT. Our speaker is Dr. Bilal Ahmed. He is a professor of medicine at University of California. He is liver transplant physician. He will give his virtual talk on diagnosis and management of MESLT in 2024. Now, without further delay, I like to call our chairs to come on stage. Our first chair is Dr. Professor Muhammad Arif Nadeem. He is HOD of Medicine and Gastroenterology at Services Hospital. He is a supervisor at various universities. He is a writer of many articles. Our next chair is Professor Arun Yusuf. He is Professor of Medicine and HOD of Gastroenterology at Shalimar Hospital. Our next chair is Dr. Abdul Malik Achakzi. He is a consultant gastroenterologist at Bola Medical College, working as an assistant professor there. Our next chair is Dr. Arslan Shahzad. He is AP and GI HOD at Fizaiya Medical College Hospital, Islamabad. Today's talk is virtual. Please start.
Assalamu alaikum. I would like to congratulate the organizing committee led by Dr. Daud and the president of PSH, Dr. Asad Chaudhry, on the 24th annual PSH meeting. Unfortunately, I am not able to travel, but inshallah next year for the 25th year meeting and celebration, I will do my best to be there in person. It is also my honor to be invited again. I think this is my 7th year constantly having a talk at PSH, and I'm very humbled and the love and respect giving to be by the PSH and the organizing committees. The topic today is diagnosis and management of MESLT in 2024. These are my disclosures. The outline of my talk in the next 30 minutes is to discuss briefly about new nomenclature, which most of you are already aware about. There are some guidelines from ASLD and American Endocrine Society about how to identify these high-risk patient population, and then management of MESLT, and talking a little bit about mostly lifestyle, but mainly about the new treatment and where the field is headed, especially now we do have the first FDA-approved medication, resmetirom, and how are we thinking about using this medication and how the future holds. So last year, after an extensive Delphi process, ASLD, EASL, ALA, and other organizations combined together came up with a consensus of changing the nomenclature. The revised nomenclature highlights the critical role of metabolic dysfunction, Now, most of you are aware that when the name NAFLD or NASH was coined, it was less understanding of the multi-system impact of the disease did not reflect the disease etiology because these disease looked like more alcohol and the name non-alcoholic was coined at that time. It does have a lot of stigmatizing language, including the word alcohol as well as fat into it. The new nomenclature, which now is MASLD, it is mouthful metabolic dysfunction associated with steatotic liver disease, and MASH is the new NASH, which is metabolic dysfunction associated steatohepatitis. So MASLD or MASH is defined by the presence of hepatic steatosis either by imaging or by liver biopsy with only one cardiometabolic risk factor requirement. So rather than having a diagnosis of exclusion where you have to rule out all the other things, any patient with evidence of steatosis and one cardiometabolic risk factor can be called MASLD or MASH. Now, under the umbrella of steatotic liver disease, there are other etiologies which many of you are aware about. So beside the MASLD, one other distinction of this new nomenclature is to highlight an entity that we were seeing more and more, which are patients who have MASLD and increased alcohol intake. These are not the patients who have alcohol-associated liver disease, but these are the people who were drinking alcohol on average 20 to 50 grams in female and 30 to 60 male. And this entity we call MET-ALT. Now this field has increased more attention for not only research and identification in these patients. So many of you who are going to come to ASLD, there will be a session we are arranging as a community session for MET-ALT and identifying these patients and how we manage these patients. And there are a lot of research papers who are coming in. Obviously, the steatotic liver disease umbrella does include the specific etiology of SLD, which are drug-induced. There are many liver disease like medication like tamoxifen and steroids. Amiodarone can cause it. And then you have this cryptogenic SLD, where maybe there are some patients with lean BMI, which does not have metabolic risk factor, can qualify. But overall, the new nomenclature that we are using is MASLD and MASH for NASH or NAFLD. Now, also, when you look at the metabolic syndrome criteria or adult criteria, you only need 1 out of 5, as I mentioned earlier. So either you have a BMI of greater than 25 if in Western world, but 23 for Asian, or increased waist circumference. You have diabetes or increased fasting glucose or medication for type 2 diabetes, high blood pressure, plasma triglyceride, or plasma HDL, which is low. And same thing that came out for the PED. So if you have a child with this, you only need one of these criteria for metabolic to qualify someone to have MASLD. And as I mentioned before, this is now diagnosis of inclusion then exclusion. Most of you are aware about the increased prevalence of MASLD worldwide, which is up to 30%. Overall, 1 billion people have evidence of MASLD. MASH is present about 25%, and out of these patients, expected about 9 to 10% or 22 million have advanced fibrosis. If you see all over the world, the prevalence is increasing, especially in Middle Eastern countries and South Asia, but Asia Pacific area are also slowly increasing. And if you look at Pakistan, the prevalence in South Asia and India is about 33%. So this disease is not considered to be a Western world disease. It is present in all over the world at this time. Now in the US, this prevalence has expected to increase. We feel about close to 27 million people with MASH, and 30% of these people with MASH are projected to progress to advanced fibrosis, which we defined as F3 and F4. Now, many of you know there are many different parameters of MASH, but fibrosis is the single most important determinant how liver will get long term. Now, when we look at the risk of fibrosis and other, not only we feel like with advancing fibrosis stage, the risk of overall mortality is increasing, but the cardiovascular mortality also increase with the stage of fibrosis. So someone with early F0 and F2 fibrosis, the cardiovascular mortality is lower as compared to 4-fold higher if you have F4 fibrosis. So not only the overall mortality is increased, the cardiovascular mortality is increased with the stage of fibrosis, and same with the liver related. Obviously, if you have cirrhosis, then the outcomes of liver transplant, of complication of cirrhosis hepatocellular cancer, need for liver transplantation, death certainly increases. So as many of you are aware, fibrosis stage is the single most important determinant of mortality and cardiovascular as well as liver-related mortality in patients with MASH. We also have some new guidance document in the last few years, and one was the ASLD practice guidance, but also American Association of Clinical Endocrinology and ADA have guidelines that patients who needed to be screened for certain risk factors. In the past, the screening for general population was not recommended, but recently, based on the newer data, there is a high-risk population that are recommended to have fibrosis screening for in patient with MASLD or MASH. The first group is patient with type 2 diabetes, and the risk of clinically significant fibrosis defined as F2 to F4 can be up to 20%. Patient with obesity up to 22%. And the two important group that we don't pay too much attention is again that MET ALT patient who have combined MASLD and alcohol. 18% can have clinically significant fibrosis. And the other group is patients who have first degree relative with MASH cirrhosis. And that's the other group that I always wanted to pay attention, because if we have a patient in my clinic or patient admitted to the hospital who have MASH cirrhosis, I am recommending that their first degree relative should be screened for fibrosis. And this is something I wanted to make sure that if you have a patient in your practice with MASH cirrhosis, you should consider and talk to them to have them screening. Now, the question is, how do we screen? We did talk about like what are the clinical assessment tools that are available at this time. And the risk is pretty long, and we divide them in clinical laboratory tests, which are simple. And although the simple, in the past, FIB-4 index was calculated, and also the NAFLD fibro score, but the most important in all the new guidance document, FIB-4, which is much more easily available, and I'll discuss in the next slide. And the second one is the complex, which are available by blood tests, and there are many of these are available, and the list are growing, but the one test with the ASLD and have been gained more attention is enhanced liver fibrosis, or ELF score, which has been approved in the US by Simmons Company. Now, we also know about imaging to look at the elastography, and the most common with the point of care is FibroScan and vibration controlled transient elastography, but we do have availability of MR elastography, but expensive and also not easily available. So non-invasive tests have become the first line tools for ruling out fibrosis. The first is when you have a patient with identify at risk of fibrosis, as I mentioned, anyone with type 2 diabetes, obesity, MET ALT, or first degree relative with MASH cirrhosis, we have non-invasive blood testing for fibrosis, and the tier 2 is liver stiffness measurement. So these are the two ways that we are. The first tier is how do you identify with non-invasive, and countries like Pakistan, and even in our primary care setting, what we are recommending is checking FIB-4. And this is based on, this is not the test which is 100% accurate, but this is the best data that we have, and most of you aware the FIB-4 has 4 components: age, ALT, AST, and platelet count. And if you have the number, I would recommend remembering is cutoff is 1.3. Again, in patients who are younger adult, older, or diabetes, they can be a little bit different. So if someone has less than 1.3, you can rule out advanced fibrosis. And if someone has greater than 2.65, we can say they are rule-in, and there many patients will be in the indeterminate range. However, if you have a patient with a FIB-4 of less than 1.3 or 1.3, you don't need any further testing or fibrosis assessment, and you can. So many patients you see in your general practice or your liver clinic, if they have diabetes, if you have obesity, family history of MASH fibrosis, you should do the FIB-4 as a start. Now, if the FIB-4 is elevated in the indeterminate or high probability, the next step is to look for with a FibroScan test or VCTE. And the number to remember that puts patient at the risk of F2 or higher is the number to remember is 8.0, right? If patient has a VCTE of less than 6, they don't have any fibrosis. 6 to 8 is early stage 1. And then I remember 2 is the number 6 to 8, 8 to 10, and then if you have 10 to 12 or 14, then you have F3. And cirrhosis is varies from different to different, but some say it's like, but cutoff of greater than 14. Now, the advantage of FibroScan is you can also calculate the steatosis amount, and the different numbers are out there when you say steatosis, but this is the number for fibrosis assessment is 8.0. So this is an important thing to remember and use it in your practice. And I know that many places in Pakistan have the availability of FibroScan, which can be used to detect fibrosis, and these are the cutoffs to remember. Now let's, before talking about the management, it will be good to review a case presentation. This is a patient I recently saw, 47-year-old with MASLD, very social alcohol use, has an history of elevation of ALT and AST for the past 5 years, but when he came to see me in the clinic, the ALT was 60 and ALT was 90 and AST was 60. Already had workup done for other causes of liver disease, and this is important that although if patient does have normal liver enzyme, except for wild hepatitis, we don't, but it's still, if someone has elevation liver enzyme, you need to do workup for other causes of liver condition. And on the testing, as FIB4 was 2.7, so greater than 1.3 and greater than 2.67 put him at an increased risk of advanced fibrosis. He had a VCTE done, which showed a median KPA of 10 KPA, and the CAP score was 340. So consistent with severe steatosis and advanced. So most of the time we don't need a liver biopsy, but because of his history of elevation liver tests, he already had a liver biopsy before he was referred to us, and the liver biopsy had shown grade 3 steatosis, had steatohepatitis, and stage 3 fibrosis. The patient already had advanced, only 47 years of age, past medical history of type 2 diabetes, obesity, and dyslipidemia. Only medication he had is atorvastatin and metformin. And also when he told us the mother was diagnosed with MASH cirrhosis. So this is the classic picture that we see many of patients like this, and this patient is advanced. So the question is, how do we manage this patient, right? And how do we think about? So obviously patient already have F3 fibrosis, and one of the things we wanted the patient to have regression of the fibrosis, have biopsy proven inflammation with MASH. So when we improve the inflammation, it improves the fibrosis because it's a marker of fibrosis. Inflammation, and there is good amount of data that the improvement of the NAS score or inflammation will help with the fibrosis improvement also. Since his risk factor of obesity, if we help with that, it improves the metabolic state. Type 2 diabetes, we have to address the glycemic control and dyslipidemia, that we need to have treatment that not only address or at least do not worsen the atherogenic risk, right? So this is important to understand that when we are treating these patients with MASH or NASH, every treatment has to be protective for the heart, and it has to have a holistic approach, making sure all the other medications are helping the patient with the improved cardiometabolic benefit. So therefore, when you look at the ASLD guidance document from 2023, it does bring up an important multidisciplinary approach, and it may not be that helpful in Pakistan because many of the time, as a hepatologist, you need to take care of many of these patients, become their primary care. But in the US, we do talk with the endocrine and primary care. We have access to nutritionists and lifestyle intervention. Obviously, patients with advanced liver fibrosis or more fibrosis or cirrhosis need more hepatology and gastroenterology care. But at the same time, we need to have access to weight management. We need to make sure patients, if they need a bariatric surgeon, how do we access to it? And importantly, a cardiology, preventive cardiology and lipid management. So you have to view the patient holistically. Polypharmacy is very common in these. There's some patients need a psychologist. And at UCSF, we are thinking about this precision metabolic clinic where a patient can see an endocrinologist, hepatologist, preventive cardiology, and nutritionist, and possible weight management expert during the same visit if possible, who are high-risk patients. Now, weight loss, we always talk about, and there are different diets, especially low carbohydrate, low calorie, or Mediterranean diet have shown, but weight loss have shown to improve multiple component of MASLD, not only steatosis, NASH resolution or MASH resolution, as well as fibrosis. And the number we talk about is 7 to 10%. But if you have a patient who lost 10% of the body weight in this very impressive study of 52 weeks of lifestyle intervention. Many of the time you have seen these studies in different talks that NASH resolution or MASH resolution can be achieved up to 90% of the time if you have 10% of the body weight. Fibrosis regression can happen up to 80% and steatosis almost 100%. But the problem is, despite all these tools that were provided in this intensive lifestyle intervention arm, only 10% of the patient were achieved that 10% weight loss. So it is, and then many of these patients in other studies have shown that the weight gain is still a major issue. And this has been shown in other diabetic literature that patients, it's hard for them to lose weight and even harder to maintain it. So although weight loss is important, but we need to provide the tool to the patient and has to be culturally sensitive about what kind of a diet your patient is taking, which is because the diet which is recommended by EASL or ASLD may not be good for our Pakistani population, and we need, as a PSH or from other societies, come up with more MASLD or if you want to call it MAPLD, but MASLD lifestyle recommendation based on Pakistan culture and the diet. Now, importantly, things have changed in the weight loss because many times when I used to see patients, just the case I presented, we start with a lifestyle modification and patient is not able to do it. We talked about the weight loss surgery and now we are using more vertical sleeve gastrectomy and some patients need a Roux-en-Y gastric bypass. But now, since in the last 4 or 5 years, we do have access to these amazing anti-obesity medication, which have shown a significant result. And many of these have been, at least semaglutide has been used. Even American GI Association AGA has new guidance document for management of obesity, and they do talk about that in adult with obesity or overweight with complication, recommend adding pharmacological therapy sooner. And they are recommending, or at least semaglutide, and at that time the tirzepatide was not available. So even for obesity, there is a whole push to start these anti-obesity medication early on. Now, many of you have looked at the data, but many different studies were done on semaglutide and the weight loss. And the data has been pretty impressive. And in this study, which was in New England Medical Journal in 2021, if you look at the semaglutide arm, more than 10% weight loss was achieved close to 70% of the patient, and 32% patient had more than 20% weight loss. And this has changed how we are thinking about obesity, diabetes, and even in our patients with MASLD. Now, there was a phase 2 clinical trial that was published also in New England Medical Journal using semaglutide in patients with MASH. And the primary outcomes were resolution of MASH or NASH with no worsening liver fibrosis and improvement in liver fibrosis with no worsening of MASH. So clearly there were 3 arms of the study, and the 0.4 milligram of semaglutide were clinically significant in improving the resolution of MASH or NASH with no worsening as compared to 17% in the placebo arm. Now, the study did not have seen clinically significant change in the fibrosis improvement, but when you look at the study in more detail, there are less patients who had progression of fibrosis. But based on this, semaglutide just finished enrolling their phase 3 clinical trial, and we are waiting, and hopefully in the next year or 2, we will have started hearing some preliminary results. And I'm hopeful that this will be approved in the future as one of the additional therapy for MASH, which is in addition to FDA approval of diabetes and obesity, it will be approved likely for the MASH also. Now, the field is growing. Now, there are many different medications that are on the horizon, and I'm going to just show you this triple agonist data of GLP-1, GIP, and glucagon receptor. And if you look at this study, which was also published in New England Medical Journal last year, that in 48 weeks, about many patients have, weight loss up to 24% with average weight reduction in this arm of the study of 12 milligram, which is so impressive. And also, Arun Sanyal did presented an abstract last year where the subgroup of these patients also have shown significant improvement in the liver fat content, and this is impressive, about 82% improvement 82% have improvement in fat reduction. And so this is another agent that you will gonna be seeing for weight loss, for diabetes, and potentially for MASH. Now, there is clearly a more cardiovascular benefit of these medication. There were multiple studies have done, and this is the data from SUSTAIN study where patients on semaglutide have shown cardiovascular benefit for MACE, myocardial infarction, stroke, and cardiovascular death. And this is a very impressive. So more and more, utilization of these medication in our diabetic and obese population have also shown the benefit in that one. Now, so this is something that we are using, but there are still some patients who have morbidly or class 3 obesity and not everyone will tolerate these medications. The bigger problem in the US is access to it. It's expensive. Not all the insurances are approving it. So we still have patients that we, prescribe, but they don't have, or there is a demand is so high. And there are still a group of patients that we recommend bariatric surgery. And this is French data, which you have seen also. They have very impressively followed these patients, mostly Roux-en-Y gastric bypass, and have shown that at 5-year mark, patients who had lost weight after bariatric surgery has a resolution of MASH or NASH up to 84%, and also fibrosis improvement up to 70%. So one of the things that not only early on, this improvement after bariatric surgery can persist up to 5 years. So there is a selected group of patients which will be benefited for bariatric surgery, but you need to consider before they develop cirrhosis to be more benefit out of it. Last year, it was an amazing study that was published in Lancet about a randomized controlled trial of lifestyle modification, Roux-en-Y, and sleeve gastrectomy. And you can see, again, the primary outcome of NASH resolution without fibrosis or improvement of one stage. It's like at 1 year follow-up, you can see 57% in both arms, the sleeve gastrectomy and Roux-en-Y as compared to 16 in lifestyle modification improvement. And they are going to publish their ongoing, because although the fibrosis improvement was not significant, but it's only 1 year, and the follow-up study likely will going to show improvement in fibrosis. So histological improvement at 1 year is significant by these, and sleeve gastrectomy as good as Roux-en-Y gastric bypass. And there was a study from Cleveland Clinic looking at the patients who have long-term outcome effect and other things, but patients who have bariatric surgery had also, important decrease in the incidence of liver and cardiovascular adverse events. So these have far prolonging benefits after the weight loss. Therefore, at ASLD guidelines, bariatric surgery is recommended as a therapeutic option who meets the criteria and also reduce mortality from cardiovascular disease and malignancy. Now, when we look at the other term that you will gonna look at for the pharmacological treatment. So there are patients who will decide the lifestyle changes and other things will need more pharmacological. And the word we are using is early at-risk MASH. So these are the patients who have F2 and F3 fibrosis with inflammation. And these are the patients we feel are the highest risk of progression to cirrhosis. And that's where the whole focus on identifying these patients. And these are the group of patients who have been enrolled in the clinical trial. So this is a busy slide, but it just tried to explain some of the pathophysiological pathways for the pharmacological medicine we have available. So we have medication targeting insulin resistance, and some of these medication, including GLP-1 semaglutide, the FGF21 agent, and resmetirom we'll talk about. Then we have targets related to lipotoxicity and oxidative stress. The phase 3 is lanifibranor. Unfortunately, obeticholic acid did not reach the significance that needed, and the company decided to terminate the clinical trial. But there are other agents, including targeting inflammation, targeting apoptosis, and ultimately the saving grace or the ultimate, holy grail of liver disease would be reversal of the fibrosis. And their different combination agents have been studied in this regard. Now, there are also a lot of off-label medication until we have the approval of first FDA medication, which are still there and has some utility. We're still using vitamin E in patients with MASH, but no fibrosis or early fibrosis. And the dose we are using 800 IU per daily. In fact, we just finished enrolling for a clinical trial uh, using a dose ranging study of vitamin E 200, 400, 800 versus placebo. It's again an NIH study, and we will share the results hopefully next year if we become available. Bioclidazone is also a good medication. The only problem with bioclidazone is the weight gain. And so, but there are patients with a lean BMI you can consider with type 2. However, the GLP-1, the liraglutide, semaglutide, tirzepatide has been changed the field of off-label use, and we are using many patients which are approved for diabetes and obesity right now. And also the SGL2, blockers have been also FDA approved for diabetes and have a cardiac benefit. So patient with diabetes, we are using or recommended by endocrine to start these medications. But the most important thing since early this year in March was the approval of resmetirom, which is thyroid THR beta agonist. This is basically the concept is that THR beta agonist selectively liver targeted molecule, which is administered once a day, and it decreases the R3 inactive and increases the free RT level. So in clinical trial and other studies, it has shown the resmetirom lower the liver fat, potentially reducing the lipotoxicity. It's improved inflammation, lower LDL, and lower triglyceride. So this was more liver specific. So THR beta agonist, which is liver sensitive, was being in phase 2 trial have shown. But the phase 3 Maestro NASH trial, which led to the approval or conditional approval of this medication, the trial did include 3 arms, placebo, 100 milligram and 800 milligram. So you can look at so the data which was presented at week 52, which is the primary endpoint histological data, but the trial is still ongoing to look at the long-term outcome. The inclusion criteria did require metabolic syndrome with 3 metabolic risk factors. The FibroScan KPS score was consistent F2, F3, and fibrosis stage was stage 1. Very few patients, mostly 2 and 3, or greater than 10% liver fat. And so this was the most important, what was the primary outcome of NASH or MASH resolution of fibrosis improvement. So if you look at this data, placebo arm has 10% as compared to 26%, 30% with 80 or 100 milligram of resmetirom. In addition, there is a trend also towards the fibrosis improvement and was statistically significant of fibrosis improvement by 1 stage. Although you can argue it's 14% in placebo versus 26, but this was the first time it is shown. And I wanted to dedicate also or remember Dr. Stephen Harrison, who unfortunately passed away very early after the publication of this trial or approval of this medication. But he's a giant in this field and, was responsible for many of these amazing clinical trials. So based on this, it led to approval of resmetirom as the first FDA medication for MASH. Now, it is overall well tolerated once a day, and mainly patients have diarrhea and nausea, which also gets better. And also as compared to other medication like obeticholic acid, the risk of pruritus is very low. Now, there are other medications which are also in the phase 3 clinical trial, and we'll hear more and more of this data. There would be some late-breaking abstract during the ASLD. But besides resmetirom, which is still ongoing, is lanifibranor, the denifanstat, and then we already talked about semaglutide, but there's FGF21, and also there are other medication, and I wanted to do mention survodutide, which just had the New England Medical Journal article published by Arun Sanyal. So very unique, and as you know that beside the GLP-1, sorry, if I able to unshare the slide. So the survodutide is a dual agonist for GLP-1 and GIP, and which is a glucagon receptor. So this phase 2 clinical trial have a different arm of 2.4 milligram, 4.8, and 6.0, and placebo arm of close to 70 patients, mostly biopsy proven MASH with fibrosis F1 to F3. So what the data have shown is that MASH with no worsening fibrosis, and it's pretty impressive result that you can see up to 43, 62% as compared to placebo of 14%. But even with the short period and also the significant decrease of steatosis by liver fat by 30% was very significant in all three arms, 2.4 and 4.8 as compared to placebo. So this is also a very exciting molecule, and I think that will also be available once the phase 3 clinical trial will be done. So this field is expanding, and it looks very, very promising. The question is, what do we have available in Pakistan? So GLP-1 is definitely, which are off-label right now, and we don't have resmetirom, but hopefully in selected patient, it will be available. It is expensive medication, and we are just learning to use this medication in the US. But for summary, the guidelines support screening key subgroup population which are high risk, and we talked about patient with type 2 diabetes, patient with obesity, patient with met ALT with alcohol and fatty and MASLD, as well as first degree relative with MASH cirrhosis, worsening fibrosis or advanced fibrosis associated with increased mortality. MASLD is a part of multi-system disease and need multidisciplinary approach. Lifestyle changes remain the cornerstone of treatment, and we still recommend goal weight loss of 10%. Resmetirom represent a major milestone in the fight against MASH, and there are other drugs in the phase 3. So it is time to screen our patients, stage them, and treat based on the data that we have available. Thank you so much. And I hope that I will be available for answering any question. Thank you.
Talk, and thank you all of you for listening this virtual talk. I request our chair, Professor Nadeem, to give his conclusion marks.
Bismillahirrahmanirrahim. Assalamu alaikum. As ever, Bilal Hamid is always used to give us knowledgeable and practical talk. Same is here: screen, stage, and treat. These are three nutshell messages. चूँकि ये virtual था, इसलिए सब लोगों ने इसको virtual ही कर दिया. तवज्जो नहीं से सुना नहीं आपने, हालांकि बहुत ज़बरदस्त practical point बताया जा. Thank you very much for bearing the virtual talk.
I think an excellent talk, and one thing a take-home message should be: it's a multidisciplinary disease, and we should pick the patient at the right time. And I think we should involve other people, especially dietitian and psychologists, because without just saying that they improve your diet will not work, and it's just a scientific way which we have to approach these patients. Thank you.
I request chair to.
Thank you very much, Professor Bilal. Just want to highlight few points. जो high risk population है F2, F3 fibrosis वाली, we miss as a gastroenterologist in Pakistan. In my 10-year experience, fibroscan at times is deceiving. तो फाइब्रोस्कैन पे हमने रिलाई ज़्यादा नहीं करना इन पाकिस्तान. वी नीड टू ऐड 5-4 स्कोर मस्ट. इसलिए हम गैस्ट्रोएंटरोलॉजिस्ट वी मिस द पॉपुलेशन ऑफ F2, F3 फाइब्रोसिस विच इज़ करेक्टली हाईलाइटेड बाय प्रोफेसर बिलाल. इफ़ आपको लगे फाइब्रोस्कैन नहीं तो प्लीज़ ऐड लिवर बायोप्सी. प्रमोट द कल्चर ऑफ लिवर बायोप्सी बिकॉज वी नीड टू ट्रीट दीज पेशेंट्स एज अ गैस्ट्रोएंटरोलॉजिस्ट जी. थैंक यू जी.
Thank you, Dr. Bilal. As regarding my province Balochistan, वहाँ पे फैटी लीवर जो है वो प्रेवलेंस उनकी काफ़ी ज़्यादा है, उनकी डाइट्स की वजह से जो है और उनकी जो लिटरेसी रेट है उनकी वजह से हैं. मगर कुछ चीज़ें जो हैं वो आउट ऑफ द गाइडलाइन होती हैं. फॉर एग्जांपल हमारे पास फाइब्रोस्कैन इलास्टोग्राम की एक्सपर्टीज़ नहीं होती, या बहुत से पेशेंट जो हैं वो लिवर बायोप्सी के लिए नहीं जाते. तो इस हवाले से जो है हमें फिर ज़्यादा फोकस करनी पड़ती है कि पेशेंट को एजुकेट कर ले, जो कि उससे भी ज़्यादा मुश्किल होता है. तो इधर इस रिगार्डिंग इसमें अदर देन गाइडलाइन आया हम फर्दर क्या कर सकते हैं. तो इस हवाले से बिलाल साहब से क्वेश्चन फिर रहता है, अगर ऑडियंस में से कोई दे दें इसकी. थैंक यू.
सर कम फॉर ग्रुप पिक्चर.
जी छोटी सी हाउसकीपिंग अनाउंसमेंट है, काम की बात है. जैसे आरिफ ने कहा आप लोग तवज्जो नहीं दे रहे, प्लीज नो बैकग्राउंड टॉकिंग. दिस इज वेरी डिस्ट्रैक्टिंग फॉर द स्पीकर्स एंड डिसरिस्पेक्टफुल. सो लेट्स नॉट हैव अ कॉन्वर्सेशन इन द रूम. दिस इज अ बिग होटल. You can go to any corner and talk, but not in this room, please. Does everybody back it up? ओके प्लीज, थैंक यू। द अदर काम की बात यह है कि आपको खाना नहीं मिलेगा अगर आपके पास ये नहीं है। अगर आपने रजिस्टर नहीं किया और ये कूपन पिक नहीं किए तो घर आप भूखे जाएंगे। सो प्लीज आई वुड रिक्वेस्ट टू क्रिएट सम डिसिप्लिन व्हेन वी आर ईटिंग। प्लीज टेक दिस कूपन्स। यहाँ बैठा हुआ है मुजम्मिल, आप कार्ड्स ले लें। फैकल्टी के लिए जो अक्रॉस द हॉल जो सेकंड डोर है आगे वाला, उससे एंट्रेंस है। फॉर द डेलीगेट्स खाना वही है बाय द वे, इसमें नाराज ना होना, लेकिन वो आगे से एंट्रेंस है और दूसरों के पीछे से एंट्रेंस है। प्लीज लेट्स हैव सम रिगार्ड फॉर द फैकल्टी एंड कीप इट डिसिप्लिन। थैंक यू वेरी मच। सो इस टॉक के बाद लंच है, 1:30 बजे नमाज होगी। जो एलिवेटर्स के साथ एरिया है वहाँ पे नमाज की जगह है, इसके साथ बोर्ड रूम है, वहाँ पे फीमेल्स के लिए नमाज की जगह है। सो दीज आर हाउस कीपिंग अनाउंसमेंट्स। थैंक यू वेरी मच।
Thank you, sir. Now we are going to start our sixth session, which is basically a sponsored session. I am Dr. Prince Misri Khan. I am working as a consultant physician at Chanka Medical College Hospital and Shahid Mohtarama Benazir Bhutto University, Larkana. So without taking any other delays, I would like to call the worthy chairs of this session. One of them is Professor Brigadier Dr. Shahid Raza Khalid. He's head of Department of Gastroenterology at Imran Idris Teaching Hospital, Sialkot. Sir, please. Our next guest is Dr. Iftikhar Yusuf. He's consultant gastroenterologist at Shalamar Hospital, Lahore. Followed by Dr. Tahir Bangash. He's professor and head of liver transplant at HBP department. He is also the pioneer of fellowship in transplant surgery at CPSP. Sir has also the privilege of being the first in Pakistan to carry out cadaveric transplant. Sir, may I request our chairs please take the seat. Professor Iftikhar Yusuf and Dr. Tariq Mangash. I would also like to request Professor Altaf Alam Saab to please come and take the seat, sir. Sir, please. Our first speaker for this session is Dr. Asad Chaudhary. He's FRCP. He's working as a consultant gastroenterologist at Chaudhary Hospital, Gujranwala. He's current president of Pakistan Society of Hepatology and also the founder of Parsa Eco Pakistan. Sir, please.
थैंक यू। बिस्मिल्लाहिर्रहमानिर्रहीम। आज दो चीज़ें सीखी हैं। इतने मिनट की मेरी टॉक नहीं है जितने दफ़ा मुझे ये मैसेज दिया गया, सर जल्दी करें। और दूसरा, अगर मैसेज डी की टॉक के बाद खाना ना भी मिले तो मेरे ख्याल में गुजारा चल जाएगा। सो यू हैव टू बेयर विद मी। I'm going to speak on clinical usefulness of PIFCA2 and GAD algorithm in HCC surveillance. So here are my disclosures. So just to give you background, I picked a few slides from EASL about liver cancer. It's the 5th most common cancer and 2nd most frequent cause of cancer-related deaths globally. It amounts to 7% of all cancers. It accounts for, HCC accounts for approximately 90% of primary liver cancer, and it's a major global health problem. So we must not forget about prevention. Wherever you can treat, you have to treat. और ये बात बहुत ज़्यादा reinforce की जा चुकी है आज की talks में. Hepatitis B है, hepatitis C है, then there are other risk factors, and don't forget obesity and MASLD. And this is the modified staging. You all know about it. Just keep going back to it again and again because this is very important, which stage we are going to pick the liver cancer. So HCC is primarily हम globally तो बात करते हैं, but the burden of the disease is in Asia. And unfortunately in Pakistan, as far as my practice is concerned, we are hit by a tsunami of HCC in Pakistan. So we have around 25,000 patients with liver cancer. So ये 2020 का data है. Or again, majority is secondary to hepatitis C. And this is one of the posters we had in 2017, just to, where we figured out about the presentation of hepatitis HCC in Pakistan. And you can see out of total 102 patients, you have child A, B, and C class in front of you. 57% were picked on ultrasound in this category, and nearly 38% were alerted by alpha-fetoprotein. Size was more than 5 centimeter at the time of diagnosis in 50% of the patient, and nearly 50% had vascular invasion when the cancer was diagnosed. We could offer curative option. This is besides the point whether our population can afford it or not, to only 21% of the patient. So palliative local regional 43%, and around 35% was the best supportive care. So early detection of HCC is key to improve survival outcome and chances of cure for patient. The 5 years overall survival, if you diagnose or pick the cancer in early stage, 40 to 70%, it is nothing, it is less than 5% in late stage HCC, as the majority of the patients they present. The frequent screening in high risk group can lead to 37% decrease in HCC mortality. It is cost effective and allows for the early initiation of the curative treatment. So surveillance according to EASL, cirrhotic patients in child A and B, we keep surveilling patients awaiting liver transplant, non-cirrhotic hepatitis B patient at intermediate or high risk of HCC, advanced fibrosis patient. Usually 6 month interval is what is reasonable and cost effective. There are uncertainties. Role of surveillance for patient with NAFLD without cirrhosis is unclear. Ultrasound is an operator dependent thing. So this, you have to keep this in mind. Tumor biomarkers for accurate early detection are still lacking. And patient on the waiting list for liver transplant should undergo surveillance for HCC to detect and manage tumor occurrence or tumor response, and to help define priority policies for transplantation. If you come to a puzzle, again, ultrasound and alpha-fetoprotein. Ultrasound is, there is operator variability, poor performance in patients with fibrotic change and fatty infiltration of liver. Again, there are technical difficulties in obese patient and difficult to detect small lesion. Alpha-fetoprotein is not specific for HCC. It can be false positive in other conditions, as in cirrhosis, active hepatitis, or other types of tumors. And it can be false negative in HCC patient or small size tumor. So there is an unmet need that a new HCC biomarker to improve the performance of surveillance strategy. So here comes the PIVCA. I think everybody in this room is aware about the PIVCA, which is an abnormal prothrombin protein, which is test gamma carboxyprothrombin. This precursor undergoes carboxylation by gamma glutamyl carboxylase in liver to form the native prothrombin. And this is inhibited by vitamin K deficiency. And in HCC patient, this carboxylation is affected, which leads to raised PIVCA levels in these patients. And we are all doing that. The question is whether we can do better. So the median of this population was around 18.7, and a cutoff of 28.4 PIVCA, this is by the Alexis-Roche method, showed high sensitivity combined with good specificity in detecting late stage HCC. It also correlated with tumor aggressiveness. HCC patients with elevated PIVCA2 levels are 1.8 times more likely to have microvascular invasion. And you can see how it goes up as far as the stages of, as the BCLC stage increases. So for early stage HC, around 2 additional patients for every 10 can be detected with PIVKA2 and alpha-fetoprotein versus alpha-fetoprotein alone. So the numbers are in front of you, and the multiple studies, they demonstrate the clinical performance of PIVKA2 and alpha-fetoprotein in early stage HCC detection. As you can see, most of the data, they come from Asia. In the dark blue is the combined PIVKA2 and alpha-fetoprotein, which is showing higher performance as compared to alpha-fetoprotein alone. Now, all the Asian studies, they validate this in Japan, in China. So what is GAD? So what happens in GAD is with gender, age, alpha-fetoprotein, and PIVKA, which is des-gamma carboxy prothrombin. So the Roche came up with an algorithm to aid the diagnosis of early stage HCC. Late stage HCC तो आपको ultrasound पे और high alpha fetoprotein पे वैसे ही मिल रहा है. So GAD showed a sensitivity of 73.1% and 77.4% for detection of early and all stage HCC respectively. And combination of GAD and ultrasound leads to a sensitivity of 92% for all stages of HCC detection. So this is the data from Taiwan. Here you can see all stage HCC where GAD showed 77.4% sensitivity, and early stage it showed superior performance to alpha-fetoprotein, PIVKA2 or ultrasound alone. So addition of GAD to ultrasound improved the detection of early stage HCC, and in BCLC stage 1 it goes up to 89.5% and BCLC stage 0 85.7%. So calculation is either through GAD algorithm, this is the Alexis GAD, alpha-fetoprotein and PIVKA, they are done through different methods. There are other vendors also in the market, but this calculation and this algorithm is on the Alexis Roche system. And they have automated analyzer, which now the labs are reporting commercially, which gives you calculated GAD score. And what happens is, with alpha-fetoprotein, PIVKA, age and gender, the GAD reveals a risk factor score from 0 to 10, which is the likelihood of your patient developing hepatocellular carcinoma. And the cutoff is at 2.57. To me, if the patient has GAD score more than 2.57, so you have to seriously look into liver cancer. And especially when we are doing screening in early stage BCLC 0 or 1, so that is where you really need to focus on, because that's the key for the survival of your patient, and it means even cure for your patient. So this is some data from New Zealand, and here you can see all HCC, early stage HCC and late stage HCC, GAD has superior sensitivity to ultrasound for detection of early stage curable liver cancer, and GAD plus ultrasound is better than the ultrasound alone. And it detected almost twice as many early stage HCCs as the ultrasound alone. So it really helps if, as a clinician, you are alerted by a score that really just pushes you more to look deeply in whether the patient has liver cancer or not. So this is published in Hepatology, the algorithm, the GAD algorithm, it showed improved early and all-stage HCC detection. Clinical performance area under the curve for differentiation of HCC and CLD was significantly higher for GAD score versus alpha-fetoprotein or PIVKA2 alone across disease stage, etiology, or geographical region. So just to elaborate a case study, a 77-year-old female, chronic hep B cirrhosis, treated with nucleoside analog since 2002, virally suppressed. She had dyslipidemia and under regular follow-up for HCC surveillance with biannual ultrasound and alpha-fetoprotein. So on 21st of March 2023, ultrasound showed mild fatty liver without lesion, and alpha fetoprotein that is routinely recommended is 4.3. So what happens in September, alpha fetoprotein is 4.82, PIVCA is 97, and the GAT score is 3.29, which is above the cutoff limit as recommended by the algorithm. So you can see there's a small lesion on ultrasound, subsequently showing the characteristic features of HCC. The patient undergoes microwave ablation. She is already on treatment, and effectively this patient is cured. This does not mean the surveillance won't stop. The surveillance will keep going, and we keep monitoring this patient. So what it means in my practice? In my practice, or what we do as a clinician, it means only one thing. So this is where we need to pick up our patient. That's all. We only need to pick up our patient at early stage so that we can offer them curative options. To conclude, GAD algorithm significantly improves early stage HCC detection for patients with CLD undergoing HCC surveillance. It shows strong specificity with a low rate of false positive regardless of disease age, etiology, or region. GAD has shown superior performance to alpha fetoprotein or PIVCA alone in the detection of early stage HCC. Majority of the patients detected early in the course of illness are eligible for curative treatment. While further phase 3 and 4 studies are warranted to assess the utility of incorporating the algorithm in clinical practice, local Pakistan data will be very helpful. Thank you very much for your patient listening.
Thank you, sir. Our second presenter is Professor Zahid Azam. He's a professor at the Dow University, Karachi. He'll be speaking on the topic of role of ferric carboxymaltose in IBD on the behalf of Maternal. Sir, please.
Bismillah ar-Rahman ar-Rahim. Assalamu alaikum ji. This molecule, which is used for OBGY as well as by us, but we need further elaboration. So I'm going to talk about ferric carboxymaltose, which is available by the commercial name of Pfizer by MDM. And this molecule has background research over many years for IBD patients, and majority of us in this hall are also practicing gastroenterology. That's why they had chosen this. So iron deficiency anemia in IBD patients. So this is very common that we are taking care of our IBD patients, and we come across on a daily basis iron deficiency as well as iron deficiency anemia. And especially this is commonly seen in UC, then Crohn's disease. And the causes of and prevention of anemia in IBD, basically it's seen that iron deficiency anemia happens in 90% of our patients suffering from Crohn's disease or ulcerative colitis. And this progression of anemia leads to a lot of psychosomatic symptoms, and this decreases the quality of life if our patients are suffering from anemia or iron deficiency or iron deficiency anemia. So iron stores are basically present in the form of 80% in hemoglobin, then liver is the second most highest source of 20%, and then rest are divided in muscle, reticular endothelial system, and less than 0.2 in plasma circulation. So treatment of iron deficiency anemia or iron is basically to raise the hemoglobin as well as to get the higher level of ferritin and transferrin saturation should be above normal threshold. Because what happens is that in these patients, despite your IBD is under control, they tend to lower their hemoglobin gradually over year. And that's why your restoration target is just above the target. And iron supplementation is recommended for these patients. Even we know that oral treatment is available, and most of us are giving us our patient oral treatment. But what are the difference when we give oral versus IV treatment in IBD patients? So it is ineffective due to poor absorption. The ulcerated area that is, and especially this is more common in Crohn's disease because iron gets absorbed in the upper intestine rather than the lower. And then the they have oral iron have a lot of complications, or patient cannot tolerate because of diarrhea. Sometimes they have constipation, they have abdominal symptom, nausea and vomiting, and that's why this is important for compliance issue as well. And intravenous iron was found to be safe, effective and well-tolerated molecule, correcting the iron deficiency and maintaining the iron store. So what are the advantages of ferric carboxy maltose in IBD patients? Previously, for IV replacement of iron, we were using iron sucrose as the agent, Venofer, which was very well known by everyone. So this molecule allows for faster correction of iron deficiency and replenishes iron stores and bypasses the gastrointestinal and avoiding GI side effects. And here we have a lot of trials that are supporting the literature. So ferric carboxy maltose reservoir is an intravenous agent which is available in 500 milligram vial, and this can be given as 1000 milligram and in only 15 minutes. So with this shorter time of, so this can be diluted in 100 ml normal saline, and as physician we can give this in our endoscopy recovery room for those patients who are coming with iron deficiency, and we are also getting their endoscopies done. The efficacy and tolerability of ferric carboxy maltose have been shown in various indications, including anemia associated with IBD, which I'm talking. But this is also used in pregnancy-related postpartum hemorrhage, heavy uterine bleed, and most recently chronic heart disease patients have been treated with this. And there is some data on bleeding secondary to acid peptic disease and chronic liver disease. So with time, I'm skipping this. So this was the trial for GI core, a randomized controlled trial, which was the trial of patient where 80 patients were screened, and they were randomized to receive either ferroxycarbomaltose 224 versus iron sucrose compound. And then there was some withdrawal, and then they analyzed these 224 patients in their analysis, and the major complications were comparable between the two, though this was the largest study in IBD, and it showed that the patient with IBD had response significantly better when we use this molecule as compared to the simplified dose regime. And this is a simplified dose regime. We do not have to calculate with the Gazzoni formula, and because we can use 200 milligram at one time, and there are multiple dosing that is required as compared to this is only a single dose, and we can use 2 vials, that is 1000 milligram in 15 minutes, and we can give it, which is cost effective later on because you are giving 200, 200, 200, so 5 to 10 injections, and the cost comes the same. This not only that we have iron deficiency anemia, there are some patients where the iron store is low, but the hemoglobin is maintained. But even then, they have a lot of symptoms related to iron deficiency, and common are basically sleep disturbance, fatigue, attention deficit, and agitation. And it also, you have normal hemoglobin, but iron stores are low. It also decreases your quality of life. So I'm skipping this. There is another multi-center prospective trial of 105 patients where single dose of 500 milligram of Pfizer was used and the outcome that was assessed was improvement in ferritin level as well as iron level and transferrin saturation level after 1 month of dose. And what they found that it has significantly improved health-related quality of life, evidenced by improvement in SF12 version 2 as well as visual analog score. So they concluded that ferric carboxy maltose demonstrated rapid restoration of iron parameters and significant enhancement in both quality of life as well as the symptoms. So this is the post-marketing phase 4 trial where intervention was given in 101 patients in Germany, in several centers across the Germany, and they had concluded that there was improvement in serum iron from 6.1 to 12 point, the last row, 12.4 micromole, as compared to the improvement in clinical scores and quality of life, and there was no adverse drug reaction, serious adverse event. And the beauty of this molecule is also that for iron sucrose, we are scared of having a lot of allergic reactions, and that's why this needs to be given very slow in a controlled environment, where this can be given in small clinics or ER and our endoscopy suites as well. So, study results of ferric carboxy maltose versus placebo. What they have done, they have replaced, and then they followed this patient, and after follow-up, they given again a dose and also a placebo. And the idea was whether the iron stores were depleting in IBD patients once they have repleted their source. So in FCM group, there was anemia recurrence was 26%, whereas the placebo group there was 39.4%, which signifies that we sometimes need to have an eye on this drop in hemoglobin. And FCM iron was plus 30, as well as transfer saturation was good as compared to negative impact when the placebo were. So they conclude that this molecule is more effective than placebo in preventing anemia recurrence in IBD patients. So this is GI. I'm switching from GI to hepatology. This is a randomized controlled trial of intravenous ferric carboxy maltose over oral iron to treat iron deficiency anemia after varicose bleed in patients with cirrhosis. And here, this was published in American Journal of Gastroenterology 3 months ago, where cirrhotic patients with varicose bleed who were adequately treated and were being discharged were given in a randomized fashion intervention arm of where 48 patients were randomized to receive ferric carboxy maltose, and the control were given oral carbonyl iron compounds. And what they came up after 3 months follow-up, that the serial hemoglobin iron profile and quality of life, as well as hand grip and liver-related events were better as compared to those patients who were replaced with oral iron compound. And so the median increase in iron was at 3 months in the IV, and oral was 3.65 gram versus 1 gram only with oral replacement in 3 months follow-up period. Iron stores normalized in 84.6% in IV group as well as compared to 21%. Anemia improved in 50% and 21%. And so just to summarize, it is effective treatment of iron deficiency anemia in IBD patients, delivering replenishment dose up to 1,000 milligram and over 15 minutes. And the results of several RTC in IBD supports their claim of better control of iron as well as quick replacement and improvement in quality of life. And there is some recent data that is available. This is a randomized control trial of esophageal varicose bleed that I showed you. There is another publication 9 months ago with retrospective data from Spain, where they have used this molecule in acid peptic disease bleed, where they have replenished iron, and the similar results were obtained. And in clinical trial, this was well tolerated, and therefore is an effective option in the treatment of IDA in patients in whom oral treatment or IL preparation cannot be tolerated, and we need quick response. Thank you very much for patience listening.
Thank you, sir. Our third speaker is Mr. Salim Mustafa. He is a Allurion certified trainer. He's from Jordan. He'll be speaking on the topic Allurion gastric balloon, a non-invasive approach for medical weight loss. He'll be speaking on the behalf of Shazo Pharmaceuticals.
Yeah, you are controlling. All right, thanks everyone. Thanks for the entire PSH committee and for the members for giving us the platform to speak today. So my name is Salim Mustafa. I'm the regional director for Allurion in the Middle East, Africa, and Pakistan region. And today we are here with our partners Pakistan, Shazo SPL, bringing the Allurion program into Pakistan. So today we will be talking about Allurion under the theme of discovering the future of weight loss. So what is Allurion? Allurion is the only intragastric or the only weight loss device that requires no surgery, endoscopy, or anesthesia in either insertion or the removal of the device. So how is it placed? It's placed during a brief 15 minutes visit, and it passes naturally approximately 16 weeks after the placement. And patients on average loses 10 to 15% of their total body weight loss. The studies have shown that up to 96% of average weight loss may be sustained 1 year after the balloon passes. And our program gives the opportunity to access to our Allurion Virtual Care Suite, which is a set of tools that's provided to the healthcare providers and the patients to monitor their weight loss and other parameters, health parameters trend, and helps the HCPs to manage their patients. So I'll show this video that gives an overview of the program. Sound, please.
Gastric balloon that requires no surgery, no endoscopy, and no anesthesia. The Allurion balloon will help you embrace healthier eating habits, recommended by a care team that will support you throughout your journey. The program also includes digital tools to help you stay motivated and maintain a healthy lifestyle. People lose an average of 10 to 15% of their body weight and maintain up to 96% of the weight lost at 1 year follow-up. The Allurion balloon is placed by a certified healthcare professional during a 15-minute procedure. The balloon is packaged into a capsule that's attached to a thin catheter for easy placement. Your healthcare professional will help you swallow the capsule with a glass of water. Once the balloon is in place, your healthcare professional will take an X-ray to confirm proper placement. Once in the stomach, the vegetarian capsule degrades and the balloon will be filled with 550 milliliters of water. Then, a second X-ray is taken to ensure filling is complete. The full balloon is roughly the size of a grapefruit. Your healthcare professional will gently remove the catheter from your mouth. The Allurion balloon placement is now complete. Your clinic will set you up with your Allurion app and link it to your Allurion connected scale, and you can go home to start your weight loss journey. While in the stomach, the Allurion balloon helps reduce the feeling of hunger by taking up space in the stomach. It creates a feeling of fullness, encouraging smaller portion sizes and helping you to reduce snacking. The balloon automatically empties and passes out naturally when you use the toilet. People lose an average of 10 to 15% of their total body weight. You won't be alone as you achieve your weight loss goals. The Allurion program includes ongoing support from your doctor and nutritionist for at least 6 months. They will work with you to change your diet and exercise habits as part of a healthy and holistic approach to losing weight. In addition, you will receive an Allurion connected scale and an Allurion app to help track your progress. You will be able to share your successes in real time with your healthcare team. A temporary balloon placement does not mean temporary weight loss. The Allurion program kickstarts sustained lifestyle changes to help you reach your target weight loss and then keep the weight off. Join the world's fastest growing weight loss program and start your Allurion journey today. Kickstart your...
So a little bit of history about Allurion is the company was founded in 2009, so today is 15 years. We have successfully treated 150,000 patients in over 80 countries worldwide. We are partnering with 1,500 plus clinics, And we have conducted the large clinical body of evidence, including the largest ever clinical study on intragastric balloons, concluding 5,003 patients. The balloon is designed and manufactured in the US, in Boston, and the company has been listed publicly in the New York Stock Exchange last year. So as the video said, the gastric balloon-based program is designed to deliver rapid and sustainable weight loss. So it's very simple and safe. The key message is that it doesn't require surgery, no endoscopy, no anesthesia, and is placed in easy 15 minutes placement in an X-ray setup. And it passes naturally 4 months after the placement. The results are effective. So on average, patients achieve 10 to 15% weight loss with one program, one balloon. And with 2 consecutive therapy or 2 consecutive balloons, over 12 to 18 months, patients can get a result of 23%. Allurion evolves about lifestyle modification, and it's a patient-centered multidisciplinary program. So on the maintenance side, our studies have shown that 96% of average weight loss may be sustained with a proper lifestyle modification 1 year after the balloon passes with a proper follow-up. And also the studies have shown that nearly 2.5 more weight loss achieved with the Allurion program and intensive lifestyle change rather than or compared to lifestyle change alone. And as I mentioned earlier, the program is equipped with a set of tools that are provided to the providers and the patients for better patient management and therefore better weight loss results. So the Allurion program fills an obesity treatment gap, as this slide shows. So on the lower end, diet and exercise achieve the 5% to 10% weight loss. On the higher end is the surgery that achieves the higher results of above 25%. And there is a treatment gap of 10 to 25% that has not been traditionally filled with any treatment. So here are like different combinations of treatments, like the balloon program alone can achieve up to 15%. 2 balloon programs can achieve up to 23%. We have studies that shows that balloon and medication can achieve up to 19% in one program. So this program is for people who have tried other weight loss modalities, but they were not successful, and people who qualify for surgery but don't want to commit to this option. Surgery or endoscopy or anesthesia is not an option for them. Or people who are simply not candidates. So we have conducted multiple studies, and all these studies conclude that a lot of patients, 60% of those who would consider healthcare provider intervention would consider an Allurion balloon, and that's the opportunity is really big for this. So 4.3%, according to the surveys that we have made, of the population would consider this as an option for them. So in terms of safety and tolerance, if compared to the other intragastric balloons available, the legacy ones available in the market, Allurion, the studies shown that Allurion is 10 times less serious adverse events compared to the other liquid-filled balloons, and it's 7 to 8 more times tolerant compared to the others. And this is simply linked to the shape of the balloon, how malleable it is, and the material that is made from. It's polyurethane compared to the silicone-based endoscopic balloons that's available in the market. In terms of other health-related modifications and enhancement, we have multiple studies shown that Allurion proven to help manage type 2 diabetes. So in this study there are 216 patients have been treated, and significant modification on sugar levels have been achieved. 226 patients. So diabetic patients dropped from 7 to 5.5, and pre-diabetic patients dropped 1.1 points from 6 to 4.9. So Allurion safety and efficacy has been very well demonstrated and proven with over 30 published abstracts and manuscripts. You can scan this barcode here, and will lead you to all the manuscripts and the studies of Allurion. And as I mentioned earlier in this presentation, Allurion had the largest gastric balloon study in the world. It's a global experience with 5,003 consecutive patients from 26 international obesity centers in 10 countries. And to conclude the results of this study, average weight loss achieved is 14%, with high success swallowing rate and very low adverse events and serious adverse events. So you can have also the abstract for this study in details. So I conclude with this. We'll just show one video for the first placements that we have done in Pakistan, and we can conclude with that. Can we show the video, please?
Hi, this is Salim Mustafa, and I am the Regional Director for Allurion in the Middle East, Africa, and
socialize than others. So for that, you don't only need to look fit, आप mentally भी उतने ही fit होने चाहिए. So mentally fit होने के लिए भी ज़रूरी है कि physically आप के attributes ऐसे हों जो कि देखने में भी attractive हों. So this is the reason जो हमेशा से था.
All right. Drink. Push it, push it, push it. And it's gone. That's it, it's gone. Now stop. Now slowly, slowly.
Okay, so the balloon has been placed successfully and it has been inflated. As we can see that this is the shadow. There's this inside it, so it's been confirmed that it's in the stomach.
वेल हियर वी आर और प्रोसीजर के बाद अभी मैं प्रोसीजर रूम से निकला और सबसे मज़े की बात ये है कि कंप्लीट हुआ अचीव हो इंशाल्लाह अल्हम्दुलिल्लाह आई विल टेल यू माय एक्सपीरियंस एंड माय अचीवमेंट इंशाल्लाह थैंक यू.
And with this, we conclude. Thank you for allowing a few minutes over the time. And if you have any question, please reach out to Shazo SPL representatives here in the event. Thank you so much.
Thank you. Our last speaker is Dr. Alia. She's Senior Medical Manager at Mector, and she will be speaking on the semaglutide, a groundbreaking innovation to improve patient access. I would request you to please stick to the time limit, please. Thank you.
Thank you so much. My name is Dr. Ayla. I represent Mector International. I serve in the capacity of Senior Medical Manager. On behalf of Mector International, I'll just walk you through the 40 years of pharmaceutical manufacturing excellence that we have. We have the first approved facility for lyophilized biologicals. The journey has been exciting for Mector. We boast as having the most biologicals. 2019 has been a groundbreaking year for us, and so has 2024. September 2024, groundbreaking innovation to improve patient access. Leveraging the platform that PSH has provided us, we're proud to introduce the rDNA origin semaglutide once weekly injectable. Thank you so much. The benefits that it offers include a variability in the titration. We offer the minimum and maximum dose. We've removed all pain points for physicians. Semaglutide is the most researched brand that has approved indications in type 2 diabetes, obesity, with clinical trials that have patient population of more than 25,000, and ongoing research that continues with NAFLD and MASH. Thank you so much for your time and patience, and thank you, PSH.
Thank you very much. And now I would like to request chairs to please share their comments, sir. Thank you.
Thank you very much. It was basically a series of industry-sponsored talks. So it all seems very good, does work, but we have to remember that what are the exact clinical situations where to use them, not to completely follow the industry suggestions, but use our own mind to find the right indications, when to use, why to use, and where to use it. So, for example, in IV iron therapy, one has to see that the patient is unable to tolerate oral treatment and the gut is not healthy enough to absorb iron before start giving it to everyone. There are situations where you want to bring up hemoglobin quickly without transfusing, and certainly it is needed in these situations. So thank you for making us wiser with the newer innovations in medicine, and one has to use it judiciously is all my request. Thank you. Brigadier sir.
So I think we have summarized it in a very good way, and lunch is also waiting. I don't want to stay to delay it anymore. Thank you.
Thank you. I would request chairs and speakers to come for a photograph.
So I would request all faculty members for a group photo, PSH 2024, and that will be followed by the lunch. Time is half hour. We have cut down half hour from the lunch time. We request you please come at 2:30 p.m. sharply. Thank you. And we need your cooperation as you did before. Thank you. All faculty members are requested. Dr. Om, Professor Nasir Hassan Lak, please come forward for a group photo. Please join us for group photo.
Hello. 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 Hello, sound check. Hello. 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 आवाज पार्टी आ रही है. Hello. 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 Hello, sound check. Hello. 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 Hello, sound check. Hello. Hello. Hello, sound check. Hello. Hello. Hello, 1, 2, 3. Hello. Hello, sound check. Hello, 1, 2, 3, 4. Hello. 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 Hello, sound check. Hello. खाना सामने वाले हाल में.
Bismillahir Rahmanir Rahim. And Assalamu alaikum and good afternoon, everyone. I am Dr. Taha from SIUT, and I'll be moderating this session, which is entitled by the topic of acute on chronic liver failure. Before beginning with the speakers, I would like to call upon the stage the chairpersons. First of all, I would like to invite Professor Arif Siddiqui. He is the Fellow of Royal College of Physicians, London, Edinburgh, and Glasgow. And he's also the former president of PSH and Pakistan Society of Gastroenterology. He's also the former principal at Allama Iqbal Medical College and also the former dean of Pakistan Kidney Liver Institute. Currently, he is the principal at Rashid Latif University Medical College, Lahore. Now I would like to call upon Dr. Atif Majid, who is also the assistant professor of gastroenterology at the Aga Khan University Hospital. Now the third person who will chair this session is Mia Shah Yusuf, and he has done fellowship in gastroenterology from the College of Physicians and Surgeons, Pakistan, and he's also the assistant professor and head of the department of gastroenterology at Prime Teaching Hospital, Peshawar. Dr. Shah Yusuf. All right. So now to begin with the presenters, I would like to call upon the stage Professor Hasnain Ali Shah. He's a fellow of Royal College of Edinburgh and fellow of American College of Gastroenterology. And he's currently the consultant gastroenterologist and professor at Aga Khan University Hospital.
Before Shah Saab takes the mic, can I request people at the back to kindly sit down, settle down. जिस तरह मेरी टॉक जिस तरह जब बैट्समैन जो है उसकी साइड स्क्रीन के आगे कोई चीज़ आ जाती है तो वो बैटिंग छोड़ देता है, इसी तरह जब स्पीकर बोल रहा होता है पीछे साइड स्क्रीन पे लोग मूव कर रहे होते हैं तो वो बड़ा डिस्टर्ब होता है. और जो ऑर्गेनाइज़र है उनसे भी मुझे रिक्वेस्ट है कि जो लोग अभी आएंगे खाना खा के उनको भी कहें कि जी तशरीफ़ रखें rather than loitering at the back. तो आप मुझे अलाउ कर देना कि अगर ऐसी कोई बात हुई तो शाह जी मैं आपको स्टॉप करके तो उनको थोड़ा सा बिठाने के लिए कह दूंगा. काइंडली गो अहेड.
Can I start? Bismillahirrahmanirrahim. Assalamu alaikum everybody. Thank you very much, chairpersons, and thank you, moderator, for the kind introduction, and the organizers of the symposium to have invited me to come and talk. I've divided my talk into two portions. One is about general definitions and then to talk about the Western criteria and what our country has to say about this thing. I'm a very Eastern person at heart. People know me. I was born and brought up in a very orthodox Eastern family of Pakistan. But over the years I drifted into the West. But still the heart is very much Eastern and the heart is in Lahore, and it's always a pleasure to be in Lahore for whatever reason. And Amna is always a daughter of the East. So we are both Eastern, but I'm just going to present some data from our country. So ACLF used to be, I always used to say it's a new entity, came into being somewhere in 1995, ending of the last century. But then the talk said it's an evolving concept, but now it is a distinct entity. In this syndrome, which is a form of decompensation of chronic liver disease, the distinct part is that there is a potential for reversibility if managed appropriately in a timely fashion. Otherwise, it has a very high mortality. As I said just now, the term was first coined in 1995 to describe a condition where there have been two lesions or two insults into the liver. One is a chronic one, which could be chronic hepatitis of any etiology. Other is cirrhosis, which again could be viral, it could be metabolic, it is drug-induced, alcoholic, etc. So the difference between, I won't talk too much about apostle because they might be overlapping on what we have to say. The insult is mostly liver specific in cases of the apostle definition, whereas EASL deals with insults which are general, like surgery, sepsis, trauma, alcohol, anesthesia, etc. So the EASL definition, which is the Western definition, is an acute deterioration of pre-existing chronic liver disease, usually related to a precipitating event and associated with increased mortality at 3 months due to multi-system organ failure. Important thing is that about 6 organs are followed up in this condition, whereas apostle is a condition which is manifesting as a jaundice with a serum bilirubin of at least 5 milligram and a coagulopathy, which is INR of 1.5 or more, and a prothrombin activity of less than 40%. Complicated within 4 weeks by the occurrence of ascites and or encephalopathy in a patient previously diagnosed or undiagnosed with chronic liver disease. Important thing is that it is a first-time presentation in such patient, and the index presentation is the first presentation with decompensation of chronic liver disease, whereas the EASL criteria take on second, third, fourth, fifth decompensations as well. So the first element involved in the definition of ACLF is the presence of chronic liver disease, which is defined by the apostle as the presence of compensated cirrhosis of any etiology, which could be cholestatic, metabolic, chronic hepatitis, NASH, excluding NEFRD. So the acute precipitating event is something which can be liver specific, such as drug-induced liver injury, alcoholic hepatitis, new onset of viral hepatitis or reactivation of old disease, and ischemic hepatitis, like Budd-Chiari syndrome. And systemic events can be surgery, infection, trauma, variceal bleed. So East versus West, if I have to say that, in the East, infections are more common, acute hepatitis of new onset, reactivation of hepatitis B, whereas in the West, alcoholic hepatitis and drug-induced hepatitis are more often. Infection or sepsis is, mind you, the most common cause worldwide, may it be West or East. And now, in many countries of the East, alcohol is now taking over as a very important part of the etiology of ACLF. It's no more disease of the West. And as I said, the single most common precipitating event is sepsis. In the pathophysiology of the disease, the pathophysiological mechanism involved a systemic inflammatory response syndrome, SIRS, which is caused by sepsis or a bacterial infection and can lead to worsening of the sepsis by the translocation of the bacteria, mainly from the gut. This leads to organ dysfunction on a background of decreased hepatic reserve and altered hemodynamics in the splanchnic, renal, and peripheral circulation. I just wanted to dwell on the criteria which are used for the definition of ACLF in the EASL definition. So as you see over here, that 6 organ systems are gauged and they are studied. And if the liver has these bold connotations are where the liver is deemed to be, where the organs are deemed to be failed. Dysfunction starts from the second column, where, and the top are the numbers which are assigned, or the score which is assigned to the patient if he falls into a particular category. And as you see, that liver, kidney, brain, coagulation, circulation, and lungs are deemed to have been affected in that order if the number increases. And the ACLF, if there is no organ failure or single non-kidney organ failure, a creatinine of below 1.5 milligram percent, and no hepatic encephalopathy, that is no ACLF, as per EASL definition. And the patient, if he or she gets single kidney failure, it's ACLF 1A. 1B is single non-kidney failure, creatinine under 2 milligram percent, and or HE of grades 1 and 2. ACLF 2 is at least 2 organ failures, and ACLF 3 of 3 or more organ failures. Now over here I'd like to present our findings of the Pakistani population. And this is the Pakistani perspective. The data is in the process of being analyzed fully. Like there is a shortage of technology in the country. The statisticians and the data analysts are in great demand, and it's not easy to get hold of them to work on this. So let's see. Over the last 2 or 3 years, we gathered data from 5 different major tertiary care centers of the country, starting right from KP, and then let's say Karachi first, at the Aga Khan University, JPMC. These are the names of the team leaders, and they had their own associates working with them. Nazish Bhatt, Professor Zahid Azam from the UHS, the Faruqi Saab from Peshawar, and Kashif Malik Saab from Sheikh Zayed Hospital, Lahore, and they contributed to the patients. Performers which were designed by the EASL group in London were used, filled up, and then the data is in the process of being analyzed. And as per this performer or this exercise, acute decompensation or AD is defined by one or more of the following in a patient with cirrhosis: the jaundice, ascites, encephalopathy, GI hemorrhage, sepsis, and one of these is the main cause of hospitalization. AD often occurs without a significant organ dysfunction, whereas in a subset of patients, which is ACLF, there could be a failure of organs like the liver, kidneys, brain, respiration, coagulation, and circulation, 6 organ systems as enumerated earlier on. The term ACLF is used for patients who fulfill the laid down criteria which I've already enumerated a short while ago. And there are at least 13 different definitions used, and everyone has the right to pick up his or her own. And the Americans have their own NEXLD. The Europeans have evolved into EASL. The Asia Pacific has the APASL. And now there's also a Chinese definition which is gaining popularity in many parts of the world. So data was collected prospectively from 5 different centers of Pakistan and analyzed according to the laid down criteria of the canonic study of gastroenterology 2013. So what we see in this is patients of ACLF versus acute decompensation. A total of 393 patients fulfilled the criteria of ACLF as per EASL, and 499 were in the acute decompensation. And I haven't mentioned on this, sorry, there wasn't sufficient time. Hepatitis C virus is the main cause of ACLF, accounting for about 60% of patients of ACLF. Hepatitis B virus is something like 17%, and the rest is DILI and alcohol and metabolic conditions, autoimmune, etc. So by and large, 60% of the patients are because of HCV. So HCV is still very prevalent, and maybe by 2030 we'll get good news that it is no more, but still it is there. So age of the patients was younger in patients with ACLF. There was no gender difference, and so also the patient hospitalization in days. And the BMI was near normal in the ACLF as compared to AD, which was slightly obese, and significantly so at the 5% level. This is a rather busy slide. I don't know whether you can read it, but the data analyst put too much data on this. That by and large, leukocytosis, which is a marker of sepsis as well as SIRS, is more prevalent in ACLF, so also PSC, variceal bleed, ascites, jaundice, SBP, HRS, encephalopathy grade, worse in patients with ACLF, and the 1 week mortality was 37% in cases of ACLF, as opposed to 9.2% in the AD patients, and the 28-day mortality was 53.4% versus 15%. Now, as I said, that HCV is the most common, so we also analyzed the data to see whether HCV patients did any differently than the non-HCV patients. So comparing HCV with non-HCV, what we see is that they are older patients, and the females take a lead in this, that there are more females in the hepatitis C group than the males, whereas the days of hospitalization is similar, and so is the body mass index. And if you go into the other variables or patient characteristics, we see that PSC is more often seen in cases of non-HCV related disease, whereas variceal bleed occurs more in cases of hepatitis C virus disease. And if you see lower down that even the grades of PSC are worse in patients with non-HCV disease. The mortality in the two groups at 7 days and 20 days is no different. So the outcome in these patients with hepatitis C is no different from those without other causes of ACLF. Now we've also graded as per grade 1, 1A, B, and C, and saw what the effect on mortality was as the grade gets worse. So we see that patients with grade 1A of the EASL classification, the 7-day and 28-day mortalities are 17% and 29% respectively. And so also in 1B, the mortality is 4.3 and 6.65, and as we move on to 1C grade, the mortality is 6% and 6.5% and 6.43% at 7-day and 28 days. The overall mortality and the prevalence of ACLF grade 1 patients is 66.15% in total of the whole group, whereas the mortality at 7 days is 26% versus 42% in the 28-day mortality group. ACLF grade 2, over here the mortality goes up at 7 days and also 28 days, where it is 63% and 82% in the two settings. Whereas in cases of ACLF grade 3, which are the worst patients, at 7 days, a little over 80% have died. And it is about 89% deaths at the age of, at 28 days. So if we don't act early, we don't recognize the condition safely and early, the mortality is going to be very high in this group. I've just taken the liberty of we could not analyze data as per the APASL classification is concerned because of the reason that, sorry, this is just the second last slide, Mr. Chairman. I know I've gone over my time, so just one. आप बड़े मेहमान नवाज लोग हैं, जो बहुत दूर से लोग आते हैं उनको आप टॉलरेट करते हैं. I know that. The Punjabis are very big-hearted people. So because a parcel needs variables like serum lactate, serum CRP, which is not done in every patient. So we could not analyze and classify these patients, but overall the prevalence was about 18% of the AD patients, and the 7-day and 28-day mortality without grading into 1, 2, 3 were 37 and 60%. So in conclusions, up till now the data reveals HCV is the most common cause of ACLF in Pakistan. There is no significant difference in mortality between HCV and non-HCV related ACLF. Short-term mortality is significantly increased in ACLF compared to AD, implying early recognition and treatment of ACLF patients. That's it. Thank you. And my gratitude to the 5 centers which contributed to the data. And to the best of my knowledge, please guide me on this. I'm maybe naive. I think this is the largest series, a cohort of patients from Pakistan, which is going into publication soon, first ever done. If there's someone who is aware of something like 1,000 patients looked at in this way, or prospectively, please let me know. Thank you.
Thank you, Professor Shah, for an excellent talk on acute on chronic liver failure. It's different aspects, different consortiums, and the local data. So now I would like to call upon our next speaker, and Dr. Amna Subhan. She's the Associate Professor of Gastroenterology at Aga Khan University Hospital, Karachi. She's also the Progress Director, GI Fellowship Program at Aga Khan University Hospital. She is also currently serving as a Vice President of Pakistan's Scientific Society of Liver Disease, and she's also an active member of ACLF Apazal Research Consortium. So, Dr. Amna Subhan.
All right, so thank you very much, Taha, for kind introduction. Assalamu alaikum, everyone. Lunch karke aaye hain. Assalamu alaikum. Excellent. One more time and more awake than this. Assalamu alaikum. Thank you very much. Wa alaikum assalam wa rahmatullahi wa barakatuh. Thank you. So let's come back. So a day in your round, you're seeing patients. Maybe you are actually in a clinic, you're receiving your call from your resident. There is a patient who is 40 years old without any known comorbid, presented with 2 weeks history of fever, jaundice, grade 1 encephalopathy. Total bilirubin is 7 milligram per deciliter, INR is 1.8, ALT is quite elevated, so is SGOT. Alkaline phosphatase and gamma GTs are near to the normal. Ultrasound revealed irregular liver margin. And the resident is thinking that, what's going on with this patient? You may actually come across with another patient, 40 years old, with ascites, hepatic encephalopathy grade 2, hypotensive, low oxygen saturations on room air, INR of 1.7, total bilirubin of 4.5, ALT slightly elevated, so is SGOT, creatinine is elevated, having metabolic acidosis, and ultrasound revealed cirrhotic liver, dilated portal vein, splenomegaly, without any prior history of ascites or encephalopathy. There is another patient, a 40-year-old gentleman with history of decompensated cirrhosis, now presented with ascites, hepatic encephalopathy, hypotensive, hypoxic, coagulopathic, elevated total bilirubin, ALT and SGOTs are slightly elevated, creatinine of 3 milligram per deciliter, and bicarb was 14. So the first step is what's going on with the patient, which phase of the disease is this? And then you move to how I'll evaluate this patient, how I'll confirm the diagnosis, what I can offer as a specific treatment for this. So these are three major steps we all follow whenever we evaluate this patient. So now I'm coming back to you. What do you think? Which patient is actually having ACLF? 1, 2, or 3? What do you think? All of them are having ACLF? One is having ACLF? Who is having ACLF? What do you think? So this is a little confusing. Every time when the patient comes to you and you start thinking, is this an APASL-driven definition-based ACLF diagnosis or not? You try to make it and your residents say, what about the EASL definition? This patient looks like an ACLF, and you say, okay, calm down. Okay, this may be because of ACLF APASL base, this may be an EASL base. So this is an area which makes you wondering all the time that, okay, what I'm going to follow, and if I don't follow any definition, is this patient is ACLF or not? Because here you get sensitized as C, just like an acute liver failure. This patient may deteriorate and I need to act very fast and send this patient, refer this patient for the liver transplantation if this is a possibility. And that is why this is important to understand that is this is an ACLF or not. So Dr. Shah just talked about EASL perspective about it. My job is to talk about a APASL perspective, but I will actually take you back a little bit again to understand the philosophy behind the two definition. And how is it started? It was 1995 where Oshini and his colleague has actually described a condition where they said this is a condition where the patients are coming very sick and they are having two concurrent insults, acute and the chronic. In 1997, the first case report of liver failure was reported after the TIPS, and people started thinking is this an acute liver failure? Yes, but it is different, seems like a different than simple acute liver failure. In 2002, Rajiv Jalan is actually proposed the working definition of ACLF. It was not very much backed by the data, but he said that the syndrome of an acute deterioration in the liver function over the period of 2 to 4 weeks, it can actually lead to a severe deterioration in the clinical status of the patient, jaundice, hepatic encephalopathy, and a rare hepatorenal syndrome with very high SOFA or an Apache score. 2014 was a year when APASL is actually proposed the cutoff of serum bilirubin is of more than 5 milligram and an INR of 1.5 to be the core definition to identify liver failure in patient with an existing chronic liver disease and cirrhosis. And this was based on the data of 280 patient or 185 patient, and they also extrapolized the cutoff of bilirubin and INR from the definition of acute liver failure, but it was backed by the data they reported. In 2009, the first consensus definition came in. It was a little like wide open, relatively less objective, but later on they actually backed it with the help of their prospectively evaluated data, and they revised the definition again in 2014, added the mortality, short-term mortality of 28 days, and meanwhile in 2011, EASL CLIF was launched, and they started collecting prospective data, and based upon that, the canonic study was published in 2013. So everybody started thinking, tried to back by the data, and came up with these definitions. APASL said that this is an acute hepatic insult which actually manifests by jaundice, which is the cutoff they added, bilirubin of more than 5, coagulopathy, INR of more than 1.5, or a prothrombin activity less than 40%, complicated within the 4 week of the the presentation by ascites and or hepatic encephalopathy in patients which are actually previously diagnosed or undiagnosed with chronic liver disease without any prior decompensation. The EASL says, see, this is a specific syndrome in patients with cirrhosis who are presenting with acute decompensation, organ failure associated with short-term mortality, and acute decompensation is described with ascites, encephalopathy, GI bleed, bacterial infections. However, they may develop ACLF without the prior history of decompensation, but they may develop it in the presence of prior hepatic decompensation, which simply means that they included decompensated and undecompensated both of the patient in this group of people, and organ failure they defined by the different organs as Dr. Hasnan described. So after the diagnosis, what comes? How severe the disease is. So Hepacil made it very simple based on total bilirubin, hepatic encephalopathy grade, INR, lactate level, serum creatinine level, and based upon that they come up with severity scoring system, a scoring system which is ARC scoring system. They categorize them into ACLF grade 1, grade 2, and grade 3. EASL followed Cliff SOFA scoring system, which is a little complicated, as Dr. Hasnan mentioned in his presentation, and based upon that, 6 organ failures component has been integrated, and this scoring system is actually used to assess the severity of ACLF and also to segregate the group of people who are not having ACLF, but apparently clinically they will look like. So this is how EASL is actually used this grading system to exclude no ACLF, but with grade 1, 2, and 3. And the summary form of this table was just shown by Dr. Hasnan to you. Now let's segregate it. What is the difference between these two definitions again? So the apostle says that this entity would have the first episode of decompensation in patients who have underlying cirrhosis or just chronic liver disease, for example, grade 1 to 2 fibrosis or something like that, but no prior decompensation. Acute insult they categorize as it should be an hepatic only. Variceal bleed is considered as an insult if it is leading to liver failure, organ failure, liver failure should be there, and for the liver failure they use 3 things. 1, bilirubin, 2, INR, 3, clinical manifestations, which is hepatic encephalopathy or ascites. Duration, they made a cutoff of 4 weeks, and these definitions are actually based on the liver involvement as a central cause, which is affected organ. Subsequently, other organ could be damaged, which will be definitely define the severity. But for the definition, the liver failure is mandatory. And they define that higher the grade of our score, higher will be the mortality. While on the other hand, EASL says the acute decompensation in cirrhotic patient with or without prior decompensation, acute insult could be hepatic or could be extrahepatic. This simply means that if somebody is having an organ failure other than the liver, that patient could also have acute on chronic liver failure. This is a very, very important point. And for the organ failure, the 6 organ failure, liver not mandatory, no specific duration is defined. Based on the existence of one of the 6 organ failure, Cliff score C is used to categorize them into no ACLF and then ACLF grade 1, 2, 3. And associated mortalities has been calculated. And these are the organs and the cutoff both of the societies actually has used to define the criteria. So the liver, mandatory for a parcel, kidney, brain, coagulation, they comes in the definition. Creatinine is not included in the definition, but for the severity. On the other hand, for the Cliff, again, these are the organ failure which is included. So this simply means that a parcel includes very early stage disease patients and a homogeneous group where they expect that the reversibility is a highly possible entity, and that is why these are the group of people where we should invest all of our resources to save them. They call it golden window period. While on the other hand, the EASL is actually says that the liver failure is not necessary, relatively is actually unhomogenized population, reversibility is a possibility, and again, this entire business is actually help also them to select the group of the people who could be offered early treatment. So this is how you can say that ORG ACLF is actually follow this group of patient, Cliff a bigger spectrum, and NEXL relatively shorter group of spectrum of people is actually included. Now this is very important. So what they call it is pre-ACLF. So in case of Hepacil, this more than 5 milligram of bilirubin with 1.5, more than 1.5 of INR is actually included in definition with one or more organ failure. But earlier than that, if the patients are actually having less than this, this is a phase where they can actually progress to pre-ACLF. This one? Thank you very much. So this concept of pre-ACLF is actually important to understand, where the easel says that the presence of liver dysfunction or failure or renal dysfunction, jab bhi kahin hoga, you can call it pre-ACLF. When the apostle says that with the symptoms of hepatitis and mild hyperbilirubinemia, this is the pre-ACLF phase. This would progress and develop acute liver failure, while on the other hand, more than 12 milligram per deciliter is considered as organ failure. More than 2.5 of INR is considered as organ failure by easel, which simply means that this cutoff defines the organ failure, but less than this is not considered as a liver failure by easel. On the other hand, if you go into the grading system, in grade 1, 2, and 3, let me show you again. In grade 1, 2, and 3, you can see that the bilirubin level less than this is also included when you calculate these SOFAs and all. So when you give a score 1, again, different cutoff values and different cutoff values. So this brings a little discordance in the definition and the categorization of the people to label as liver one organ failure with a very, very high level of bilirubin. So that brings again a point that yes, the easel definition is more curtailing the bigger group, but relatively less homogeneous group of people. And APASL is actually making a very homogeneous group, aiming that these people should be identified during early phases, and you can use your resources to save this group of patients. But what's that? For so many years, we're just struggling on the definition. Let's put some focus on the treatment. So in 2024, what we can offer to them is more or less same what we can actually offer to the patient who are having decompensated cirrhosis. So today you can say that, see, whether this is easel definition or this is a APASL definition, the management is more or less same. If the patient will deteriorate, I'll refer to the liver transplantation. Other than that, the standard of care to be provided to these patients. But the implication will come in the later year if we could actually really identify ACLF group, and we can actually put our energies and efforts and resources to identify the treatment option for these patients. Prognosis will change, mortality will change. So right now, identification of the group of people who can offer liver transplantation early is the key, where is actually we can say, okay, it is important for me to decide about कि जी इस patient को ACLF है या नहीं है. So for following that, the easel make it simple that if somebody is actually having an ARC score of less than 10 and MELD of less than 30, these are the patients where you can actually give them a conservative treatment. If there is a no improvement, these patients should go for the liver transplantation. So similarities, both require 2 insults, which is acute and chronic. Both consider ACLF as a reversible condition. The definition holds true irrespective of the etiology. Alcohol, viral hepatitis, drugs, post-surgical decompensation are considered as acute insults by both. Both of them include underlying chronic liver disease, cirrhosis, and stable chronic liver disease. Include the short-term mortality, 28 to 90 days. Liver transplantation is the definitive therapy, must be decided upon early phase. Both ARC and CLIF SOFA score can predict post-liver transplant survival rate accurately. The key differences in defining the organ failure, for example, the liver failure in terms of bilirubin and the coagulopathy. Hepatic versus non-hepatic insults. APASL doesn't include all extrahepatic insults as in the definition of ACLF. The presence or absence of prior decompensation is a major difference between the two societies' definition. But what could be offered? What could be actually offered further? So the one of the two options could be that it could be the liver failure, the same cutoff, but relatively may expand the definition, where you can include one or more than two organ failure and at least kidney in the definition, versus categorizing them into type A or type B. So this idea is proposed by Professor Serene, but it appeared to me a relatively more complex, where he said that follow Apostle and Japanese classification group as a type A and relatively bigger non-homogeneous group as a type B, but to me this will not change the situation to bring a crisp definition. So it seems like we need to come up with a definition backed by the objective analysis of the available data, where we can exactly see that, okay, these component adding in the definition as a matrix will give you to identify the group of patients who fulfill the definition of ACLF. And with that, again, my emphasis would be that, see, there are subtle difference, but we should now move forward to put our energies to identify the treatment options for this group of patients. However, in the liver transplant criteria, the priority could be given to these patients when they are in early golden window time period, acute on chronic liver failure, whether they're stable or not, the point could be is actually assigned to them so that they can come up higher on the list, on the liver transplant list, wherever these systems are available. With that, I will might leave you a little confused again. I tried to segregate it, that's why I remain focused on the definition and the scoring system, but this is something which will confuse you many people. Here I will end. Thank you very much, ladies and gentlemen, and you all are welcome in our 18th annual meeting of Pakistan Society of Study of Liver Disease, going to be held in Karachi, December 13 to 15. Thank you.
Thank you, Dr. Amna, for an excellent and enthusiastic talk on acute on chronic liver failure. Yes, and very well explained regarding the East versus West difference and the importance of the puzzle definition of the acute on chronic liver failure. Because we are running short of time, so I would like to request the audience that if they have any questions, so before the tea break, so we can have those questions collectively after this session. So any word from the chairs?
बिस्मिल्लाहिर्रहमानिर्रहीम। हसनैन अली शाह साहब ने मुझसे टाइम मांगा था, तो मुझे एक पुरानी बात याद आ गई। हसनैन साहब मुझसे 1 साल सीनियर थे किंग एडवर्ड में, एक ही वार्ड में हम काम करते थे। ये मेरे एसओएचओ थे, मैं जूनियर हाउस ऑफिसर था, तो ये एसएचओ थे मेरे। तो अब मैं एसएचओ साहब का टाइम तो लिमिट नहीं कर सकता, तो सर आपसे गुस्ताखी अगर मुझसे हुई तो माफ़ कर दें। सीनियर हाउस ऑफिसर आजकल एसएचओ का कुछ और मतलब भी होता है। आई एंजॉयड दिस टॉपिक। देखिए, मेरा ख्याल है ऑर्गेनाइजर से कि ये टॉपिक फर्स्ट टॉपिक होना चाहिए था, पोस्ट प्रेंडियल टॉपिक ये ठीक नहीं था। There was too much of terminology and jargon. Or I think we were, allow me to say this, कि हम उलझ गए definitions में, classifications में, 2 point ऊपर में, 2 point नीचे में. I would have loved to hear what are the guidelines in the management of acute on chronic liver failure. I think किंग्स कॉलेज वाले बहुत अच्छा लेक्चर देते हैं इसका, कभी किसी को हो तो उसकी वीडियो आप सुने। सो व्हाट वर द टेक होम मैसेजेस एज फार एज द मैनेजमेंट ऑफ ACLS इज कंसर्न। ये छोटे छोटे डिफरेंसेस ईस्ट और वेस्ट के, आई डोंट थिंक दे मैटर टू मच। ACLF जो है, इट इज़ द पिनिकल ऑफ टेस्टिंग ऑफ योर क्लिनिकल स्किल्स एज अ हेपेटोलॉजिस्ट, और जिसके अंडर एक भी ACLF का पेशेंट एडमिटेड होता है, उसको कॉलिक भी होती है, उसको IBS शुरू हो जाता है। उसको रात को उठ के वो उस पेशेंट के सोडियम, मैग्नीशियम, बिलिरुबिन, कोआगुलेशन प्रोफाइल और पता नहीं क्या क्या कुछ सोचता रहता है और पूछता रहता है. इट्स अ वेरी चैलेंजिंग टॉपिक. और मेरा ख्याल है इसके ऊपर एक बड़ा ब्रॉड सिंगल टॉपिक कॉन्फ्रेंस होनी चाहिए जिसमें स्टेप बाय स्टेप हमने ज़्यादती की इन दोनों स्पीकर्स के साथ कि हमने इनको पूरे का पूरा ACLF एक हंडिया में बंद करने के लिए कह दिया. सो दे हैड टू गो वेरी रैपिडली. सो यही स्लाइड्स अगर हम आहिस्ता आहिस्ता देखते तो वी वुड हैव बीन मोर नॉलेजेबल. बट थैंक यू वेरी मच फॉर अ वेरी ग्रेट एफर्ट एंड आई एम श्योर देयर विल बी वेरी मैनी लर्निंग पॉइंट्स हेयर. एटलीस्ट हमें पता लगा कि ईजल और APSL में ACLF की डेफिनेशन में क्या फ़र्क है और उससे आउटकम में क्या फ़र्क पड़ता है. Thank you very much. Would you like to say something?
Yes, thank you very much to both the speakers. This is indeed a very important topic, and I would like to second Dr. Arif as well that it's definitely a very disturbing part of our hepatologist's life when a patient with ACLF comes to us. Just one thing to add, that these scores should be not considered as a day one scores. These scores are very, very dynamic scores. So day one, someone might present with hepatic encephalopathy and they might actually not manifest the renal failure, which might come in a couple of days later, and then the sepsis, and then after the sepsis they might go into hepatic encephalopathy back again, and then subsequently develop respiratory failure. So these are very dynamic scores. When we are considering someone for liver transplantation, it is very important that we need to set in the right people for liver transplantation who've got ACLF. So day one assessments, day two assessments, and dynamic scoring system, and it's a clinical day-to-day judgment for each and every patient. You cannot put same guidelines on each and every patient. This is my comment regarding selection of patients who are supposed to be liver transplanted with ACLF.
Thank you, Professor Arif Siddiqui and Dr. Atif Majid, for your kind comments. With this, we wrap up this session, and we'll move towards the next session, which will be moderated by Dr. Noman Siddiqui, and it's based on the mixed diseases. And mystery one, it's basically on autoimmune hepatitis and associated disorders. Yeah, before that, I would like to ask the presenters, the moderator.
Thank you, Dr. Raha. Assalamu alaikum, ladies and gentlemen. It is indeed a matter of great pleasure and immense pleasure for me to welcome you all to this afternoon session of day one of 24th Annual Conference of Pakistan Society of Hepatology. I am Dr. Noman Karim Qureshi, Assistant Professor Gastroenterology and Hepatology, CMH, Sheikh Khalifa bin Zayed Hospital, Muzaffarabad, Azad, Jammu and Kashmir. Also, I am the regional representative of Pakistan Society of Hepatology for the region of the North. We are delighted and privileged to have some well-renowned and highly reputed gastroenterologists here with us who will chair the session. It is the perfect opportunity for all of us to benefit from their wisdom, knowledge, and expertise. Among these, we have Professor Hussain Ali Shah, Professor Altaf Alam. He is the professor of the gastroenterology, ex-head of department, Sheikh Khalifa bin Sheikh Zayed Hospital, Lahore. Sir, I request Professor Altaf Alam to come to the stage as the chair. Sir? Okay, our second chairperson is Dr. Hamad Ashraf. He is the fellow of Royal College of Physicians, London, Edinburgh, as well as Glasgow. He practices in NHS UK as well as in Pakistan Evercare Hospital, Lahore. He has acquired formal training in transplant hepatology from various transplant centers in the UK, including King College Hospital, Royal Free Hospital, and Cambridge University Hospital. Sir, please come and join the stage. Our third chairperson is Dr. Yasser Abbas Zedi. He is MRCP, FCPS Gastroenterology. He is the Associate Professor and Chairperson, Gastroenterology and Hepatology, National Medical University and Hospital Multan. Dr. Zaidi is a very dynamic gastroenterologist with more than 13 years experience in his field. He has 27 research articles in both national and international journals. Please come to the stage. Finally, we have our last chairperson, who is Dr. Saeed Anwar. He is the MD Gastroenterology. He is the Assistant Professor Gastroenterology, Kharia Medical College, Kharia. He has more than 10 years experience in the field of gastroenterology and hepatology, and many research articles published in the national journals. So please join the stage. To start with the session is about recent advances and updates in different aspects of the liver diseases to help gastroenterologists to keep pace with changing practices and ever-changing guidelines. There will be 4 lectures to update us, and then there will be questions and answers at the end of the session. Now, without any further delay, we will move to the presentations. Remember the rule that each presentation has to be finished within 15 minutes. Our first topic is primary biliary cirrhosis, updates in the management and goals of treatment. It will be presented by Dr. Junaid Mushtaq. He is MRCP and FCBS in gastroenterology. He is the Assistant Professor of Gastroenterology at Services Institute of Medical Sciences. He is the author of many national and international publications, currently working in IBD registry these days. Sir, please come to the stage for your talk.
Thank you very much, and I'm really grateful to Pakistan Society of Hepatology for giving me this opportunity and for the kind introduction as well. To begin with, my topic for today's presentation is primary biliary cholangitis. We'll be talking about the updates on the management in these patients. So taking this opportunity, I wanted to be the audience to be acquainted to what's the latest updates on primary biliary cirrhosis, as we'll be seeing a lot of press releases in 2023, and there has been a lot of work going on in the new management options. So I'll be highlighting the treatment options, what are the current practices in the treatment and the diagnosis of primary biliary cirrhosis. There has been some new concepts that had been introduced in year 2023, and many FDA-approved drugs has been in the pipeline. We'll be discussing some phase 2 trials and the phase 3 trials, as their publication has been issued in 2023. And a lot of work is going on towards the development of these phase 3 trials, and they might be available in 2024. So it's been known for more than 5 decades now. Initially, the primary biliary cirrhosis name was given because there wasn't any pathology that was linked to the disease, and later on it was known to be an autoimmune entity. As most of the patients has autoimmune antibodies present, that is antimitochondrial specificity. So later on, the name was changed as because of the early diagnosis in the patients, and the diagnosis was made when there wasn't any cirrhosis in the patients. So they named it to be, the name of the nomenclature was primary biliary cholangitis. So now we are heading towards the potential new drugs which will be available in the market real soon, changing the pathophysiology of the primary biliary cirrhosis. So we're all familiar that this is an autoimmune condition where you see a patient with a cholestatic pattern of liver injury, and most of the patients are female in the middle age group, and they usually present to be asymptomatic or might have some pruritus, fatigue, and poor quality of life. So you see cholestatic biochemical changes in patients with raised alkaline phosphatase with the specific autoantibodies of antimitochondrial nature. And if you go for the liver biopsy, you see periductal inflammation with chronic inflammatory cells and ductopenia. So to establish the diagnosis, you need to have 2 out of 3 criteria, as this is supported by EASL and AASCLD as well. So while doing the liver biopsy, you see periductal inflammation with ductopenia, chronic inflammatory cells, granuloma formations, and leading to cirrhosis. So you have all seen this picture quite frequently, where you see a patient with high alkaline phosphatase, GGT. You do an ultrasound, rule out the viral serology, and go for specific serological markers that AMA and ANA, you might need to rule out PSC as well and drug-induced liver injuries. So if you still cannot make a diagnosis, you may embark onto liver biopsy to rule out other concomitant problems as well, like MASH or autoimmune hepatitis. So it's an immune-mediated injury that could be environmental, could be viral, or maybe a genetic predisposition that leads to the biliary destruction in these patients that activated by the macrophages, B cells and T cell mediated, resulting in recurrent damage to the biliary tract system, leading to ductopenia and causing the symptoms in these patients. So most of the patients, they'll present to you with an extrahepatic manifestations, primarily complaining of fatigue, pruritus in these patients. They might have Raynaud's phenomena, they might have Sika syndrome, and they might present with vitamin deficiencies as well. There might be restlessness, cognitive impairment as being the primary symptoms when seeking a medical advice. So hepatic manifestations are way later when there is an advanced fibrosis, or you see the hepatic manifestations as significant portal hypertension. You might see problems like ascites, hepatic encephalopathy, hepatocellular carcinoma as well. So while evaluating these problems, you need to address these associations like autoimmunity in the family or in the person, smoking, recurrent urinary tract infections, osteoporosis, night blindness as well. So this is one of very important component is risk stratification in the patients with primary biliary cirrhosis before deciding on the treatment plan for the patients. In the past, it has been done very frequently by doing a liver biopsy initially and in the follow-ups as well. But now most of the centers, they are following the fibroscan or the elastography or MR elastography. So each of them, whichever your center is following, so you need to have a very good hold on the values, each of these fibrosis scoring systems. So our center is mostly performing the fibroscan, and the values are 8 and 15. So these are the similar ones that are used in the MEFILD and the MASH as well. So there's a problem with the overlap syndrome when you see non-specific features in the patients with primary biliary cirrhosis. As you see in the biochemical, you might see a rise in the ALT or AST that does not follow the Paris criteria of the primary biliary cirrhosis, with a raise IgG levels and smooth muscle antibodies as well. So here you need to do a liver biopsy to rule out an overlap syndrome to decide the further plan for the patients. Ursodeoxycholic acid has been there for more than many years now. It has been well-tested first-line treatment option for these patients, and the dose is to be 13 to 15 milligram per day. The well-tolerated is 2 divided doses, the BID dose, and you need to address which strength are you using in these patients to acquaint with the adherence to the drug. So it helps in delaying the development of the complications in these patients, reduce the death ratios and need for the liver transplantation, and even the development of the cirrhosis in this patient. They improve the overall survival of these patients. So using different criteria to check on the response to the ursodeoxycholic acid, there has been many binary systems and the continuous systems. So most of the data that is available is using the GLOBE score, that is a continuous score, which use different parameters. It is available online, which should be done at the baseline and the follow-up 1 year after initiation of the treatment. So, all the new trials that has been done, they have been incorporating GLOBE score as their primary scoring system to evaluate the patient with treatment response to the in favor of the GLOBE score. So people do lose towards the failure of ursodeoxycholic acid, and interestingly, many studies have shown that up to 60% of the patient if diagnosed early, they do lose a response to the ursodeoxycholic acid. So this is quite concerning. And what a clinician should you do when a patient with a loss of response to the backbone of the treatment is that is ursodeoxycholic acid presented to you? First of all, you need to check to the adherence to the drug, as most of the patient might not be taking it at the right amount, or they might be having some complications while taking the ursodeoxycholic acid, and could be because of the weight gain, altered bowel, or may be due to the hair loss as well. Do check for the diagnosis, the concomitant comorbid conditions as well, ruling out autoimmune and MEFILD as well, or avoid any concomitant administration of bile acid sequestrants. Then you can shift the patient to a second-line treatment. So POISE is a very interesting study which shows all those patients who lose a response or who do not respond initially, they can be shifted to obeticholic acid, and you have seen that they have compared the 5 milligram to the 10 milligram. So starting with the 5 milligram and using the POISE criteria by reducing the alkaline phosphatase less than 1.67 or greater than 15% reduction to the baseline, or the normalization of the bilirubin. So using this liberty, many clinicians tried to shift the patients with advanced liver disease to obeticholic acid, and they have published this data that most of the patients who were started on obeticholic acid, they had a decompensation within less than 6 months of starting the treatment. After the publication, so FDA has issued a safety communication on the use of obeticholic acid by analyzing their own data of 25 patients, thereby issuing a warning in the use in the patients with an advanced liver disease. So the recommendations for the obeticholic acid that is contraindicated in the patients with child B and child C cirrhosis. However, even in those with a compensated cirrhosis who have a significant evidence of portal hypertension. However, it can be used in advanced centers with a close follow-up in the patient with an advanced fibrosis. So what are the newer concepts in terms of the treatment? So this is a very interesting data that has been shown to check the treatment response using a GLOBE score, so which shows that those patients who have a higher initial GLOBE score and they brought to a drop in the GLOBE score at a 1-year treatment, they have a better chance of survival and a better survival in these patients. Similarly, the response has been adequate, and now they're pushing towards a secondary target to the deep response, whereby presenting this data, retrospectively analyzing these patients, that if a patient has a deeper response where they have tried to normalize the alkaline phosphatase in these patients on ursodeoxycholic acid, so they have a 10 years gain in the survival of 7 to 6 months, and those with an advanced fibrosis, they have a better chance in complication-free survival of 52.8 months. So now most of the development is using this deep response as a second endpoint for the treatment of these patients. So difficult to treat patients with those who were already on obeticholic acid, and according to the POISE criteria, they have loss of response over 1 year time. So they have compared whether obeticholic acid followed by a fibrate or fibrate followed by an obeticholic acid, which one will respond better. So as you can see in the figure 2, that those who were started early on obeticholic acid and then shifted on to a triple therapy by adding a fibrate had a better chance of survival by reducing the alkaline phosphatase at 1 year time by 42% in these patients. So normalization of the biochemical tests of the liver and improving the pruritus in these patients in the limb B. This is one of an interesting studies where they shifted the patient to ursodeoxycholic acid with phenofibrates. The only difference was the results are very promising, but the only difference, they used the Barcelona scoring system rather than the GLOBE scoring system. So when comparing with the rest of the studies, it might be very difficult to interpret this recommendation, as phenofibrates might cause transaminitis in these patients by causing the drug-induced liver injury, and they do have an effect on creatinine as well. So now the interesting concept is with the use of GLOBE score, they have incorporated liver stiffness protocols as well while evaluating these patients on ursodeoxycholic acid. Bezafibrates has been in recommendation for an off-label use. The patient who, according to the POISE criteria, they have lost their response to the obeticholic acid, and it is well tolerated in the patients with a significant decline, a 1-year protocol of alkaline phosphatase. So there has to be a more workup on these bezafibrates to make it a formal recommendation what dose and what kind of patients should be shifted on bezafibrates. So what are the emerging therapies? Ursodeoxycholic acid to be the backbone of the treatment for the patient with primary biliary cholangitis. We're all familiar with FXR agonist, obeticholic acid. So the most inclination is towards the PPARs medications. So FDA has already given approval, and AASLD has already given an acceptance to the phenofibrates as well. So all these medications are at different pathways of the pathogenesis of the disease by blocking the bile acid absorption, by reducing the immune modulation, and by decreasing the inflammation and metabolism of the bile acid homeostasis. So PPARs, there are various different PPARs. They are in the pipeline. We'll be talking more about the delta ones, that is elafibranor and seladelpar. So this is one of the phase 2 data from elafibranor, which is primarily the delta and have some alpha component as well. It is a well-tolerated drug, and a dose of 80 milligram and 120 milligram was initiated for 12 weeks, which shows a significant decline according to the POISE criteria, and that shows a significant drop in the alkaline phosphatase in these patients, and there wasn't any worsening of the pruritus or exacerbation that was induced by the drug. Later on, it was extended, and only the 80 milligram was used. As from the last slide, you can see that 80 and 120 milligram did not show much of the difference in the response to the drug. So in comparison to the placebo, 51% to 41% in the patients with placebo to the elafibranor. Seladelpar has a similar results, but the problem with the seladelpar was while doing MEFILD trial, they have seen some of the side effects in the and FDA has issued some warnings. So we only have 12 weeks data, 12 months data of these patients on the seladelpar. So this also has shown similar effects as seen in the elafibranor as well. So I'll just quickly go through the names. The seladelpar has been, a trial has been suspended, and no further enrollments in this phase 3 after the phase 3 press release in these patients. We're familiar with the obeticholic acid, and we're not sure about which dose along with the obeticholic acid, but you can see that 10 milligram and 400 milligram of bezafibrates have shown a significant reduction at the 12 weeks. So this is one of very interesting, which shows initially that sitanexib, this is a NOX inhibitor, which shows there wasn't any significant decline in the GGT and alkaline phosphatase. However, when they retrospectively re-evaluated the data, so those patients who have an advanced fibrosis on the FibroScan value greater than 9.6, they had a significant improvement in the fibrosis at 24 weeks. So which given it a chance to go into the phase 3 trial, and this is the only drug so far which has improved the fibrosis in the patients with primary biliary cholangitis. So a lot of new drugs are still going on, and we still only have a data from European and the Japanese ethnicity. We don't have any local data that is available. So thank you very much.
Thank you, Dr. Junaid, for such a nice talk. Our next talk is Recent Advances and Future Prospects in the Management of Autoimmune Hepatitis, and it will be presented by Professor Arshad Kamal Bhatt. He is working as DGI at UHS and practicing at Choktai Medical Center. He has more than 39 years experience as a medical educationist and researcher, including his 24 years as a professor of gastroenterology at Sheikh Zayed Hospital, Lahore. Also, he is my teacher and my mentor. Thank you, sir. Welcome.
Thank you very much, Dr. Nawan. Dr. Nawan was very firm, and he declared a rule. The talk has to be limited to 15 minutes. My submission is rules are meant to be broken. And I might overstep my allocated time by a few minutes, and I would thank the chair and the co-chair for being so supportive and understanding. Okay. Ladies and gentlemen, I must express my deep gratitude to the organizers of PSH 2024 for giving me an opportunity to talk about autoimmune hepatitis, how we treat it now, and what is for the future. I have no financial disclosures related to this presentation, although it looks impressive, we have something to declare. Treatment of autoimmune hepatitis, or AIH as it is called, it's a huge topic and whole days can be allocated to it. So in the interest of time, I'm going to limit my talk and talk about some basic reminders as a foundation with reference to historical overview, just a passing reference to the clinical features, a bit of details about pathogenesis and pathology, because if we know what is the pathophysiology, we can understand why a particular molecule is being used and how it works, and a reference to the diagnostic approach, and finally, what is the treatment as we practice it today and what is for the future. Now, let me take you onto the history lane. A journey of treatment of autoimmune hepatitis has spread over 74 years. The disease was described first way back in 1950 by Dr. Weldenstorm, the same gentleman with whom Weldenstorm's macroglobulinemia is associated with. He reported this disease along with the clinical and lab features in a group of women who had SLE. And based on his description, it was named as leukopenia hepatitis. However, subsequently, 10 years later, it was found that patients who did not have SLE also presented with similar features. And therefore, the name was changed to autoimmune hepatitis because it had a very strong immunological basis. And this nomenclature has persisted up till today. And please remember, at that time, hepatitis B was not known. We didn't even hear about hepatitis C at that time. And therefore, autoimmune hepatitis was the first chronic liver disease for which a dedicated treatment was available. And that was in the form of corticosteroids, subsequently beefed up with azathioprine. We didn't find anything new for the next about 20 years or so. Same corticosteroids and same azathioprine was used. However, beginning of 2000, 2001 and 2, our colleagues in nephrology and in rheumatology had been using immune modulators. And therefore, the hepatologists also got interested in this mode of treatment. And now there are certain trials which are undergoing, and some of them are nearing completion, like the JKB 122, EMBER and FORTOLA trial, and hopefully by the end of this year or maybe next year, we will have more data available to recommend some robust method of treatment. Now, a quick overview of hepatitis, autoimmune hepatitis. We know it's a disease of chronic hepatocellular injury, of which we don't know the etiology. It is characterized histologically by what we call interface hepatitis. Previously used to call it piecemeal necrosis. There is predominant aminotransferase elevation with relatively little elevation of alkaline phosphatase. But if you find the ALP levels elevated as well significantly, do look at other possibilities. The characteristic hallmark, biochemically speaking, is high immunoglobulin levels, predominantly IgG, and autoantibodies. And then you also need to exclude other chronic diseases. It can have varying presentations, completely asymptomatic in 30%, discovered because LFTs were done for some other reason. 40% could have chronic hepatitis, sometimes presents with acute hepatitis and even acute failure. The picture could mimic cholestatic hepatitis, and if the disease is left untreated for years, patients could end up with cirrhosis with all its complications: portal hypertension, ascites, bleeding, varices, even hepatocellular carcinoma and liver failure. So what are the clinical features of AIH? No different from other causes. You can't differentiate AIH from other causes of chronic liver disease based purely on clinical features. But please remember, since it has a very strong immunological basis, it has a strong association with other autoimmune disorders as well. So do screen your patients for diabetes, type 1, celiac disease, if appropriate, thyroid disorders, and other autoimmune disorders as well. To understand the pathogenesis and pathology of AIH, let's go back to some basic immunology. We know that the immune system, which works in our bodies to prevent infection from exogenous antigens, whether they are bacteria or viruses or parasites or whatever, is primarily a two-pronged attack. One pillar is the cell-mediated toxicity, the other one is humoral toxicity, and they supplement and complement each other. Whenever an antigen gains access to our bodies, the antigen-presenting cells are activated, and they present this antigen to quiescent T lymphocytes, labeled as T0 cells. These cells become active and are transformed into active lymphocytes known as CD4 cells. These CD4 lymphocytes have two primary functions. One, they cause the B cells to be transformed into plasma cells and start secreting antibodies against the invader, and at the same time they also stimulate the formation and proliferation of CD8 cells, which have the capacity and the capability to directly attack the invader. This is called cell-mediated toxicity. In addition, there is a third actor, that is the T regulatory cell, or the Treg cell as it's called. This is required to keep the CD4 and CD8 cells at bay. Otherwise, there will be an uncontrolled, unbridled storm of immune response. And therefore, the Treg cells are required to promote tolerance to native antigens. Primarily, AIH, in a nutshell, is a breakdown of immunological tolerance to self-antigens. And why it happens? There are three possible mechanisms. One is called molecular mimicry, where the invading organism has certain antigens which are similar to local antigens. And the immune response directed against those foreign antigens mistakenly destroy our native antigens. The second one is disturbances of T cell, primarily dysfunctional or low numbers of T regulatory cells which cannot control the immune response of the CD4 and CD8 cells, and finally overactivation of the beta cells, and that is what's shown here, molecular mimicry, where the proteins on the surface of hepatocytes are similar to the proteins, let's say on hepatitis C virus, and this, T cells are then directed to attack not only Hep C, but also liver cells. This is what Sherlock Holmes would have called a case of mistaken identity. The second one is loss of self-tolerance. As we all know, T regulatory cells are required for self-tolerance. If they are gone, uncontrolled, unbridled, and unmonitored immunological response has the capacity to damage the hepatocytes. So basically, excuse me, it is antibody-dependent cytotoxicity because of T cells, complement-dependent cytotoxicity, pro-inflammatory cytokines like interleukins and tumor necrosis factor, and cell-mediated cytotoxicity. So there are a certain number of antibodies which are associated with AIH. The conventional ones, we all know ANA, SMA, LKM. But there are certain unconventional like SLA, soluble liver antigen, AMA, PNK, and anti-liver cytosol antibodies. Please remember, out of these, the soluble liver antigen is almost 99% specific for AIH. So in an appropriate patient with an appropriate clinical feature, if you find SLA positive, that is autoimmune hepatitis. But also remember, these antibodies are not limited by any way to AIH. They can be seen in other conditions as well, and I've listed these conditions here. AIH, by the way, is not a single entity. It's a heterogeneous group with two different and probably three different variants. all of them have a female preponderance with different age groups. For example, type 1 can be seen in any age group, but type 2 is almost exclusively limited to children and young adolescents. Type 3, if it exists, it is questionable, is usually seen beyond 30 to 50 years of age. All of these have the different antibodies with anti-LKM limited to type 2 and soluble liver antigen seen in all. Response to corticosteroids, which is the mainstay of treatment in these patients, progressively declines as we grow from type 1 to type 3 autoimmune hepatitis. How to diagnose it? You have to exclude other liver diseases which can cause chronic liver disease. All the diseases, metabolic disorders, viral hepatitis, DILI, alcohol, so on and so forth, all have to be excluded. To make a definitive diagnosis of autoimmune hepatitis, way back in 1999, the international group suggested that we take into consideration these various factors, and they came up with a scoring system where each parameter is given a particular score. The composite score, if it is equal to or more than 15, is definite autoimmune hepatitis. If it is between 10 to 15, it's probable. Less than 10, you're not sure. This is too cumbersome, at least I can't remember this thing. So to make my life simple, the same group came up with another criteria called the simplified criteria, which only considered 4 parameters. Autoantibodies, ANA, ASMA, LKM1, and soluble liver antigen, IgG, which is typically elevated, histology showing interface hepatitis, and exclusion of viral hepatitis. And again, each parameter is given one score, definite score. If the total score is 7, it is definite AIH. If it is more than 6 and up till 7, then it's probable. Now you will notice that the maximum score can never be more than 6 if we take out liver histology. The maximum score for autoantibodies is 2, for IgG is 2, and for epsilon viral hepatitis, that adds up to 6. So if you don't have a liver biopsy, you are still, where are we? Still in the realm of probable autoimmune hepatitis. The bottom line is, for the diagnosis of AIH, you need liver biopsy. This scoring system, although very good, can miss 2 groups of patients, those with acute liver failure and those who are in the pediatric age group. Now, armed with all this knowledge, let's come on to treatment considerations. The goals of treatment on these patients are, we need to induce remission, we need to prevent disease progression, the relapses must be minimized, and survival must be improved. The historical approach was, since it is an autoimmune disorder which deranged immunity, so let's suppress immunity, a broad blanket immunosuppression. However, in recent years, beginning in year 2001 and 2, we have realized that rather than a complete immunosuppression, we should be focusing on what is called targeted immunomodulation. Identify the basic mechanism involved and target that mechanism. In other words, the paradigm shift is from a broad immunosuppression go on to immune modulation, because one size does not fit all. So who qualifies for treatment? Do you treat everyone? No. If the patient is clinically asymptomatic or is completely intolerant of therapy, you have to stop treatment or don't give it in the first place. If the AST LDL levels are less than 3 times the upper limit of normal, these patients can be observed. If the liver biopsy shows inactive cirrhosis or portal hepatitis, again, they do not qualify for treatment. Other than that, if the symptoms are incapacitating, there is relentless progression of disease, the AST LDL are more than 10 times normal, or the gamma globulins are more than twice the upper limit of normal, and the liver biopsy shows bridging necrosis, that's an absolute indication. And you can make a case for relative indication in between these 2 categories. But in decompensated cirrhosis, prepare the patient for liver transplant. In terms of managing these patients, we need to be very clear, what do we mean by response? Remission is either biochemical or histological. Normalization of liver biochemistry and immunoglobulin levels, resolution of inflammation. And treatment failure would be worsening of labs and histology despite adequate treatment, and despite full compliance. Incomplete response is defined as improvement in liver histology or labs, but less than the minimum remission criteria, which is at least 50% within 4 weeks. Relapse, obviously, once you stop the treatment, the disease comes back, that is relapse. And intolerance would be when the patient cannot tolerance or cannot continue with the therapy because of intolerable side effects. And this is the time frame. Once you have started the patient on treatment, within 4 weeks, ALT levels and immunoglobulins should reduce by at least 50%. If they don't, this is a non-responder. Within 6 months, these levels should totally normalize. If not, then this is an insufficient response. And remission is when you withdraw the treatment, the patient maintains normal liver biology, histology and liver enzymes. If they don't, that's a relapse. Now, AIH treatment as we know it today, basically the mainstay or the backbone is prednisolone, one of the steroids, or prednisone, along with budesonide and azathioprine. You can either choose prednisolone or budesonide plus azathioprine. Now, how do we treat them? Stratify your patients according to the clinical status. If they are treatment naive, use prednisolone at 30 milligrams per day and for 1 week along with azathioprine. I'm not a great proponent of monotherapy because that means a lot of steroids and a lot of side effects. Reduce it to 20 after 1 week and 15 after another week. Maintain them on 15. And if the biochemical parameters are stable, use the lowest possible dose, but keep azathioprine on 50 milligrams per day. For incomplete response, you have to increase azathioprine to 2 milligram per kilogram per day. If the disease progresses, use a higher dose of steroid and a higher dose of azathioprine. With drug toxicity, identify which drug is causing the problem, reduce that, or discontinue it altogether and increase the dose of the other drug. And if that doesn't work, you can use mycophenolate or MMF, which by the way is a second-line treatment. So if you look at the treatment options, 60 to 70% of patients will achieve remission, but this happy outcome is not maintained. 70% of these 60% will relapse. Only 30% will remain in remission. About 13% will either have an incomplete response or you're forced to withdraw drugs because of drug toxicity, and 10% will show disease progression despite your best efforts. What else can you offer them? Third-line treatments, we have budesonide, cyclosporin, tacrolimus, mycophenolate, cyclophosphamide. Each has its advantages and disadvantages. Our colleagues in nephrology and rheumatology are far more experienced. Do enlist their help and when you're treating these patients. What are the possible future treatments? We have thiopurines, mercaptopurines, and thioguanine, which are the metabolites of azathioprine, mTOR inhibitors, monoclonal antibodies, we are quite familiar with them. Novel agents are there. Chloroquine, somehow this drug simply refuses to die. It was used for malaria, and last time I heard it was used for, I think, corona as well. And finally, we have adoptive Treg cell or T-reg cell transfer. Remember I told you earlier on, the T regulatory cells, if they are reduced in number, inflammation of the liver will proceed unabated. So transferring or translocating active T regulatory cells from a genetically similar individual is likely to dampen down the inflammation. And this is the mechanism of action. All of these ultimately lead to regression of pro-inflammatory genes and activation of the anti-inflammatory genes and bring about resolution of inflammation. How long to treat? If there's suboptimal response, indefinite. With complete remission, at least 2 years. Ideal endpoints would be normal liver biochemistry and normal liver histology with a liver biopsy. Gradually taper off steroids and azathioprine, but remember, monitor your patients after stopping treatment. 1 month for the first 3 months, 6 monthly for the first year, and once a year thereafter. Because why? Once autoimmune hepatitis, always autoimmune hepatitis. Don't lose your patients, don't forget about it. And don't forget the patient's perspective as well. Patient is not concerned about liver histology or liver biology or liver biochemistry. They want a drug with least side effects. They want it to be cost effective. They want quick, rapid symptomatic improvement. Nobody wants daily medicines. Once a week, or maybe if you have something once a month would be more desirable. And I can assure you, it's a big no-no for liver biopsy from the patients. So take home message, ladies and gentlemen, AIH is a lifelong remitting relapsing disease. It has got a strong immunopathogenic background, can present in various ways. We do not have a single diagnostic signature. Even today, steroids and azathioprine are the mainstays of treatment, but good news are there. We have second and third line treatments and newer molecules on the horizon. But a word of caution here, please remember the new molecules which I've mentioned, they are to be taken very seriously. Sometimes they can produce miraculous improvement in your liver biochemistry, but sometimes they have very serious side effects. And to this end, I'm reminded of advice given by the master physician of last century, Sir Robert Hudson. For too much zeal for what is new and too much contempt for what is old, good Lord deliver us. Thank you very much for your patient listening. Thank you very much indeed.
Thank you, sir, for such an elaborative review. Now moving to our next talk, which is emerging insight into the diagnosis and management of Wilson disease. It will be presented by Professor Shahid Sarwar. He is the Professor of Medicine and Gastroenterology at Allama Iqbal Medical College, Lahore for 3 years, and also visiting physician at Jinnah Hospital, Doctors Hospital, and Bahri International Hospital. He has more than 15 publications in national and international impact factor journals with more than 700 citations and supervising postgrad trainees in gastroenterology. Sir, come for your talk.
Bismillahirrahmanirrahim. I am extremely thankful to PSH for giving me this opportunity, and I have a very difficult job to follow up my teacher, such an excellent presentation, and to keep all of you awake at this time of the day. My talk is going to be about Wilson's disease, and Wilson's, for a disease which is as unusual and uncommon as the Wilson's is, new emerging trends and new treatments and diagnosis can take decades. So what I'm going to do is I'm going to review the existing pathophysiology and clinical manifestation, existing standards for diagnosis and management, and we'll see what are the new options that we may have in future regarding this disease. We all know this is a disease of a younger age, and majority of patients are diagnosed around the age of 20 to 30. But around 3% of them are going to be diagnosed after the age of 40. And interestingly, the first organ or first system which is manifesting for Wilson's disease changes from hepatic to neurological as the age advances at the time of diagnosis. At an older age, more and more neurological manifestation becomes the first manifestation. It basically is a genetic disease in which there is ATP7B mutation at chromosome 13, and there are more than 800 mutations which are associated with this disease. It's an autosomal recessive, so there is risk for first degree and second degree death. Primarily, ATP7 gene is responsible for production of ATPase. That is a transporting protein, which is responsible for transporting copper across the trans-Golgi network. And that particular copper has to be incorporated into apoceruloplasmin to convert into holoceruloplasmin, which is then released into the circulation. So once the copper is not going to be transported into the Golgi network, then obviously the ceruloplasmin is not going to be matured and it will not be released into circulation. The copper will start accumulating within the cell, resulting in damage to the cell. And once this copper starts releasing into the circulation, it can produce manifestations in the other systems of the body as well. So the cellular damage starts from the liver or the brain or the other organs which are inflicted with this copper deposition, and that will result in the clinical manifestations. So the different clinical manifestations, we know it can present with hepatic, neurological, or involvement of the cardiovascular system. Then we have got manifestations related to the kidney system as well, and obviously rarely joint can be involved in this disease as well. So in liver disease, majority, there is a big number of patients are going to be diagnosed in routine workup for somebody who has got deranged LFTs, and you start working them up and you come up with the diagnosis that patient has Wilson's. But a certain percentage of patients will present with acute hepatitis, and a very small percentage will present with acute liver failure. Around 6 to 12% of the patients of acute liver failure are basically of Wilson's disease, and especially at a younger age, it becomes a very difficult situation to handle because the only treatment for this situation is liver transplantation. And then there are patients who will be diagnosed at the stage of liver cirrhosis. The first presentation will be when they already have developed a liver cirrhosis with its associated complications. As far as the neurological manifestation, there is wide diversity in that. There are people who are going to present with Parkinsonism-like symptoms, which is basically akinetic rigid syndrome. Then people can have pseudosclerosis, in which there are certain types of tremors which are afflicting them, and it's greatly disabilitating for the patient. Then patients may present with dystonia, rigidity of the whole body, with difficulty in movement and day-to-day activity. And then a certain percentage of patients can present with psychiatric manifestation. And this is the one group which may remain undiagnosed for many years, maybe presenting with poor performance at the school, presenting with depression, presenting with psychological manifestations. So that's personality changes. That's one aspect, especially at a younger age, that we need to keep in mind, that probably Wilson can be one of the possible cause, one of the possible treatable cause in these patients with psychological manifestations. Just to give you an idea how debilitating this disease can be, this is basically dystonia, where whole of the body becomes stiff and patient has a lot of difficulty in movements. And this is what is classical wing beating tremors, which may be seen in these patients. We are all familiar with KF rings, which can be used, which are basically used for the diagnosis of Wilson's disease due to the deposition of copper at the descendant membrane. And then there are a lot of other manifestations in hematological, renal, musculoskeletal, cardiac, or these disease can also afflict the fertility of the patient and rarely can present with gallstones and pancreatitis as well. Now, moving on to the diagnosis. There are multiple tests which are available, and we are all familiar with ceruloplasmin, 24-hour urinary copper, and all those. But none of these tests has good enough sensitivity and specificity to be diagnostic as a standalone test. So you always use the combination of these tests. Now let's see what's the limitation. Ceruloplasmin is the one which we usually go for as the first test for when we are suspecting Wilson's disease. And normally somebody with less than 20 milligram per deciliter is suggestive. Less than 10 is all the more suggestive for this diagnosis. But there are conditions which may lead to false positive or false negative, because we know it's a protein, so it may be normal in somebody with Wilson's if patient is pregnant or there is other acute inflammation going on, and it can be low even without the presence of Wilson's disease in patients with malabsorption, protein energy malnutrition, and things like that. So the positive predictive value of this particular test is not very good. Then serum free copper, it's not the total copper, it has to be free copper, which is to be advised for this particular diagnosis. That is also raised in so many other acute illnesses where Wilson's may not be present. Then the 24-hour urinary copper, a very popular test for this. It has got very good sensitivity, and generally the value above 100 microgram per 24-hour is suggestive. The higher the value is more likely that this patient may have. But obviously there is a certain way of collecting the urine, there is a certain way of getting this test done, and it can be raised in other diseases as well. And it can be normal in people who are especially asymptomatic with the Wilson's disease. So, and there is another test for such situation where you have difficulty in diagnosis, is the penicillamine challenge test. You just give 500 milligram in the morning and 500 after 12 hours and collect 24-hour urine. If the value is more than 160 microgram in 24 hours, that's another way of diagnosing these patients. So how to use these tests? There are so many tests, and how to use it for the diagnosis. Obviously, a gold standard test, supposed to be gold standard test, is liver biopsy. And there you have to specifically ask for this staining for the copper. Otherwise, it's not going to help. Otherwise, the features are the same as you find in any chronic liver disease. So you may use arsine stain, which is going to stain the metallothionein, or rhodonine with robionic acid, which is basically staining the lysosomal copper. It has got low sensitivity. There are issues with this particular as well, because there is heterogeneous distribution of copper within the liver, so you may miss the area which has got a lot of copper. Then you need a good enough sample for that, and then even liver biopsy can be normal in patients with copper disease, depending on the way we have done this test. Then genetic testing is another thing which is not widely available in our country and is difficult, and obviously the cost is associated with it. And here the problem is that there are more than 500 mutations, more than 800 mutations which are associated. The one, the H1069Q, that's the most common, but there are so many other which can be associated. But it's a very good test for family screening. If you are able to diagnose the mutation in one person, that can be very helpful in screening his family. So we all know this very popular scoring system, and it still stands as the best modality to make a diagnosis in these patients, where the scores have been assigned to clinical manifestations, to the lab values, and as well as to the liver biopsy and the genetic test. So generally what you do is you start with clinical manifestations, and especially the neurological manifestation have got a very good score of 2, along with KF ring examination and ceruloplasmin. And if you can go to the score of 4, that's enough for the diagnosis. But if score is 0 to 1 after these 3 modalities, then you will have to do a liver biopsy as well as 24-hour urinary copper. If the score is between 2 to 3, maybe urinary copper can be the final diagnosis, which can lead us to the score of 4. So that's how you use these tests sequentially to make a diagnosis of Wilson's disease. There are few newer modalities, but obviously these are not available right now in the market, but that can be helpful, like this particular PET scan, which can detect the presence of copper in different parts of the body, or magnetic resonance spectroscopy, which can help in identifying the presence of the copper in the brain as well. Then there is a newer test of optical coherence tomography. This basically is a way to look at the KF rings, and KF ring appears as a range from yellow to orange color. And the more the copper is deposited, the more the darker will be the color, more closer to the orange. And this test can be used, as is suggested, for the follow-up of the patient as well, because as the disease improves and the content of the copper gets reduced from the descendant membrane, the color becomes more and more yellowish in nature. So that's another modality which can be helpful in these patients. What about treatment? Obviously, we have to advise patients regarding certain dietary restrictions, in that shellfish, nuts, chocolates, mushroom, and organ meat. These 4 or 5 things can always be remembered to be advised to the patient to avoid taking these. These are the drugs which are available maybe for last many decades for utility. For a new drug to come up, the important thing will be to have a better efficacy than this. And that is the one limitation. That's why we are still using the same drugs for the Wilson's disease. In this, we are most familiar with the penicillamine. It's basically a chelating agent, which is going to release the copper from the forms of proteins and will lead to increased urinary excretion. It's very good for improvement in hepatic manifestation, because but as it leads to higher levels of serum copper transiently, so it can lead to neurological deterioration as well. That's one aspect that we have to keep in mind. And its efficacy can be monitored with the urinary copper. Then trientine, that's not much available here, but it's the same function of chelation, but what it does, it binds itself to the serum copper. That's why the chances of neurological deterioration are less with trientine as compared to the penicillamine. Then zinc is basically, it reduces the absorption of the copper from the gut. That's its main function. It induces metallothionein, increases its binding to the copper, not allowing copper to be absorbed in the circulation. So it is mostly used for the maintenance therapy, because once you have chelated copper from the body, then you can use this particular drug to reduce the absorption from the gut. So generally it is started as 150 milligram per day in 3 divided doses, and it leads to reduced urinary copper as well. That's one monitoring that you do. So urinary copper is a very good test to monitor these drugs, but the values are different for initial induction phase and then for the maintenance phase. And this can guide you very well in deciding that either you are giving underdosage or you are doing overdosage, because these treatments are going to continue for a long time, and these treatments are associated with side effects as well, for which we need to keep eye on CBC, liver function test, and urine examination and renal function test as well. So in nutshell, there will be an induction phase. Either you will start only with penicillamine or with a combination therapy. And there are studies to show that the combination therapy is associated with lesser chances of neurological deterioration at the start of the treatment. And then once you are at the stage of maintenance, where the urinary copper has has declined to a certain degree, then we can continue with the maintenance drug, which will be continued for the life for these patients. What is new? There are 2 drugs. Obviously, this tetrathiomolybdate, this works both ways. It is a chelating agent as well, and it reduces absorption as well. There are trials going on gene therapy, and this ALXN 1840 was the trial for which there was a lot of enthusiasm, and they showed very good results, but last year it was abandoned just because of some safety issues. Then there is another trial which is ongoing. Basically, what they're doing is they are trying gene therapy. They use adenovirus as a vector, and they are translocating a particular stranded DNA genome to that particular location where they need to replace the mutated gene. And they have completed phase 1, and they have shown that it is at least safe to be used in humans. And presently they are enrolling people for phase 2 trial, and that is obviously will take some time to come up because it will need a long-term follow-up. We all know acute liver failure is a very critical situation with Wilson's disease. Patients present with encephalopathy, and most of the time there is not much to offer to these patients apart from the liver transplantation. And obviously chelation therapy giving at this stage will be difficult if there is already encephalopathy. There are scores which can predict the outcome of patients with Wilson's, which are based on, this is the one which is most popular, bilirubin, INR, AST, white cell count. And it is believed that if somebody with acute liver failure or acute presentation of Wilson's disease has a score of more than 11, it's better to refer that patient for transplantation. Few words about family screening. Obviously, an autosomal recessive disease, lifelong disease. If you find one patient of Wilson's disease, it's imperative that you screen all the family members. It will be very helpful if you find the mutation in the index case, because then you can check for the same mutation. But if you don't find it, then obviously there is a way to go around that. But if this genetic testing is not available, then at least complete blood count, liver function test, 24-hour unicopper, and ceruloplasmin. These are the tests to be done in every family member of a patient with Wilson's disease. So, ladies and gentlemen, in a nutshell, it's a complex heterozygous autosomal recessive disorder which has multi-system manifestations. Diagnosis needs systematic use of both clinical and laboratory parameters, as we have seen. Treatment is lifelong, and the focus is presently on removal of copper from the body along with the reduced intestinal absorption. And probably gene therapy.
University Hospital, Karachi. He is also the ex-dean of Faculty of Gastroenterology at CPSP, and more than 250 publications in national and international journals. Thank you, sir.
Thank you very much for this kind introduction. Bismillahirrahmanirrahim. So, as we know, the worldwide prevalence of hepatitis delta antibodies is about 5% in HBsAg positive patients. But in Pakistan, this is very high. This is 16 to 18%. But we have some of the districts in Pakistan where the prevalence is much more high. And I will be discussing that. And this is a recent paper published last month which shows that the patients who are coming from Pakistan, they have the worst prognosis, and already most of them have developed cirrhosis in their early, in their teenagers or in their early adulthood. So we aim to determine the prevalence of delta hepatitis viremia in our patients, and this is the area where the study was carried out. And 1643 persons were screened, and you can see the hepatitis B prevalence is 16.9%, which is much high. Our national prevalence, according to the new studies, is about 2.2%. So these are the high prevalent areas, and if we found that 67% of these hepatitis B surface antigen were positive patients, they were delta hepatitis positive as well. So the antibodies were positive. And out of these who are serologically positive for delta hepatitis, 58% were having viremia. So here comes the importance of double reflex testing. Double reflex testing means that when you see a patient for hepatitis B surface antigen, ask for the delta antibody. And if the delta antibody is positive, then you ask for the HDV RNA. So coming to the treatment of delta hepatitis, we do not have any definite treatment so far. There are many studies where the pegylated interferon was given including one of our own studies, and it shows only 1/4 of the patients with delta hepatitis, they show the durable or sustained sort of a response to the pegylated interferon. What about combining pegylated interferon with adifovir, tenofovir, or entecavir, or ribavirin? So there are different studies. The famous one is HD2, where tenofovir was added to the pegylated interferon. In our own study, entecavir was added to the pegylated interferon, and there was no improvement in the response rate. About coming to lambda interferon. So this is type 3 interferon, and these receptors are present mostly in the liver. So chances of side effects become less as compared to the pegylated interferon alpha. And this is a study that appeared in Hepatology. To this study, many patients were from Pakistan. And you can see again, the response rate was not better than the pegylated interferon alpha, though the higher doses of 180 were better as compared to 120 dose of lambda interferon. So about the newer agents that are coming, we'll be discussing some of these newer agents. And our group of the Delta Hepatitis Consortium, they decided that if there is more than 2 log reduction in the HDV RNA level with normalization of the ALT, and this should be considered a reasonable secondary endpoint for the clinical trials, because most of the drugs that were in trial, they failed to show eradication of the virus. So this was taken at the surrogate marker for the treatment efficacy. So here are some of the drugs that are being tried and trials are being done. There are entry inhibitors. As we know, that is sodium taurocolate co-transporting peptide receptor, which is the virus receptor for the entry of the virus into the hepatocytes. And there are drugs like bulevirtide, which has been approved by the European Medical Agency, and another investigational drug, HS0033, and that is being tried, and we are the part of this trial as well. Then there are drugs that affect the prenylation of the hepatitis delta antigen as the virus replicates in the nucleus. These antigens are released along with the genomic RNA, and assembly of the virus takes place in the endoplasmic reticulum. But before that, there is a need of prenylation of HDV antigen, which is a large antigen. And this step may be blocked by the drug lonafornib. And then after the assembly of the virus has taken place in the endoplasmic reticulum, this virus, these particles are accepted by Golgi apparatus, where the hepatitis B surface antigen covers the virus, and then the virus is released. So here again, there are some drugs like nucleic acid polymers that are being tried to prevent this step. When the particle is released back into the blood, then you require the surface antigen, and for the surface antigen, drugs are being tried. And these include small interfering RNAs that prevent the production of the surface antigen. So briefly, we'll be discussing these drugs. About the bulevirtide, this is the drug that has been approved for delta hepatitis. Dose is for this drug is given subcutaneously daily 2 microgram. And this mimics pre-S1 protein of the hepatitis B surface antigen, and it binds to the receptors on hepatocytes and prevents the surface antigen to be recognized by the hepatocytes, so delta virus cannot enter the hepatocytes. So this is a trial that has recently appeared, in which 2 milligram of bulevirtide sub was compared with 10 milligram bulevirtide daily. And in the third arm, the treatment was deferred for 1 year, and then the treatment started with 10 milligram.